Good morning or good evening, wherever you're joining us from, for day 2 of London Live Endoscopy. We were delighted to have attendees from 75 countries around the world yesterday. We had a superb day. If you missed any aspect of upper GI endoscopy or HPB, ERCP and EUS, you can go back and review any aspect of the meeting on the Gastro Learning site. There's lots of interesting learning to be had. Don't do that this morning because this morning we have a fantastic colonoscopy symposium addressing all areas of diagnostic, interventional colonoscopy, including where these procedures fit into the overall patient pathway. We're now going to move straight over to my colleague and chair of the colonoscopy symposium, Dr. Ed Seward, for a fantastic morning ahead.
Good morning, hi. Welcome to day 2 of London Live. As George says, today is going to be all about colonoscopy. Yesterday you learned about upper GI and ERCP. We're going to be focusing initially on diagnostic aspects of colonoscopy this morning. To do that, I'm joined by a stellar international faculty, Professor Brian Saunders from St. Mark's, Professor Evelyn Decker from Amsterdam UMC, and Professor Helmut Messmann from Augsburg, Germany. So thank you very much for coming along today. We're going to start by going into our first case, which is a bowel cancer screening case, and we're going to be demonstrating water-assisted insertion. And this is going to be done with a Olympus 1500 scope and an X1 processor and a Pentax waterjet. And the learning objectives for the case is we want to be able to demonstrate what the benefits of water-assisted insertion is, the benefit of identifying the innominate grooves with respect to lumen identification, and what are the benefits to the patient in terms of comfort. So straight over to our first clinical case, please.
So we're just demonstrating water insertion here today on a bowel cancer screening patient. So my foot is on the pedal and we're putting water in all the time, and you'll notice the screen is on near focus, and that allows me to see these innominate grooves which tell me which way the lumen is coming up. You can see at the moment the grooves are across and now up and down the screen, and that tells me that the lumen is off to the right. The lumen is always at right angles to the direction of the innominate grooves. So you put your foot on the pedal, and if you ever come into a sort of air-filled space, you suck out the air and just carry on filling it with water and then proceed. And the rationale for doing water insertion is it not only makes insertion easier, and there is data on this, but it's also more comfortable to the patient because it's the distension caused by air or carbon dioxide which makes it unpleasant. So we just had a flash of the innominate grooves there, again going up and down, so the lumen's off to the left. And we're forming an alpha loop as we go into the sigmoid, which is obviously one of the commonest loops you'd expect to see. It's well tolerated at the moment, and I'm putting some just some clockwise torque there. And now as we're going into probably the descending colon now, I'm putting more clockwise torque to allow myself to get around there, and the alpha loop seems to be going to an N loop. You can hopefully see that on the scope guide. And that's definitely one of the sort of favourable loops to have, because you can normally be fairly confident you can pull the loop straight with clockwise torque. So we're going up with a N loop now. We're just beginning to round the splenic, and really that's your opportunity to try and straighten the scope if you can. You'll feel tension as a loop forms in your right hand as you're pushing the scope in, and as you straighten, that tension will go, and that's quite important to get that kind of tactile feedback from the scope. And it's quite a hard thing I always find to teach trainees, but it's really important that they understand. So we're now in the transverse colon, making good progress. I've got a little bit of a sigmoid loop there, you can see that, but it's well tolerated. If that was painful, I would pull back and straighten at this point and use my stiffener in the first instance to try and manage that. Now the loop might make me struggle a bit to get round the hepatic flexure, and if it does, we can just straighten that, no problems. Oh, just seen a small adenoma there, that's good. So we're trying to get into the hepatic there, and you can see that sigmoid loop is getting bigger, so I'm going to try and pull that straight if I can, and I can just feel the scope relax in my right hand as I'm doing that. Patients in left lateral, we've not had to move them so far. That's one big bonus of water insertion. I often stay on the left all the way in, rather having to move to supine. So that's just allowing me now with a slightly straighter scope to go up and over the hepatic. And we've got another adenoma, that's great. And we're going to try and pull. Normally I pull in. There's the IC valve there at 6 o'clock, so I'm pretty much all the way around. So I'm just pulling straight, so I'm sucking and I'm pulling back, and we're all the way around that.
Great. Okay. Thanks for that. We're just going to run a separate video as well, just concentrating on the innominate grooves. So we're just going to bring that up, just in case it wasn't clear on that live demonstration there.
Okay, so this is just to show the innominate grooves that I was talking about in the previous recording. So the blue lines are showing you the innominate grooves in the bowel wall. And remember what I said is the bowel lumen is always at right angles to the innominate grooves. So in this case, it's up and to the right. And if you were to do tip up and a little bit of clockwise torque to take yourself in a 2 o'clock direction, then that will be the way the lumen is going, and that just gives you a little bit more information when the tip of the scope is quite close to the mucosa and you can't see where the lumen is going. Hope that's clear.
Great. Okay, so thank you for those videos. Brian, I once watched you do a video of you doing a water insertion at the BSG, I remember, which was very impressive. Is it something you use for every case, or?
Yeah, I mean, the transformational moment was when the endoscopes incorporated the water wash. Before, we kind of knew that using a syringe could help in certain difficult situations. But the minute you have the water pump allowing you to infuse continuously, it becomes practical and realistic to use. So we've just completed quite a large randomized study looking at water all the way to the cecum, or water to the splenic flexure, and then a combination of water and CO2. And we found it was much more efficient to do the hybrid approach. So I don't turn the CO2 button off. I insert mainly through the sigmoid using water, and then at the splenic flexure, a combination of the two.
Yeah.
Otherwise, you're spending a lot of time filling up the bowel with water. You've then got to aspirate all of that water when you're doing the withdrawal, and it makes the procedure less efficient, which we don't want. So I think a hybrid approach is the way forward.
Yeah. Although I suppose that is the question, is whether you actually do aspirate or whether you try and do the whole water exchange colonoscopy and try and get the benefits of water on the way back as well.
You get additional cleaning, but it takes more time.
Yes.
And in terms of the overall time of the procedure, it was much more efficient to use a hybrid approach, we found. In your insertion, was there an alpha loop there? I'm not sure. It looked like an N loop all the way.
I think it was going alpha, and then it's with the clockwise.
But of course, they are basically the same thing.
Exactly.
It's just that an alpha loop is more exaggerated and turned.
Yeah.
But do you think you get, Evelyn, do you think you get more or less looping when you use water?
to be honest, I don't use it routinely. I switch to it when I am having difficulty. So for me it's not, but maybe I should start doing it and see. I mean, I'm quite impressed by the video. I haven't been at BSG seeing you do it before, but I quite like it when I'm having difficulty. So I'm not the one that you should
I'm
consult
guessing
for
the
routine.
Dutch don't like the idea of being underwater, I suppose.
That's a very, that's very well, yeah.
Helmut, what about in Germany? What's the practice there?
I use it routinely in every case, even in maybe easy cases, but not my whole team, interestingly. I couldn't convince them that I see the advantages, and I do the hybrid approach as well. My staff actually is my nurses, because we use the syringe. We do use warm water. So this is for, I'm not sure whether there is a trial on the temperature of the water, but if you use warm water, I had the feeling the gut is more relaxed. If you use cold water, ice cold water, it gets maybe a spasm and you have a more or less benefit. So maybe temperature plays a role, I don't know.
I've heard anecdotal reports of if you leave the water, if the water is cold and you infuse a lot of water, the patient can become hypothermic.
Yeah.
It's a possibility, which is about the only complication from the technique.
And when it came out, yes, there were anxieties, weren't there, about also loading a patient with several litres of water if they've got congestive heart failure or whatever, but that doesn't seem to have panned out. Excess mucus production I've heard with cold water as well. I must say that we aren't as kind as you are in Augsburg. We just put tap water in, so we don't warm it specifically ourselves. And I must say I don't have an issue with water temperature. But the important thing is the foot goes on the pedal, is what I teach my juniors, and then it doesn't come off until I get to the splenic. And then exactly as you describe, you can either go in with water or CO2. For then, it doesn't.
One top tip for the trainees who are listening is get used to using the water pedal on your non-dominant foot, because when it comes to then doing therapy or more complicated work, I'm right-footed, so I put the water pedal on my left foot. I've then got my right foot free for the diathermy, and if you get used to that, later on when you're doing therapy, it becomes much easier to then combine the two.
That's an excellent tip.
So are you also not turning the patient as rigorously as I was taught in your unit?
We still turn the patient a lot, but probably a little less now that we use water for the sigmoid.
Hold those thoughts, because we're going to go on to the next case now. So this is a case demonstrating case loop resolution, and this is a female patient, again referred through the bowel cancer screening program with a positive FIT. She has a past medical history of a hysterectomy, and she's had a previous failed colonoscopy. And there's a second patient, I apologise, who has had a previous hysterectomy and has had a previous failed colonoscopy. So we're going to be looking at two patients today. In terms of equipment, we're using the Olympus 290 scope, but along with the X1 processor and the scope guide navigation system. And the learning outcomes, we want delegates to understand the reasons for loop formation, how to interpret the navigation system, and tricks and tips to resolve the most common loops during colonoscopy. Okay, so over to the VT, please.
Let's talk about colon loops. They are due to the ligaments that hold the colon into the abdomen. One of the most frequent loops that we face on intubation is the alpha loop, and that's due to a long mesosigmoid ligament that attaches the sigmoid into the abdominal wall. The maneuver to resolve it is by supine position, clockwise torque, up to 360 degrees, and then pull back. So here I am intubating this patient. The bowel preparation is not great, so I'm not going to use water immersion because it would be quite impossible. We'll feel a little bit of pushing. That's it, and patient tolerates it pretty well. And we can observe in the colon, in the imaging, that the alpha loop is starting to form. That's it. A little bit of suction. And we keep advancing rather than being determined to resolve it. Otherwise, the only thing we will do is just keep pushing the sigmoid and causing discomfort. So the best advice is to keep advancing until we reach the descending colon. And usually is very well tolerated by the patient. So it's a matter of finding the lumen and advancing clockwise torque, with clockwise torque. So now we are approaching the distal descending colon. Little bit of carbon dioxide insufflation. And I'll try to see if I can resolve it here, but it's too soon. So you can see I pull back from the descending colon. So I'm just going to go a little bit more proximal and reach nearly the splenic flexure. As the patient is well tolerating the procedure, we will continue. That's it, we are nearly there. Now I'm gonna try again, pulling back and clockwise torque and nearly 360 degrees. So I have a loop now at the shaft of my scope that I will translate to the umbilicus. So that will allow me to torque and steer freely towards the splenic flexure. And there we go. A perfectly straight scope with the patient on supine position, ready to intubate. Another very common loop is the N loop. This is because of a short mesosigmoid ligament that holds the sigmoid into the anterior abdominal wall. We have a patient that had a hysterectomy and difficult intubation of the sigmoid colon, and the bowel preparation again is not great. And as we are trying to find the lumen to where to proceed, we can see the end loop starting to form into the scope guide. So very slowly I'm pulling back with clockwise torque, and the lumen appears at 2 o'clock. So very slowly with a clockwise torque, with direct lumen intubation. If I push through, patient will have discomfort, and we will exacerbate the loop. So as you can see, the amount of torque that I'm doing by the images of the scope. And as I am pulling back, I can see the lumen starting to appear, and direct view intubation.
Right, so we've just seen two very skillful demonstrations of loop resolution by Rosa Vega there. And I think you'll probably agree with me, one of the most satisfying things to see in endoscopy is that loop being resolved very nicely on the magnetic imager. And that's something that often divides international opinion. The great thing is we've got 75 delegates from 75 countries joining us today. We've also got an international panel. So I'm going to go to the panel and ask them what they feel about magnetic endoscopic imaging. Do you use it in practice? What's the evidence for it? Do you use it selectively just for training, for difficult cases, or it's really not necessary? I'll start with Brian, because Brian, I know you've done a lot of the foundational research on this. Why don't you tell us?
Yeah, I mean, obviously, I'm a big fan of magnetic imaging. It just seems logical that you can see where you are in the abdomen, see what's happening to the shaft of the instrument. I use it routinely in all cases. It's particularly useful in patients with long and mobile colons. as much as anything, it's to show you why a colonoscopy is difficult. About 5% of colonoscopies are technically difficult. And if you get one of those, you need all the help you can get. And being able to visualize the shaft is really useful in terms of loop withdrawal, and knowing where you are anatomically, where the tip of the scope is. Timing the loop withdrawal is crucial. So for instance, on the alpha loop that you showed, if you try to withdraw that and straighten that loop too early, it'll just flip back into the sigmoid. So you need to know accurately where you are, and it's difficult to know that because the colon is a long tube, there are no signposts, just some rough markers. I'll stop there.
Yeah, that's great. That's really, really useful advice. Well, how about in the Netherlands, Evelyn? Do you use this routinely?
Not routinely. We have it set up in our endoscopy service where we do the more routine endoscopies as well as the population screening. Regrettably, we don't have it set up in all the rooms in our academic center. That has to do also with different scopes and different systems. But I definitely think there's a big use, like Brian has explained. And apart from myself, because I really like to see what's happening and how to reduce the burden for the patient by doing so, I think it's great for teaching as well, because I think just the fellows to see what's happening when you scope is just so informative, and to like Brian says with the loops, what happens when you have such a loop. Okay, so next time you go further and then see what happens, and you won't know that just by the inside of the colon. So I really like it.
Yeah, I think that training point's really, really important. I think initially to see things under direct vision, and then perhaps later on not needing to use the imager, but certainly it might shorten that learning curve for trainees during colonoscopy. And Helmut, what about the German perspective? What do you think?
The German perspective, I agree. It's attractive. It's logic to use it, but in Germany it's not so popular. I would say it differs from hospital to hospital, and we have it in our unit, but just in one room. So sometimes you would use it just in the other room, no? Whereas a difficult colonoscopy, and then you're wondering, shall I switch the patient or move the system? So actually, yeah, for teaching, for the beginners, I would say, to understand how a loop appears and how it can be resolved, it is for sure a help.
So let's go back to first principles. We saw a couple of those cases there. In one of the cases, the patient had a hysterectomy. There's a lot of talk about efficiency now in colonoscopy, isn't there? We've got a huge demand to get through a large volume of cases effectively and efficiently. Can you preemptively identify some of the patients that are going to have a difficult insertion? Are there preemptive steps you can take for those patients? What's your practice, Brian?
Yes, so you can preempt it to some extent. I think you mentioned that patient had had a failed procedure previously. Yes. Often the reason for failure is discomfort and an uncomfortable procedure. So the first thing you're going to do is make sure that you put that patient on a propofol list where they can be adequately sedated. Because that will give you the time to be able to do the procedure rather than having an uncomfortable patient who's not adequately sedated. The second thing is it's likely that you'll need a smaller diameter instrument which has a more flexible shaft, so I'd use a pediatric instrument. We'd use water insertion technique with the scope guide. I would have a gastroscope in reserve in case it's very fixed and angulated. Now I know that's controversial. Are you allowed to use a gastroscope in the colon?
I do a lot, because I do it a lot also for my pouch patients and my sigmoidoscopies.
We've had some issues.
Therapeutic and lower endoscopies.
We've had issues in the UK where if a gastroscope is used for a non-upper GI reason, if you break the scope, it's not insured.
Oh, really? Oh, I thought about the infection risks and stuff.
Well, if you clean your scopes,
yeah, that's what we say. Actually, we often use the same one for upper and lower for the hereditary.
Yeah. But it's a good point, Brian, what you touch, because usually I had several discussions with endoscopy companies. Why do they call it colonoscope and gastroscope? Why are not we talking about endoscopes with different sizes, different lengths, so you can use it everywhere? So a gastroscope is just approved for upper GI, a colonoscope just approved for lower. So you had to inform your patient, you get to inform the same. Well, in your case, we will use endoscope, which is not approved. Are you happy with this? This is official, the legal correct statement we have to tell our patients. And nobody does it. So if you have a problem, you could have trouble. If I would be a lawyer and I was in charge, and that there was a perforation with a colonoscope during an ERCP and altered anatomy. Then I think this is an issue.
It could be an issue.
We should
Could be an issue.
clearly ask the
But
companies.
No, I think especially now that, for example, Olympus has developed the TL colonoscope, which is really thin, really mobile with a more flexible tip. It's fantastic also when you want to perform upper endoscopy to try to get deeper. So I think indeed we are swapping more and more the scopes per indication. So I think it's
it comes back to the origin of the problem in the colon is because the colonic anatomy is so variable. The length of the colon, the attachments, the adhesions post-surgery, the congenital adhesions. One size does not fit all, and you need to be flexible in your approach. And if you start the procedure and you're clearly using an adult scope and you're not winning, you must be flexible and be prepared to change quickly. Otherwise, there's more of a risk.
Yeah.
Fantastic. Right, so we're just going to move on now to a lecture. We're going to talk about polyp classification. There's so many systems out there. It's very easy to get confused, and I'm sure Ed Seward is going to give us a masterclass on this. Over to you, Ed.
Omar. So we're going to talk a lot about classifying polyps in the next few hours. So I thought it'd be helpful just to remind everyone the various classification systems. And I think hopefully most of our delegates will have heard of Kudo and Paris. And I'm also going to introduce the relatively new kid on the block, JNet, in terms of how to classify polyps. So Kudo is all about pit pattern, and these are the structures which are like the pores on the skin of the bowel. Type 1 are normal pits, type 2 are hyperplastic or sessile serrated lesions, and then you have different pit types for adenoma types, 3S which are spots, 3L which are lines, or type 4, and then type 5, this is the most important thing for endoscopists to be able to recognise, because you're either talking about high-grade dysplasia or cancer. With respect to Paris, so we're describing the morphology, the structure of the polyp. I think most endoscopists will be comfortable as to whether a lesion is pedunculated or sessile, but it's also important to be aware of the 2A, the 2B and the 2C changes. So these are sessile polyps but are only minimally elevated, so 2A is a minimal elevation as compared to a 1S polyp. 2B it's completely flat. And most importantly, when we're talking about endoscopic recognition of high-grade lesions or cancer, is this depression. So 2C is the one to remember when you're trying to work out if a polyp is a worrying polyp or not. And then finally, JNet. Superficially, this probably seems a bit complicated. It's actually based on the NICE classification of polyps, which is just 3 types, type 1, type 2, or type 3. These are lesions which are being examined under narrowband imaging, MBI. So type 1, they're pale as compared to the surrounding mucosa, and that's hyperplastic or sessile serrated polyps. Type 2 is your conventional adenoma, and what JNet does is it divides it into 2A and 2B. 2A being your common or garden adenoma. 2B is where there is change with a variation in the pits, and that raises the possibility of either high-grade dysplasia or minimally invasive submucosal cancer. So that's potentially, if you're saying a lesion is 2B, you're saying it is potentially endoscopically resectable. Type 3 is established cancer. These people need surgery. So again, it's very important if you're using JNet, particularly the sort of 2A, 2B, or type 3 decision. That's what JNet helps you make. But we are going to talk through some examples. And here we go. So we'll just run this video. Helpfully, we're doing this with a GI Genius system, so you can see where the polyp is. And The important thing is you're using all your endoscopic tools. So you're on near focus, you're on MBI, and this is a lesion which is very pale under MBI. So we're talking about, this is a JNET 1, these are Kudo type 2 pits, and in terms of morphology, it's only minimally elevated. It's a 2A lesion, and this would be a very typical hyperplastic polyp, and we're looking at it in focus there. So this is a second lesion. So again, it's highlighted by GI Genius. We're going to go on to near focus just to demonstrate, and we're going to just look at this in white light, and hopefully under white light you can appreciate that there's a variation in pits there. You can see some spots which would suggest 3S, you can see some lines which would suggest 3L, but overall this is an adenoma, so it's a JNET 2A. And I can demonstrate those. So there's the lines, so those are your 3L changes, and then you've got your 3S spots. So all straightforward, and in terms of morphology, this is probably just about a 1S lesion, a sessile polyp. Now we're looking at a large pedunculated polyp. I don't think anyone would have any doubt calling this. So this is a 1P lesion, and you've got this kind of leaf-like appearance of the pits. So these are the type 4 changes. So this is an adenoma, but nothing worrying beyond that. So eminently endoscopically resectable so long as you are happy tackling that big stalk. But this is a slightly more worrying lesion we have here. So we're just in the sigmoid here. And you can see there appears to be sort of two parts to this polyp, really. We're going to rotate it round to 6 o'clock. So there's a top part there, which looks like a conventional adenoma, but then there's a bottom sort of ulcerated part. So we can see some type 4 pits. They're the slightly swirly, gyriform pits. We can see some 3L pits. You can see those lines. So very common that in the same lesion you'll have different pit types. But here at the bottom where the ulceration is, there's a complete absence of pits. So this is type 5 change, or JNET 3 is how I would classify this polyp. So this is a very worrying polyp, and this is particularly for the size of the polyp, only a tiny thing. This had established cancer within it. So very important that you recognise that as an endoscopist. So I'm just going to summarise those slides. So the things you need to remember are the type 5 pits, the 2C change, the depression there, and then if you can recognise JNET 2B as a high-grade change, which is potentially endoscopically resectable, that's great. Always use your tools on your scopes, so using near focus or MBI or alternatives if you're using Pentax or Fujin on scopes. And try and commit to a diagnosis on every case. This is how you learn how to describe polyps, and then you look up the histology, and that's going to give you more confidence going forward. Thank you very much.
Thank you, Ed. We're going to put those into practice very soon. We'll be working through cases throughout the morning, so thank you very much for that lecture. We will be going across shortly to Brian Saunders and his lecture, but just in the interim, we're going to have a brief discussion. We had a look at some of the classification systems then. Evelyn, I know you spent a lot of your career working on optical diagnosis. Let's just talk about the general endoscopist, day-to-day diagnostic endoscopy. We've got, nice classification, Kudo, JNET. What would you expect the standard to be of a day-to-day diagnostic colonoscopy? Should they be reporting all these classification systems for every polyp, or should we be using it for selected cases?
It's interesting. I think for sure we need always for every polyp like a systematic assessment, and that has to do with things that I've already mentioned. So it's of course location, size, and then morphology, and then your optical diagnosis. And of course the optical diagnosis is the one you want to discuss now. And I think it's questionable whether you always want to assess by which you've done your optical diagnosis. So that's good for trainees to learn how to use the classification systems. But in the end, I think it's just too much of a hassle and administrative part to always use all those classifications. I would definitely use them in case of a suspicious lesion, but I would not use them routinely. So I would say my optical diagnosis is an adenoma. And we teach our fellows to say CUDO generally, because I think it's a bit more precise than NICE. But of course, at any moment that you think there might be an invasive part in the lesion, that should be described by JNet for sure for me. So that's where you have to get on to the next step.
Exactly. So that brings us on nicely. Helmut, I know you do a lot of resection work, a lot of advanced ESD, etc. So you presumably get a lot of referrals to your centre where the polyp has been assessed elsewhere. Any tips you can give to people who are referring on complex polyps to you? How well is that assessment done? We will cover it a bit later in the day, but what sort of things for you make you think, I really need to know this information? Is it JNet on a specific area? Is it Paris classification? What is it?
I agree with Evelyn. I think a lot of information are necessary. The size. So I'm sure the size is really not always very precise. We have now new tools which help us, but sometimes you are referred a polyp 3 centimeters, and then you see, oh wow, this is 6 centimeters, or vice versa. So even in live endoscopies, when we invite our Japanese friends, well, we have a 3 centimeter polyp, and then overnight the polyp growed, obviously. Though first thing, sizes does matter, but it's sometimes not so easy, obviously, also for routine endoscopists to make a precise, then the location for sure, even if there, the people describe a polyp in the transverse, and you look in the transverse, you can't find, because it was a loop and the polyp was somewhere different. So this magnetic imaging or this could be helpful. Then in our endoscopic report, we are forced to use the JNet classification and the Paris classification. Each polyp, it's time consuming, I tell you, if you have a lot of polyps, so you struggle then, but this is an automatic report, and for every polyp it's described. It's not common in Germany, honestly, so many people don't use it. Yeah.
Well, hopefully by the end of today we'll have solved that problem. So we're going to go over to Brian Saunders' lecture. Brian Saunders, again, someone who's dedicated a lot of his career to optical diagnosis, especially for diminutive polyps. Brian, are we any closer to seeing optical diagnosis being implemented into routine practice? Do let us know, please.
Well, Omar, I certainly hope so. I'm going to be talking about optical diagnosis for diminutive polyps. Endoscopists tend to like talking about their very big polyps, but I'm going to be talking about the diminutive polyps. These are my disclosures. On the face of it, small polyps, are they that important? Well, this is some data from Doug Rex's group in Indiana, looking at nearly 33,000 consecutive colonoscopies, where over 23,000 adenomas and over 14,000 serrated lesions were removed. And the invasive cancer rate, as you can see, is 0%. So it's very unlikely to have really advanced pathology in very small lesions. Villus or high-grade dysplasia is slightly higher in the 6 to 9 millimeter group, but again very low in the diminutive less than 5 millimeter polyps. But small polyps are important, and the reason they're important is that if they, in a cumulative way, they predict risk of advanced neoplasia. This is a study from a little while ago, now looking at a pooled analysis of 8 prospective studies in over 9,000 individuals who'd had polyps removed. And looking at their follow-up and who developed advanced neoplasia. And as you can see, the highest risk for developing advanced neoplasia is in patients with multiple adenomas, much higher than just having an adenoma with a villus component or an adenoma with high-grade dysplasia, or even a large single adenoma. So we're going to hear about the Nordic trial later on, but this data actually predates that, in that it's the first data that really looks at long-term risk of developing cancer related to an individual colonoscopist's ADR. It's from the flexible sigmoidoscopy trial, a very large trial where over 40,000 patients were screened. And there were 13 different centres, and they were, when we look back, the individual endoscopists in those centres could be divided into high detectors, intermediate detectors or low detectors with those ADRs for flexible sigmoidoscopy. 17 years later, when you look at the cumulative cancer risk, there's a clear separation in those curves between the low detectors and the high detectors. So the higher quality of examination, the more small lesions that are detected, the better the cancer protection. Put another way, high detectors needed to do 78 flexible sigmoidoscopies to prevent one colorectal cancer, low detectors nearly twice as many, and number needed to screen to prevent one colorectal cancer death, high detectors 226 flexible sigmoidoscopies, many more in the low detectors. So picking up these small polyps is important. How do we do it? There are multiple different things around examination, good examination technique, taking enough time, good bowel preparation. But the biggest win for your buck, it comes from the endocuff. There's really good data now on the endocuff. This is the adenoma study, which showed a 10% increase in ADR, particularly in bowel cancer screening patients, with minimal downsides to using the cuff. Opening the folds, really seeing the whole of that mucosa. So can we characterize these lesions now? Of course we can. We've got advanced imaging technologies, blue light imaging. This is narrowband imaging. Nowadays with the modern endoscopes we have LEDs, and looking at the blue and the green end of the spectrum, this superficially penetrates the mucosa, picks out the vessels in particular. You can see a beautiful picture here of an adenoma with this meshed capillary network surrounding the crypts. And this raises the possibility that particularly for small adenomas and for small lesions in general, which we know have a very low instance of advanced neoplasia, should we not just be simply detecting, inspecting, characterizing, resecting and then discarding? So here's again an example, typical adenoma at the top. Note the valley sign, and that's an important additional factor, first described by Doug Rex. It's present in a lot of small flat 2A adenomas compared to the obvious serrated lesion with lack of vessels, star-shaped crypts, and this sort of slightly cloud-like appearance. So we have just completed a Discard 3 study, which is a large prospective feasibility study of using optical diagnosis for small polyps in a screening setting. Previous studies have looked at general colonoscopy practice, but we decided to look in the English bowel cancer screening group, where we have very highly skilled, highly qualified colonoscopists. And the study design was that 8 colonoscopists would enter this. It was prospective, real time. Optical diagnosis was performed. For each polyp, we had a white light and an MBI view. When we sent all polyps for histopathology, and there was a root cause analysis if there was any discrepancy between the optical diagnosis and the histology. And there was an ongoing quality assurance process throughout that. This is a very brief summary of the results, but 525 patients with over 1,500 polyps. The high confidence interval rate was 75%, which is a good a marker. If it's too low, it becomes discard becomes not cost effective. Around about 75%, it will save the British Bowel Cancer Screening Programme about £6.5 million per year. Accuracy levels were good, around 90%, and importantly, in this group there were no polyp cancers. So this is the bottom line. Can your optical diagnosis compete with histology in terms of surveillance interval concordance? When we look at the diminutive polyps, those those less than 5 millimeters, 5 millimeters or less, we have. Can you go to the next slide? Yeah, less than 5 millimeters or less, according to British Society of Gastroenterology, ESGE and US guidelines, we have this over 90% threshold of accuracy in terms of correctly allocating the next surveillance interval. When we look at all polyps less than 10 millimeters, the optical diagnosis strategy works well for BSG and ESG guidelines, slightly less well for US guidelines where there's more emphasis on high-grade dysplasia and villus histology. So it does indeed work. And this can be implemented relatively easily within the bowel cancer screening program. We got the next slide. Just to take you through this, this is how we would go about doing it. The polyp is identified, NICE criteria are applied. If there's complete agreement with the NICE criteria, you can go for high confidence diagnosis of either adenoma or serrated, or you go for low confidence. If there is partial agreement, then you can then look at additional factors such as the Valley sign, which might push you towards adenoma. Is there a fibrin cap? That pushes you towards an inflammatory polyp. And there's a separate group of polyps which we've labelled as pseudoadenomas, which at first sight look like adenomas, but they haven't got the vessels surrounding the crypts. So these are actually serrated lesions. And remember, inverted diverticular, the aurora ring sign is useful. And of course, they can be manually pushed back in to show that they're an inverted diverticulum. So in conclusion, I think optical diagnosis is now feasible and safe. Small and diminutive polyps are important, and I would now push very hard for an optical diagnosis strategy being introduced into the bowel cancer screening program, where we know that we have the quality assurance processes in place and the quality colonoscopists to do this well. It will free up about 1/3 of all histopathology time and could potentially solve the histopathology crisis that we have in the UK at the moment through lack of trained histopathologists. Thank you.
Thank you very much, Brian, for an excellent talk. We've just done a bit of swapping in the room now, so that gives me an opportunity to pick on you first now, Helmut. So Brian finished with quite a bold statement there that discard should now be adopted, and we should all just be having confidence in our endoscopic ability to diagnose. Do you think we're there in terms of training?
We are there, definitely in the centers where the studies have been performed. They could show they are able to resect and discard. In general, in Germany, I'm a bit worried whether we can start right now. I think there needs a little bit more of training and feedback, so that is also from the legal aspect possible. No? I mean, this is maybe the main issue. If you know the histology and the patient has a couple of years later a cancer, who is responsible for this treatment strategy? Yeah.
I think that's absolutely right. Evelyn, what about yourself?
Yes, so this has been a debate in my country because we've done studies, as you know, also looking at the accuracy of endoscopists. But again, it's usually a study situation. So I think the question is a lot, how well were they trained and what kind of endoscopists they are. And then the question is, what do we think is good enough? So there's the PV criteria, which look at indeed at surveillance intervals, but also at negative predictive value, which is a relatively difficult thing to assess, because usually we don't take out the hyperplastic polyps in the distal colon anyway. So there's not much for NPV anyway. So that's why we try to create new criteria, the SODA criteria. But it's so even if we know what we think is good enough, we still have the issues like how can we know for sure that this endoscopist is good enough. We did a training study and we saw that some of them indeed became good enough and stayed good enough based on PV at that time. There's also some endoscopists that just don't learn it well enough. So will we have to assess them before and accredit them? And then the question is, after that, should we also sometimes assess them again to redo it? And I think this is why the practicalities have taken us still far from implementing, regrettably. And that's why I hope if we have AI systems that more systematically provide us with a certain accuracy, and we know we are being helped with that, maybe it will be much easier to implement, because there won't be an inter-observer variability there, I hope. I mean, we're not there yet, but that might be easier to implement than using endoscopies with variable quality.
Yep. Brian, what do you think? I mean, because I think in the UK we're also fortunate in that we have a wealth of sort of quality assurance and KPI data because of the way endoscopy is set up in the UK. Does that give you reassurance that we can monitor the quality of the endoscopy?
Yes, I think there's a big difference between saying you can introduce this within the British Bowel Cancer Screening Programme and say you can introduce it across the board. It only works in a very controlled environment where you have the infrastructure and the quality assurance support. In our paper, which will be published in GI Endoscopy shortly, we come up with the concept of the optical diagnosis champion. So you need somebody with protected time who will go around, who will monitor the optical diagnosis performance, feedback to individuals, ensure with checkpoints at certain points in the process that the individual endoscopists are performing at a high level. But in that context, I think it can be implemented very, very safely, and the time and the resource saving is so vast that I think the question about missed cancer is not really an issue.
No, sure.
Already, we're going to hear about PCCRCs, aren't we, later? It happens already. Things go wrong, and any part of our practice, we can make mistakes. That's why patients sign a consent form. But it's just such a radical change in the way we've always done things that conceptually people find it very difficult to come to terms with, and yet we've been doing this already for small rectosigmoid hyperplastic polyps. We leave them alone, we ignore them. So it's already happening.
I think that's true. I mean, is it the situation in general, Helmut, with quality assurance in your sort of bowel cancer screening programs? How, I mean, it's very rigid here. You know, every 3 months we get told our cecal intubation rates and our adenoma detection rates. Is it similar in Germany?
It's almost similar.
Really?
Yeah.
Okay.
So the quality parameters, as I said, is the adenoma detection rate, the cecal intubation rate. Maybe in the future we have also the chance to have the optical diagnostic accuracy rate of the endoscopist, and the aim should be that AI brings every endoscopist on the same level. That we are talking about, would say, a special high quality level for ADR and for optical diagnosis. And this way, I think then we can for sure avoid a lot of unnecessary resections, biopsies. This is also an issue for green endoscopy. How can we save resources, avoiding unnecessary procedures?
Yes, I can't remember the statistic, but it's you save something like traveling 2 miles in a car if you save one histology pot. So it's they all stack up. And Evelyn, does every polyp count? I mean, I remember when I started in bowel cancer screening, and people were quite flippant about 1 and 2 millimeter polyps. But do you set out there? Do you put a device on the end of your scope? Do you really go the whole 9 yards to find every tiny polyp?
Well, that's a very good question that I think we don't know the answer for. For sure, ADR in itself we know is a quality parameter, but of course that comes with it that people might think, well, I found my adenoma, I don't have to look very well. We know there's other parameters like number of adenomas per colonoscopy, and so not just one and done phenomena. And there's other parameters that seem to also reflect quality. Brian has already showed us data on the number of polyps and the chance of patients having a post-colonoscopy cancer anyways. So we don't know the answer. The tricky thing is, besides that most surveillance guidelines now state over 4 or 5 adenomas means you have to go back in sooner again, which makes it again a bit more questionable, because if you do such a good colonoscopy that you detect so many adenomas, you might not need a sooner one. So I don't know the answer. I think we still teach our fellows and everyone to look very well and take away every tiny polyp. It might not be.
It's interesting, because the equipment reps tell me that there are endoscopists who say, I find enough adenomas already, I'm busy enough, my lists are crammed enough, I don't have time to find any more adenomas, which really surprises me as a attitude.
Me too. I think that's not why you do a colonoscopy, right? You hope to be finished in one colonoscopy, you've taken out every relevant polyp, and then hopefully the patient can stay away for a very long time.
Yeah.
And that's, again, we only need to do colonoscopies in those patients who need it, but once we are in, we should do the best job we can. And then hopefully protect our patients for the future. And so I'm a big fan of postponing or maybe even stopping surveillance, especially now that we have in most countries, we have screening programs by less invasive methods, and we hope to pick up new lesions in time before they suffer too much from colorectal cancer and die.
Yeah.
So there's so much going on there that I'm really looking for the future to ways to prevent all those unnecessary colonoscopies. But once we go in, we look really well and take out everything that could be relevant in the future.
Yeah, yeah. And Brian, do you think that because we're so good at finding adenomas now with distal attachment devices and with AI and all the rest of it, do you think surveillance intervals might even lengthen out because we're just so good at finding every lesion now, potentially?
Yeah, I think that's a potential, and so a normal colonoscopy probably you can extend the interval even further. I think in terms of what you do about the small lesions and how interested you are in finding them depends on the context of the colonoscopy. If it's in a screening population where you really it's a long-term strategy where you're looking to prevent cancer, I think you really do want to find all the pathology that's there. If it's a diagnostic colonoscopy in an 85-year-old, it's a completely different situation, because the small polyps are probably not relevant in that context. So, but in that specific screening group, I think we want to be as accurate and as good as possible, particularly with the index colonoscopy, because it sets the journey and sets the parameters for how that patient is going to be treated and how much intervention they're going to require to prevent cancer.
Yeah,
I agree about the age and about the context, but I think in most patients we still should do the best job ever, right? Of course, for an 85-year-old patient, there's no need to take out a 2 millimeter polyp. But anyone else, either also for diagnostic reasons or for whatever reason, or maybe at age 40, which I hope we don't do too many colonoscopies, but I think at that time we should do our best.
Yeah. Absolutely.
And detect and remove every lesion.
Yeah. I'm glad you said detect and remove, because we're going to move on to, we're going to segue on to our next case now. So this, we've actually got two patients we're looking at today. The first is a 66-year-old male, another bowel cancer screening participant who's on rivaroxaban for AF as their comorbidity. And then the second patient we're going to see is a 72-year-old female who, again, is in the bowel cancer screening program. And we're going to try and look at various different ways you can approach small polyp removal. In terms of equipment, we're using a 1500 colonoscope from Olympus with a Boston Captivator cold snare for the first polyp and the Olympus Snare Master hot snare for the second polyp. And then the third polyp we're going to see, we're going to be using the Diagmed coin tip snare, as well as the Boston injection needles. And the learning outcomes for this VT, we need to recognise the importance of polyp characterisation prior to resection, understand the importance of manipulation of the snare on the polyp, describe how to inject with dynamic lift, and really to appreciate the importance of good communication with your nursing colleagues whilst you're resecting the polyp. So we'll go over to the VT. Now, you know, the decision-making process is really interesting, you know, and people will do different things. I tend to lift less than some of my colleagues do, so we're just going to go straight for a cold snare here. In terms of characterization, always good to use your tools that you're given. So this is so we switch to MBI, we use near focus, you get these beautiful images of the polyp, and you can see it's pedunculated, it looks like a small mushroom short stalk there. Again, that wouldn't put me off using cold snare 'cause it's a very small stalk. Inevitably you'll get some bleeding, but that's nothing to worry about. Very important to be clear where the adenoma stops and the stalk starts, because you want to make sure that you get the whole of the adenoma out, and preferably give the pathologist, open please, a cuff of normal tissue. So when you're placing the snare, you use the tip of the snare to pivot. So it goes into the mucosa and that allows you to pivot down. Close up there please. Oh, just fully open there. So you see the snare slip slightly. So I want to just make sure I come a little bit more over to the right. Close again, nice and slowly. Close, 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 close. There we go. And then we've got a nice 2 or 3 millimeter section there of stalk. Cut there please. That's perfect. As I say, we're expecting some bleeding. That's fine.
So I've just spotted a polyp on the other side of the ileocecal valve, so I'm going to rotate things around 6 o'clock because that's always the easiest way of tackling things. Next step is to evaluate the polyp with MDI, it's like a JNET 2A lesion, so an adenoma that we can remove. So I'm going to lift this lesion. You start ejecting just before the needle goes in, and that allows you to find the plane. And we're using dynamic lift, so we're pulling the lesion into the lumen, and that makes it more accessible. So when the lift is completed, the lesion is relatively easy to get at. So we've got a Diagmed coin tip snare here, and you can see I'm trying to flop the snare over, and the snare wants to go off to the left. So you just have to exploit that and move it to the other side of the polyp. And then it comes over really nicely. And now what I'm trying to do is just indent the snare over the polyp and do that with some clockwise torque and cut through. That's really nice. And if we just see if we can suck that polyp up there, you can see the defect forms perfectly the shape of the snare, which shows you just how well these cold snares cut through tissue. That's good.
Good. That's perfect. Now, because there are multiple polyps here, I am actually going to be slightly controversial, and I'm going to cut up the polyp now that it's off. I'm very happy with that polyp. I'm not concerned that there's any malignancy there. So I think this is a low-risk polyp, but I'm going to top it up so that so I can carry on the second polyp. So if you just open there, please, Phil. Now, chopping up a polyp once you've removed it can be tricky. Close up please. Cut. It's a little bit like grabbing a bar of soap. Open please, in a bathtub. Close up please. Cut. And I know, open please. Close please. Cut. Any pathologist in the room will be freaking out at this point. Open please. But it's just a way of practically making it easier. Close up please. Cut. Perfect. Okay, thank you very much. And then I'm going to suck those bits up. So that was what I did last Wednesday morning. Helmut, we've got potentially 2,000 people listening to us about sort of tips and tricks for small polyps. Do you have any that you would like to share in terms of your approach?
Well, we have our ESG guidelines, and I think for polyps smaller than 10 millimeter, the code snare is meanwhile the gold standard, I would say. For larger polyps, in Germany there is an ongoing trial comparing piecemeal EMR with code snaring. We will see whether there is an advantage regarding bleeding rate, and on the opposite, the recurrence rate, which might be, from my personal perspective, a bit higher if you have a code snare because you have more pieces, but this is just speculation. But for small polyps, I would say in our country and also recommended in the guidelines, code snaring should be the gold standard. Meanwhile, it's safe, it's quick, and yeah.
And we talked about, when we were talking about water insertion, about the benefits of the foot pump. For me, the cold snare is the thing that's really changed the sort of therapy that I apply, because we obviously used to use dedicated hot snares, and you could cold snare with them, but it wasn't quite as satisfactory. But it's made an enormous difference, hasn't it?
Yeah.
Evelyn, so if you have, for instance, if you had a larger but flat adenoma, would you be happy cold snaring that piecemeal, or would you rather deal with it in a more conventional sense of lifting and using a hot snare?
Yeah, I think that's exactly where we need data. So, but in general, if the lesion is relatively flat, as you say, and looks really benign, I would be willing to lift it and take it out in piecemeal cold. I think there's a little bit more data, also not definite data, but on sess-ulcerated lesions, doing that technique, which is really safe, but of course those lesions are less vascular, so that's more easy. But I think for the adenomas, but I think you have to be, again, it shouldn't be those fleshy sessile lesions, that's one. And two is you should be really convinced it's benign, but that's of course always as soon as you had on any piecemeal polypectomy.
Yeah, absolutely. Brian, are you going to be controversial, or are you going to agree with?
No, I mean, I agree with that. I mean, the great thing about cold is the safety aspect. It's so safe. You just don't get bleeding. It's very, very incredibly rare. Whereas the minute you use heat, there is a risk of bleeding. I would encourage people to take a nice wide margin around the polyp, because there's always concern with cold that you might not remove the whole polyp, so be prepared to take quite a wide margin. It's very safe to do that. For very tiny polyps, biopsy forceps I think are fine, just cold avulsion for a 1 millimetre polyp is easier and quicker.
Yeah.
You can combine injection or non-injection. Sometimes for a bigger lesion, injection is nice because it will show the margin of the lesion. The blue injection solution will show the edge so that you're more accurate with placing your snare. And for me, in terms of would I do an en-bloc excision of an adenoma, for say a 12 millimetre adenoma in the proximal colon, if the patient is at risk of bleeding, say they're going back on anticoagulation like your patient was, I'd be very happy to take that piecemeal cold. I'd have no issues with that.
Yeah. No, I would agree. The I mean, a lifting, non-lifting thing, I drew attention to it in the VT. There are, it's definitely a bit of a grey area. My understanding is the data that is available actually doesn't demonstrate a big difference between the two, so you can do whatever your personal preference is.
Yes, I agree, but on the other hand, I think sometimes lifting also makes it a bit more difficult to take a nice margin around it, which you also could see in the video for the cold snare polypectomy where you lifted it, because if you lift it quite a lot, the snare is more difficult to stick, on the side of the adenoma instead of right at the adenoma.
Yep.
So I tend not to lift small adenomas in the colon when I do cold snare. I think a good indication is indeed when you want to see the margins, for example. So, for example, for an SSL, I would encourage earlier to do it if you're unsure about the margins.
Now, I've got a voice in my ear. We got a question through just asking about whenever or when would we biopsy polyps. So, Helmut, do you want to take that one? Is it ever okay to biopsy a polyp?
I don't see a need to biopsy a polyp because either I resect it, or I leave it.
Okay, that's pretty straightforward.
No, I mean a polyp. We're talking about the small one. Why should I biopsy a polyp with 1 centimeter? I take it out en bloc. Just in case, if you have a large malignant suspicious for malignancy polyp, where you need staging is perhaps ESD, EMR for sickness resection surgery. That could be helpful to have a grading before to say, well, this is undifferentiated, which is very rare in the colon, but majority I don't need biopsy. If you biopsy too much, then ESD becomes sometimes even more difficult. So no, I wouldn't go for biopsy.
Have you ever stared at a prolapsing inflamed fold in the sigmoid and tried to work out if it's fold diverticulitis or if it's a polyp or not?
This can happen indeed. Yeah. Then where you are in doubt, is this a polyp at all?
That
Yeah.
could be a good
But
reason.
if you are sure this looks like adenoma, or just is it high grade or low grade, or is it cancer, then take it out. Yeah. But as you said, sometimes you have a thickening of a fold, and the resection may be over treatment to resect the fold, and then you have hyperplastic or inflammation. That doesn't make sense. Yeah. This could be a situation where we would take a biopsy.
Okay, yeah, good. And in terms of when you use cold snare versus hot snare, if you've got a polyp which is maybe in the middle, is there anything that pushes you for one or the other? When would you use? I think we're all happy with the cold snare technique being safer, but is there any time when you look at, say, an 8 or 9 millimeter lesion and say, I'm going to use a hot snare there? What's your sort of criteria? Just to sort of break down the thought process so people understand.
Honestly, I don't see for the moment for the small polyps the hot snare. So for me, it's clear cold snaring. Maybe for polyps which are a bit large, and we've discussed about injection or not. Maybe underwater, perhaps we discuss later. Underwater is also a new option, a new technique, which shows that the recurrence rate using underwater EMR is less, and you can take out larger pieces and avoid recurrences, and it's safe as well. So, but this is not for underwater. The advantage for underwater is for polyps larger than, I would say, 2 centimeters or so.
Sure.
To get an en bloc resection.
Okay, thank you. So we're going to stay with polyp detection and characterization now and go to Omar's lecture on artificial intelligence, present and future use of AI in colonoscopy. Thanks, Omar.
Thanks, Ed. We touched upon it earlier. I think there's a real need for us to get a bit of help given the variation and the number of classification systems we have in colonoscopy. So the real question is can the machines help us? I'm going to summarize the current state of play for AI in colonoscopy and also look at the very bright and exciting future that no doubt we have ahead of us. These are my disclosures. So if you haven't heard about AI in colonoscopy, I don't know where you've been hiding the last few years. We've witnessed the most rapid translational journey for any technology in the history of endoscopy over the last 2 to 3 years. We've got multiple regulatory approved devices on the market for CAD-E, which is AI-assisted polyp detection, and CAD-X, which is AI-assisted polyp characterization. The real question is this all hype or is this a reality? Is this the real deal? Well, I think when it comes to AI-assisted polyp detection, we now have multiple high-quality randomized controlled trials demonstrating a benefit. The initial meta-analyses suggested that there was a ballpark 10% increase in adenoma detection rate with AI assistance, but no increase in advanced adenoma detection rate. But I'm pleased to share this more recent network meta-analysis that was performed by Alessandro Rapici's group, recently published in Lancet GastroHep, where they compared AI-assisted colonoscopy for polyp detection with other various techniques, including traditional chromoendoscopy, dye-based chromoendoscopy, virtual chromoendoscopy, and mucosal visualization devices. And what they found was that AI was significantly superior in terms of adenoma detection rate, adenoma miss rate, and crucially, advanced adenoma detection rate. But interestingly, there was no significant improvement in sessile serrated lesion detection rate. The story is slightly different for polyp characterization. We only have 10 prospective studies, no randomized controlled trials. There are 2 recent genuine comparative studies looking at human-AI interaction. Let's take a look at those. So the first study is from Cesare Hassan's group, recently published in Endoscopy, looking at the Fujifilm system of CAD-I for characterizing diminutive colorectal polyps. And interestingly, in this multi-center study in Italy, what they found was there was no significant improvement in sensitivity or specificity when it came to AI assistance. But what's really striking, if you look at this graph on the right, you can see that with the non-experts, by the time there was a clear learning curve, so by the time they got to the last 50 diminutive rectosigmoid polyps, they actually met the PIVI-1 criteria. This study wasn't powered to look at non-experts, so this is really interesting insight. The second study I want to talk to you about is Yuichi Mori's group study, published earlier this year, where similarly they evaluated endocytoscopy with AI assistance using software known as EndoBrain. And again, there was no significant improvement in sensitivity or specificity, but there was, importantly, an increase in high confidence diagnoses. So this could be crucial when we think about the implementation of optical diagnosis in real life practice. So I think the take home message is we need more studies, specifically perhaps looking at less experienced or non-expert endoscopists. It moves us on nicely to the next slide. What should we expect from AI? What are the performance measures? What value is this going to bring to the table? And this is great work by ESGE. Fantastic to take part in this exercise. It was led by Helmut, who we've got here today, Raf Bishops, Cesare Hassan, and Mario Denis Ribeiro, where we were able to reach a consensus on some of the key performance measures we'd expect for AI and embed this within the ESGE quality framework. And I think the key message again here is we've got to look at AI as something that's going to standardize performance, bring it up to a high quality, but really looking for that super expert performance is perhaps a step too far for now. So why is everyone not using AI? That's the question. We've got the evidence there. And I think there's some really important key issues. We published on this a year ago in Endoscopy, looking at some of the top research priorities and barriers for AI. And I'll just summarize some key themes. Firstly, the effect of AI-assisted polyp detection and the effect of this on colorectal cancer incidence and mortality is uncertain at the moment. We also don't know about the genuine cost effectiveness of these strategies, and that's closely tied to the issue of reimbursement. And of course, if we are going to introduce CAD-X, a polyp characterization, you heard earlier, this could be associated with some significant ethical and legal issues that need to be addressed. I'm delighted to announce we've just kicked off this project. This is an international study funded by the EU, led by Yuichi Mori in Oslo, where we will address many of these questions. Firstly, we will undertake a population-level study, a randomized controlled trial, comparing AI-assisted polyp detection versus standard colonoscopy, and crucially look at 10-year outcomes for colorectal cancer incidence and mortality. And within this project, we'll also embed cost-effectiveness analyses and also tackle those difficult issues of ethical and legal issues with AI use. So what about the future? I think the natural evolution is to move on from polyp detection and characterization to quality assurance, and particularly looking at mucosal inspection. So you can see these very nice videos at the top from a group in Wuhan looking at their EndoAngel system. In the top left, this was actually evaluated in an RCT. You can see the AI system is able to provide real-time feedback to the endoscopist about the speed of their withdrawal and the possibility that they may have lost view, and it suggests to go back. And actually, they demonstrated a significant increase in ADR with this system. In the top right, you can see real-time Boston bowel prep scoring. And in the bottom, this is work that we've published at UCL looking at an initial prototype of predicting depth from colonoscopy video to produce a 3D map of the colon. And I mean, this would be incredible to implement into real practice. You could, in theory, have a novel score looking at the percentage of mucosa that you visualized. And I think another area that's been neglected somewhat in the quality movement is endoscopic resection. We really need some help there. And this is really elegant work from Helmut, published in Gut. You can see that this AI system is able to, in real time, identify tissue structures, vessels, and instruments which could be indispensable during third space endoscopy, such as ESD. You could see how this could lead to greater efficiency, improved learning curves, and potentially a reduced complication rate. So really looking forward to seeing this develop further in real life practice. And the final point application I want to touch upon is automated report generation. Let's be honest, none of us like writing the report at the end of the endoscopy. We want to focus on the technical aspect. And I think AI could do this more efficiently, and more accurately. This is really nice work collaborative work from UCL and Odin Vision. You can see in the video that the AI system is automatically detecting different phases of the procedure. It can identify a polypectomy is being performed, pauses the withdrawal time, you get a more accurate withdrawal time. And I think the truth is this is going to bring in greater efficiency and accuracy to our day-to-day practice and hopefully really push forward the quality movement in colonoscopy. So, nice insight into the future there. Thanks a lot for listening. I think what we're going to go straight on to next is a real-life demonstration of AI in colonoscopy practice. I'm just going to go back one slide, apologies, just to introduce the case. The learning outcomes from this are, sorry, could we go back just to the case presentation, please? So the learning outcomes from this are, by the end of the session, delegates should be able to perform an optimal assessment of the cecum and appendiceal orifice, consider effective strategies to improve sessile serrated lesion detection rates, and follow a structured approach for characterizing sessile serrated lesions. So here we'll move on to the case. We've got a 45-year-old female who actually was referred initially for a diagnostic colonoscopy for rectal bleeding 6 months ago. The endoscopist had detected a 25 millimeter cecal sessile serrated lesion, which was resected by cold EMR piecemeal, and then also a couple of other SSLs in the ascending colon, but no formal diagnosis was made of serrated polyposis at that point. So they're coming back in this video for a site check and also to detect any lesions that may have been missed to see if the patient actually does qualify the criteria for serrated polyposis. So we're going to go on to the video now. So we're using the Olympus 290 colonoscope with an Olympus distal attachment cap. And what we're also using today is Medtronic's GI Genius. So we've just come into the cecum and you can see there's a large amount of fluid here. We can shift this with two strategies. Firstly, we could try to suction. Secondly, we can change the right lateral position. This could be a very efficient method because the cecum is a medial structure and this will help facilitate fluid to drain away. It's of critical importance to inspect the periappendiceal region as it's a common area where sessile serrated lesions could be encountered. So before I do that, let's just try the suctioning first and see what happens. This is what most people would conventionally do. So we've managed to suction a lot of the fluid, but to get an even better view, we're going to shift to the right lateral to move this fluid and also use my distal attachment cap to get a very good view of the appendiceal orifice. And come all the way over onto your right hand side towards me, and there you go. You can see GI Genius is immediately picking that up. And maybe this just goes to illustrate our point that you've got to look at the appendiceal orifice very carefully. And I suspect this could well be a missed lesion at the last colonoscopy because the AO wasn't inspected.
I'd like you to have a thought experiment, and that is...
and you can see GI Genius has nicely picked that up as a non-adenoma.
What would we be doing in endoscopy? Basically, not a lot.
One thing we can do with GI Genius that's quite handy is we can, when we're doing resection work and you don't want the bounding boxes coming on repeatedly, we can turn it off on the machine. It's really nice. Push button technology. It's very simple to do. Now I'm going to switch over to near focus again so we can see the margins beautifully. That's it, and close there for me. Yeah. Cut. Nice. So we've got a good clear margin there. The key is to balloon the defect with your irrigation pump and just check the margins with the cap and in near focus. And you can see there we've got beautiful margins. I'm happy that's all come out. Now, something else may have caught your eye. See a scar in front of us. Now, it's important to inspect this carefully. Reason being, we know from the CARE study that sessile serrated lesions have a much higher rate of incomplete resection as compared with conventional adenomas. And so I'm going to have a look carefully at this margin
I've switched to narrow band with NBI. And actually this is another area where GI Genius can help. If there's any residual polyp, we should see some green bounding boxes. There's a brief flash there, but nothing sustained or concerning is being picked up here. So I'm quite happy with this scar site. We've got something coming up in the periphery of the vision. Now, you could have easily dismissed that as a false positive. Let's go back and have a look. And you can see here, this GI Genius is beautifully picking up on a very subtle sessile serrated lesion. I hope you can appreciate that. So as we're coming back, you could forgive someone for thinking that's normal. So let's go in a bit further and have a look at this lesion. So there, you see the prediction of non-adenoma. Let's see if we agree. I'm going to switch over to narrowband imaging. And we're going to get a nice shot in near focus. So, let's start with the NICE criteria again. I think you'd agree with me, the colour is actually the same as the background, or perhaps even lighter. There's possibly some isolated few lacy vessels in there. And there are some white spots of uniform size. So that would make this a nice type 1 lesion. But are there also some WASP criteria here? I think there is definitely a clouded surface. There is a reasonably irregular shape. The border is somewhat indistinctive. I can't see any of the dark spots inside the crypts clearly. I can't see any clear type 2O Kudo open pit patterns, but based on the WASP criteria, I think we can confidently say that this is likely to be a sessile serrated lesion. So agree with the prediction of GI Genius. The other thing we can do to help characterize this lesion is we can, in Japan they commonly use a bit of acetic acid. We're used to using acetic acid in the esophagus for Barrett's neoplasia. There is some randomized control trial evidence now demonstrating that the use of acetic acid in the right colon can improve significantly the sessile serrated lesion detection rate. Firstly, it's a mucolytic. It disrupts the disulfide bonds in the mucus, and also it alters the structure of the tertiary proteins on the epithelium, which leads to this aceto-whitening reaction. And one of the benefits of using acetic acid is if there's a polyp recurrence and a scar and it's difficult to lift, gives you the option of using acetic acid to delineate the polyp, potentially perform an underwater EMR. We can see here another lesion has been picked up, very subtle, could look like a fold. And GI Genius is quite correctly picking this up as a non-adenoma. We've got a very nice aceto whitening effect. We can see the borders and the margins beautifully. And we're going to do dynamic lift. So we're doing a piecemeal cold EMR here. And you can see just how the aceto whitening effect helps to accentuate the contrast of the margins of the lesion with the background dye in the submucosal lift to allow us to undertake a very effective resection.
Great, so we're back in the studio. We saw a nice demonstration there of GI Genius in action. I think, having been involved in the AI development journey, one of the nicest things about AI is it makes us reflect on our own practice as human endoscopists. And I think when we consider polyp detection, I think the AI systems have made us fundamentally consider, why do we miss polyps? And I think there are two main reasons. One is because of inadequate exposure of the mucosa, and the other reason is because the polyp was very subtle and we just didn't see it. So, Brian, I don't know what your feeling is with all your experience. Yeah. Which one of those is more important? Do you think people are not exposing them, or they're just missing these subtle flat lesions?
Even the AI needs you to expose the mucosa so that the polyp, the abnormality, is visible. But all of these things are cumulative. You know, the good bowel preparation, the endocuff, AI, they all add up to a quality examination, taking your time, being aware of subtle lesions like the very nice sessile serrated polyps that you've shown. In my experience and in bowel cancer screening, the AI doesn't make a huge difference. It makes a small difference, but not a huge difference. I think where it will become standard is when the CADX comes in and becomes widely available. Because then if you ally that to the advanced reporting system, you'll be able to take your photo, you'll have a CADX opinion, you'll have your own personal opinion using the NICE criteria, optical diagnosis done in a nutshell. It will then become very, very easy to implement in clinical practice and will take over from histopathology for small polyps.
So talking about implementation in practice, one thing that's often discussed is what is the impact of AI on training and trainees, the next generation of endoscopists coming through. I had a case the other week. We were using an AI system and then we switched it off. The trainee didn't realise and said, "Oh, I was looking for the green boxes. I just got used to them." Is there, so there's a couple of effects that could happen here. We saw with some of the early studies of narrowband imaging that there was a learning effect, actually improved some detection later downstream. But on the flip side, there's a risk maybe we might de-skill. So Evelyn, I don't know what you think of the effect this may have on training, both for polyp detection and polyp characterization.
Yeah, this is an issue I think to be continued and to look. I mean, yes, it would be a worry from my side as well. And like you say, if we start relying on systems that might not always work, there is of course a problem already. So dependency too much on an AI system is a problem. Besides that, the AI system won't be right all the time. So it would still be good to be able to criticize the system or to decide sometimes different. And yes, if we train our fellows using AI systems daily, they might lose that critical vision or their learning curve there. On the other hand, they make a learning curve and they, when they start thinking, what kind of polyp is this? Oh, this is, but maybe we should ask, for training purposes, the CADX system to wait with the optical diagnosis, keep it for a while and only put it on after the endoscopist has made his or her diagnosis. So I think there's ways of trying to use it for training as well. But yes, there is definitely a concern as well.
So we still need high quality teaching and learning. It's good news for Gastro Learning London Live. We've still got a few years ahead of us. The machines aren't going to put us out of business. So Helmut, again, coming back to you, I know you get a lot of referrals for this, for advanced resection. We talked a bit about CADX, polyp characterization for diminutive polyps. What about the larger polyps? We know, particularly in the West, we're not very good potentially at identifying early T1 cancers. Or how can AI help in sort of thinking about your therapeutic strategy, picking EMR over ESD or surgery? Do you think we're there yet? Have we got a while to go?
Yeah, this is an interesting part for AI, I would say. We did a study on Barrett's where we have the same problem. Can we do EMR or ESD? And we tried to train our system to say, well, is a mucosal cancer or submucosal cancer? And we showed it the videos to experts, and the experts had a sensitivity or specificity roughly about 70%, and the AI system was similar. That means there is still some improvement possible. The experts will not improve very much, but we can train our AI systems, and not only for Barrett's, but also for the colon. So the future could be that you have a polyp and AI tells you this is resectable, it's not resectable, and which technique is the best outcome now in this situation. That would be the future where we should work and try to improve AI.
So following up, sorry, you were about to say?
Well, I agree. It's going to be difficult because we know the Japanese that have a huge experience in optically diagnosing suspicious lesions, I would say. So they developed the JNET classification. You can look at the accuracies of the different JNETs. I mean, they are having a difficult time as well.
Yeah.
Maybe AI has other ways of looking at lesions that we have never learned. So yes, there is a potential. Maybe they could integrate logically also location, size, morphology. So that will definitely add something. So yes, it would be great, and I look forward to having systems guiding us better than our own knowledge now. But I also see a challenge. And another issue, as Brian already alluded on a little bit, we still have to demonstrate using AI the whole lesion to the AI system. And we know that's often not very appropriately done either, because when we get referrals for larger or suspicious lesions, sometimes there's only 2 quite bad images. They haven't seen the backside, and they didn't realize there was the clear cancer was on the other side when you go in retroflex. I mean, there's many ways that I would still be, a bit skeptical, or at least, we have to develop a lot before we get there, I would say.
Just make a final point on this. I mean, AI has to make our life easier. We don't want our life to be more complicated or to be confusing in any way. And where the AI will really gain is when it, for instance, it gives you a bowel prep score automatically, so you don't even need to think about it. Where it gives you, aids you in the reporting of your case. We spend a lot of time sat in front of the computer doing the report, almost as much time as we do during the endoscopy. And anything that streamlines that will be beneficial. What we don't want is lots of false positives, which distract and potentially cause confusion. But of course, AI is still in its infancy. All of these algorithms are going to get refined and improve. We're starting to move into therapy now, and there's some very interesting possibilities for therapy. Can you determine when there's residual polyp? Can you predict who's going to have a risk of bleeding, who isn't? Can you predict where blood vessels are running? You showed beautifully on the video there. So there are lots of possibilities.
Great. So I think a lot of space for development, really exciting applications we've seen today. I think the future is very bright. I think AI is going to get more complex, but we definitely need the help from the societies. I think we need to have a bit of clear guidance on some of the performance measures we expect, the quality of AI, what are the studies we need to do. So a lot of food for thought. Now that very nicely brings us to close for our basic diagnostic colonoscopy lesion recognition session, and we'll be moving on very shortly to our post-colonoscopy colorectal cancer session.
Welcome back. Here we are for our second section of the Colon Symposium. And Professor Evelyn Decker is still here with us, and we appreciate that you continue with bringing your input to the discussions. And let's at Cheltenham Hospital. Hello, John, and welcome. And we are very grateful you are here with us. And remotely, I believe in Gloucester, we have Dr. Roland Valori. Good morning, Roland.
Good morning.
He's a consultant gastroenterologist in Gloucester's hospitals. And actually, we are going to start with you, Roland, because you have done a lot of work in post-colonoscopy cancer, post-colonoscopy missed cancers. And in this section, we would like to focus a bit on colorectal cancer screening, try to understand what a good quality withdrawal is so that we miss the least cancers as possible, understand colonoscopies. Also, we will bring the Nordic study and have a bit of a discussion about that. And most importantly, we know we can miss pathology. So over to you, Roland.
Thank you very much, Rosa, and thank you for inviting me to London Live. Can I have the first slide, please? I'd like to just ask you to all do a thought experiment and just imagine there was no gastrointestinal cancer. I think the London Live would have finished yesterday lunchtime because all we'd be doing in endoscopy is dealing with some gallstones, GI bleed, inflammatory bowel disease. It makes the point that most of what we do is really about cancer. And if you think about it, most of our time is spent reassuring people they don't have cancer. The next most important thing we do is prevent cancer. We spend a lot of time preventing cancer, and then we finally diagnose and we treat cancer sometimes. We remove cancer and relieve obstructions. Now, we know that we're not really as good as we need to be in this process. We know that there's great variation in interval cancer or post-colonoscopy colorectal cancer, and we need to understand how we can do better. And the way we do that is really to look at cancers that have appeared after an endoscopy that hasn't found cancer. So to achieve that, we have done a national audit. And what we've done is we've identified cases occurring within 4 years of an endoscopy that doesn't show cancer by integrating hospital episode statistics with the registry. And we've presented up to 25 cases to the 126 hospitals in England, and we've created an audit template for them to assess why there was a delay in diagnosis. Next slide. So basically, we did well with this. Of the 122 of the 126 sites that participated, we had a 77% completion of the audit template. Next slide. So the first question we ask is was the PCRC avoidable? And the second is, did it lead to harm? And the key take-home message here is that most PCRCs are avoidable. In my own study, we deemed 89% were. In this study, probably more than 70%. And what about harm? Well, up to 30% of patients had either major harm or premature death attributable to the delayed diagnosis, and that's not good. Advance. So next slide, please. So there are some factors which, just to go back one slide, there are some factors which are not related to the quality of the procedure. And this will all be recorded and you can look at this data. I won't dwell on it, but there are some non-procedural factors that lead to a delay in diagnosis. Next slide. So what were the reasons for doing the index colonoscopy? And the point I want to make with this slide is that a significant proportion of these cases are in the context of surveillance. And if we put IBD surveillance to one side, I think we really should be aspiring to prevent cancer in our surveillance strategies, and we clearly are not doing so. Next slide, please. Now, one important finding of the audit was that in 27% of cases, procedural difficulties were mentioned in the report. And I would put it to you that it's unusual for people to mention procedural difficulties in reports. So this is quite a high percentage. And if you think about it, if the procedure's not going well, or it's very long, or you've done a long resection and you're tired and you're stressed, your attention is going to be reduced. And certainly in my own practice, I recognize this, and now I take steps to ensure that my attention is maintained when I know things are going difficult, are difficult. Next slide, please. So let's have a look at a few pictures. So this is a picture I took of a cecum. Advance, please. And you can't see anything there, but if you look a little bit more closely, you can see that there's a cancer in the medial wall of the cecum. Next slide. And we found in the audit that there was inadequate photo documentation when a photo was deemed important of the cecum in 56% of cases. So there's clearly room for improvement here. And it was interesting to watch that previous presentation and the remark to get the patient on the right side to visualize the cecum properly. What about the rectum? Well, advance the slide, please. These are two pictures I took, and these are genuine photos I took not very long ago. And I always take two photos. I rotate the scope. You can see I've blown up the rectum in the second picture, and we see a little polyp there, and maybe another one just close to the scope. But really, it looks okay. And a lot of people will just pull the scope out once they've retroflexed like this. Next, advance. Okay. So, but I was a little bit cautious pulling out, and this is what I saw, advance. And then when I retroflexed again, and again, next slide, next advance again, we see that there's a polyp there that was hiding behind the scope. And this isn't the only time that I found this. I've seen other lesions with very careful retroflexion that I would have otherwise missed. Advance. If we look in the audit to see what proportion of photos of the rectum that were deemed inadequate when they were important, we find that more than half were inadequate. So there's room for improvement here. Next slide, please. Next slide, please. So the World Endoscopy Organization published in 2018 a consensus statement on post-colonoscopy colorectal cancers, and in that they had a categorization, and here you see the four main categories, which we've actually labeled A, B, C, and D. And the interesting thing here is that the majority of cases in this audit, and this is in line with our own findings of a previous publication, is that the procedure was deemed adequate in terms of intubation and bowel prep, but nevertheless, a cancer appeared within 4 years of the procedure. Advance. So this first category, that's the top one, the grey one, is an issue about quality. It's an issue of care with examination, recognizing when the procedure is difficult and you might miss something, so you really need to slow down or consider repeating the procedure. Advance. If we look at category B, which is nearly 20% of cases, the procedure was deemed inadequate, either failed intubation or poor bowel prep. And in many situations, there isn't a clear decision about repeating the procedure one way or another. So there's a process issue as well as a quality issue. The quality is all about, do you get to the cecum? Do you visualize the mucosa adequately? Process is, have you decided that this procedure is inadequate for the indication, and are you making sure that the test or another test is done to ensure there's no cancer? In the third category, next slide, please, we see nearly 10% of patients had a lesion, but nothing was, it wasn't resected in time. And there's a whole combination of things here. Sometimes comorbidity or patient choice means that It's not the fault of the service, but in many circumstances there are delayed pathways or failed booking, things that are inexcusable. And finally, next slide, advanced, I mean. So we have the category of likely incomplete resection, just about 5%. And here we're looking at quality, the quality of the resection, and we're also looking at process. So is there a timely checking of the resection of the large polyp or whatever it is? Is there good follow-up? Is that done properly? Next slide. So I think we have demonstrated that it's possible to identify cases of post-colonoscopy colorectal cancer and provide the services where the index colonoscopy was done with those names of the patients. Up to 25% of cases are diagnosed in another hospital, and the index colonoscopy hospital would never know about these cases. But we've created a method where we give the cases to the service. We've provided a template. We're building an evidence base of things that go wrong, and that evidence base will help us make stronger recommendations in the future to reduce PCRCs. Auditing these PCRCs at a local level, and I must have reviewed at least 200 in our own organization, is a very sobering experience. There are lots of things that can be improved. We have a low PCRC rate in our organization, but we still find stuff that we can do better. We can do better. We just have to understand what it is that we need to do differently to reduce rates. Thank you, Rosa.
Roland, thank you very much for such a comprehensive summary of the issues that probably we face across the globe on missing these cancers. I would like you to hold your thoughts, and we will discuss about this subject in a minute, but we will move into the next case just to complement what we are doing. So just to present the case, this is a female patient that was referred through the bowel cancer screening program because of a FIT test positive. And the patient had some change in bowel habits and reporting loose motions as the symptoms that were recorded by the bowel cancer screening practitioners. So as an equipment, we are going to use the HQ290L video colonoscope from Olympus. We are going to be using the scope guide navigation system from Olympus and the water irrigation system from Pentax. And the learning points in this case, hopefully by the end of this session, we should understand the reasons of position change, highlight the blind areas where colonoscopy withdrawal is very important to be done slowly and carefully, and also hopefully few tips and tricks on how to improve our rates of post-colonoscopy colorectal cancer. So,
back to your back again. Excellent. We will give him another 10 of Buscopan, if possible. So I'm gonna come back showing
all 800.
Yep, that's fine.
Okay, I'm going to give you more Buscopan.
Okay.
You might
Just to check there are no other lesions. And usually on the supine position, the fluid tends to be accumulating in the sort of a proximal ascending colon, and makes the visualization not very good. You can see possibly there is a lesion there, and another one here. So what I'm gonna do is change the patient position again to the left, now that I have inspected all the cecum quite extensively, so the fluid will accumulate to the left and will give me a better view of the ascending colon. Completely on your left-hand side, so just shuffle completely on the left, like when we started, all the way.
Exactly. Well done. We have a good visualization of the cecum now. There is a small polyp there, diminutive, that we will probably live well alone. So now with the patient on the left hand side, the fluid has migrated, and we will be able, so I'm just inspecting very well, pulling down with the tip down, and making sure I clean. The bowel preparation is not great, as much as I can. By fluid with the patient on the supine position. So that's a great example of why patients should be changing position in order not to miss anything. It looks laterally spread lesion. Just suctioning and cleaning well so I can inspect. Let's see if I can get a better visualization with a bit of insufflation in order to be able to assess them. There you are. Gold is a non-granular LST. That's it. The imaging, because that will allow me to have a better look on the pit pattern. There we go. So a bit of a closer look with the near focus. Then again, fluid accumulates. So I'm just going to suction. There we are. Yes, probably JNet 2A, I would say. That shows you the importance of change the patient position, because the bowel preparation is not ideal. Here is a good definition of the pit pattern with no worrying features. So a JNet 2A. Right, I think this case was a nice demonstration of how we very often can miss lesions, perhaps because we don't manage the fluid very well, or we don't change the patient position. I couldn't see the polyp when the patient was on supine, and I just got a perfect view when the patient was changed on left lateral, as it's been demonstrated. And I would like to bring a little bit of a discussion about this issue of high quality withdrawal, because probably when we set up our training programs in colonoscopy and we set up the KPIs to measure quality, we were very much biased into the insertion and reaching the cecum, because that was one objective measure that we could measure about. And I remember training, and actually even now training a lot of our trainees in our unit, and one of the things that they always make sure that they comply is on the cecum intubation rate. And I think we all have this sort of a tendency of thinking, I've reached the cecum. And then you sort of relax, and the withdrawal, maybe you take it a little bit more casual. And perhaps, and I always say to the trainees in the room, and if they are watching, they know that I am constantly saying, the patient is not interested about you reaching the cecum. The patient is interested about you telling them that they haven't got a cancer or a polyp. So the important being of the colonoscopy begins when you start performing the withdrawal. So on this note, for instance, John, just it was very interesting from Roland's talk that actually in the World Organization of Endoscopy study, nearly 56% of the lesions that were missed were in actually patients that had good bowel preparation. And most of the times we have the tendency to think, oh, I missed the cancer because I'm sure the bowel preparation wasn't good enough. So it's quite interesting that a high proportion, the bowel preparation was considered adequate. So it was more down to the quality of our withdrawal. So you are a very experienced man on this. Tell us, for instance, 3 points or 3 tips that you think it would make a massive difference on the way we are withdrawing colonoscopy and would make an impact?
Sure. So I would say the first thing is the prep has to be good. And if it's, Roland's alluded to this, we don't make a decision if we think the prep's suboptimal. So the prep has to be good. And with that, the advent of the water pump has transformed things in terms of being able to improve a suboptimal prep. But that doesn't dissuade you from the fact that if it's still poor, it's not an adequate examination. So I think visualization is important. And with visualization, you have to understand the effect of gravity. Gravity enables you to move fluid and distend with air. Keep the air in the section of bowel that you're looking at to get adequate distension, flattening of the folds to allow you to pick up the lesions, and also move the fluid around so you can see areas that would otherwise be submerged. So to understand that, you have to understand the correct patient positions, I would say. And I think the other thing I would think about would be the advent of distal tip attachments, which I think have revolutionized the ability to look behind folds. I mean, there are multiple other things. There's buscopan, there's retroversion of the right colon, there's lots of things. But if you were to look at 3 big things, it's making sure that it's adequately distended, making sure it's clean, and making sure you can see behind all the folds in what I call the blind areas.
Yes, I completely agree. And Roland, is there any subgroup of these patients that we miss cancers that are particularly worrying? In your experience looking at this post-colonoscopy colorectal cancer, was a particular subgroup of these patients, either from bowel cancer screening, symptomatics, IBD, that we were doing a worse job?
So I think that's a very good question, Rosa. So I would be looking at the surveillance categories, and within the surveillance categories, there are clearly some high-risk groups. IBD stands out. The risk of post-colonoscopy colorectal cancer is very high, but you could argue that some of those cancers were, it was a success because you diagnosed them early. But certainly in Lynch syndrome, and I think particularly in post-colorectal cancer resection, something that we see happening is we see a polyp when the cancer is diagnosed, and it's left to after the operation to remove the polyp. Then the repeat doesn't get done for a year or more, and then by which time the polyp's cancer. So I think there's something biologically different in some patients with colorectal cancer, certainly with the Lynch syndrome. And I think it is possible to identify some very high-risk patients amongst the surveillance groups.
And John, do you think, and obviously with all the waiting list pressures that we have after the pandemic, and we are all with a lot of patients in our books that need to be scoped, that we need to do something different in terms of allowing ourselves to do a good quality withdrawal? How do we need to manage the balance between getting patients through and not missing important findings?
So, Rosa, that's a great question. That's a 2-day symposium, I think. But in essence, I think we need to be able to prioritize better. And in our prioritization, we're already subjected to lots of rules and regulations. For example, a 2-week wait distorts the way we triage patients and allocate resource. And our surveillance patients are often put on hold whilst they're displaced by emergency referrals. And as Roland's just highlighted, some of the surveillance patients are actually very high-risk patients and can't really be delayed. So we need to find a way of being able to prioritize. We may need to think about our indications for colonoscopy, and certainly patients who come back for multiple procedures which are normal. How do we shall we say, not offer the procedure, and maybe that's an opportunistic cost which would be better served by another patient group. That's a really difficult question to answer, and maybe the use of FIT will come in, maybe some of the data from the post-colonoscopy colorectal cancer groups will come in, but I think we need a fresh start, and we need to think again how we triage and allocate resource.
Good. So I think Evelyn is ready for her lecture regarding the Nordic study, and we will discuss a bit further about this subject afterwards. So over to Evelyn.
Okay. The topic of my talk is on the time after the Nordic study, so population screening post-Nordic. First of all, I have some disclosures to make. However, my slides move very slowly or not at all. Next slide, please. Yeah, so here are my disclosures. Next slide, please. So population screening for colorectal cancer, just to stress, is aiming to detect colorectal cancer at an earlier stage and also to prevent the disease by detecting and removing the relevant precursor lesions. So we hope to reduce mortality from colorectal cancer, reduce the burden of colorectal cancer, and reduce the costs. So how about assessing the cost effectiveness of a screening program? Well, we look at different methods, right? And then, of course, first of all, we look at the characteristics of the methods in terms of sensitivity and specificity. But besides that, there's many other factors that come into place when looking at population screening. And an important one is participation rate, because if you have a very good test, but nobody is participating, the effectiveness of your screening will be terrible. Besides that, of course, we have to look at the characteristics of the population and the participants that are indeed complying to screening, capacity issues, costs, and of course the burden and the risks and many other factors. And we have to weigh the benefits against the risks and the costs and the burden. So, of course, we all know colonoscopy is supposed to be the best test to detect advanced neoplasia. However, it also comes with a burden. Besides that, with issues on capacity, on complications, and on costs, of course, all those other things, but mainly the burden for the patients, especially if you're just coming for population screening. And that's why it's important to look at the results of the Nordic study that was recently published in New England and is a collaborative work from 4 European countries. So it was designed as a pragmatic randomized trial with presumptively its population screening, healthy men and women between 55 and 65, drawn from the population registries in those 4 different countries in Europe between 2009 and 2014. And at that time in most countries there was not yet a population screening program in place. Only Poland was doing that, but this study was done not in that region. Participants randomly were assigned in a 1:2 ratio, either to receive an invitation for single screening colonoscopy or not receive an invitation for screening, so the usual care group. And there were primary and secondary endpoints, risk of colorectal cancer and of course related death as primary and death from any cause as secondary. These are the characteristics, and you don't have to look too much at it in detail, but you can see in total we had over 8,400 or 1,000 participants. Norway, Poland and Sweden participated. Regrettably, from my country, from the Netherlands, we were not allowed to deliver data or retrieve data from the control group, although we were given that permission 10 years ago. So we fought a lot about that decision, but it was for now impossible. So, and you can see Poland has the largest group of participants, over 50,000. And then if you go down, you can look at female-male, which I think is a little bit interesting, because apparently in this study there were a bit more males than females participating. And then participation rate in itself is interesting, because you can see this varied widely between the different countries. So average was 42% in all the countries, but look, the differences in Norway over 60%, and at the same time in Poland only 33%. And I can disclose in my country, at the time where we piloted fit screening and we had a participation rate of over 60%, in our screening trial for colonoscopy, our participation rate was even lower at 22%. And you can look at quality parameters as well, which are, I think, generally acceptable, but also varied a bit between the countries. So here is the primary endpoints. On the left hand, you can see the reduction in colorectal cancer in an intention to screen analysis. So that takes into account that relatively low participation rate of 40% on average. And you can see indeed there was a risk reduction in colorectal cancer incidence, but of course not as large as we would have hoped for in the screening situation. Mortality also reduced, but even less than that. And important numbers, I think, also to remember is the number needed to screen to prevent a colorectal cancer was 455, of course, quite high. So. Next slide. So again, I would like to stress this is an invitational screening program. Can I go 2 slides back, please? Another one, please. So that's again important, but most countries use, luckily enough, an invitational screening program because that's the way you hope to reach the whole population. In this case, in this study, we could also adjust as a per protocol analysis. And then we look at numbers that are much more expected from colonoscopy screening, although they were quite similar to the data we have from 3 large sigmoidoscopy trials. The CRC risk was reduced and also the mortality was reduced. This means that colonoscopy does protect from colorectal cancer and colorectal cancer death, but only if individuals are indeed willing to undergo the procedure. So colonoscopy screening could work, but only if high participation rates, and we know these vary widely, and in some countries they were even as low as 2%. This means that per country, per region, this depends on the organization, the culture, but also the participation rates vary widely amongst individuals. And we know there's large differences in individuals participating concerning age, gender, but importantly also socioeconomic status and ethnicity. And this really may result in those participating in such screening programs that are probably by themselves at a lower risk because they're more risk alert. So be aware of this healthy screenee bias when there is low participation rates, even more diluting your effect of your program. So how to continue from here and how to look at the future for screening. I hope for my next slide, maybe you can continue it. So other screening methods, I think I've made clear, have to aim for high participation rates. And of course, we are in Europe very used to the method with fecal immunochemical testing. It's an easy test. It can be performed at home. It's very cheap and therefore difficult to challenge by other new methods. And it has high participation rates. And look, these are the participation rates published in 2019. And you can see between the different countries, most do indeed very well, varying around 50% or even higher. So yes, participation is high, and the target is to triage patients or persons at a higher risk of having advanced neoplasia with an acceptable accuracy, so not too many false positives, and of course not missing too many lesions. And that results in approximately 5% of the participants having an indication to undergo a colonoscopy, and the adherence rates there are much higher than in the general population, and may reach clearly around 90% in countries like we had in my country. And this is indeed also data from my country showing that not only incidence after the start of the population screening, after first having increased on the left side, now has decreased beyond the level where we started, and the same for mortality, especially in the age ranges that you can see here in the screened age of 60 to 75. So yes, there is a clear effect of FIT screening as well. This is not my slide actually. I don't know how this came here. Maybe you have my next slide, or my last slide is gone. Okay, so I have to finish here. So I think this is very clear, and I hope to discuss more later. Thank you.
Right, thank you very much, Evelyn. It's a sort of a wow study, isn't it, when it came to the press, and there's been a lot of controversy and a lot of talks in every different unit that we have a lot of interest on screening colonoscopies. So, John, what's your summary about it? Because looking at the data from Evelyn, and we will discuss it a little bit with more detail, it seems that colonoscopy acceptance is probably the key, isn't it? Because the participation of the invited group was around 33%.
Yeah.
Is there anything we can do for patients to accept these colonoscopies?
So I think first thing, you have to commend the people who ran the study for such a long period of time. It was a pragmatic study, a one-off intervention, and they waited a long time for the data. And the standard for me is the colonoscopy is protective, but it takes a long time to reach that crossover point. And I think you then need to really look at the reasons why, and Evelyn's already alluded to some of those in her talk. I mean, fundamentally, you've got to look at the quality of the colonoscopies and the quality of the procedure, just as we're discussing this morning. And maybe a one-off isn't the way to go. And if you're not going to do a one-off, you have to have some way of triaging. And again, Evelyn alluded that towards the end of her talk, where maybe we can target populations which will indicate they have a potential problem, and that way you then may add a motivational factor to get them to comply and agree to the screening. So I have to applaud the people for going through with the trial. It's a first to do this, and maybe some people will reflect that the results were not as persuasive as you would have liked, but at the end of the day it was a positive trial. But I think it just probably asks more questions than it answers. This will be my summary, I think.
Exactly, and I think it has put on the table lots of probably problems and barriers that patients face during on all the screening pathway. So in the Netherlands, with the Nordic data in your hands, is there anything that it's gonna change in terms of screening patients? Is a single colonoscopy considered it's gonna be a good path? The bowel cancer screening that is established will continue. Any variations of other methods of screening the bowel that we are considering to bring in?
No. It's the short answer. I lost my last slide, but no. I think triaging is the way to go. I don't think colonoscopy as an invasive method is a way to look whether there's anything interesting in the colon. So I think we should reserve colonoscopy for those who need it, and that's why we discussed previously. We should definitely reserve colonoscopy for surveillance for those who need it, but the same, of course, for screening, especially as those patients are usually, or those individuals, that's exactly why they are individuals and not patients. They are at home and they are not worried, so they have different motivation. So I think triaging is the way to go, explaining people why you have a good reason to go in. And yes, we do a lot of research in trying to improve fit. And that was my last slide, really. So I think fit is fantastic because it's cheap and it's easy to do and it has high participation. But of course, sense and spec are not ideal. So it would be great to try to improve that with a test, maybe fit, using with other risk factors like age and gender. And for example, maybe the previous test result, we know if you model that, you do predict better who needs to come for colonoscopy in the future, or maybe also vary intervals for the next screening session, things like that. But we're also working a lot on trying to improve the test itself. It's not using just blood, which is of course just blood. I mean, many other reasons to have blood in your stool. So maybe by molecular tests, could be fecal, but it could be also maybe breath or urine. So there's a lot of thinking of trying to improve, but the challenge with FIT is fantastic because it's so cheap and doing relatively so well. It's going to be very challenging for another test to do better.
Yes, and we certainly can see the impact since in the bowel cancer screening program in the UK, we moved from the fecal cord blood test as a triaging system to FIT, and the repercussions that has had in terms of volume of advanced lesions and a higher pickup of cancer. But we will discuss a bit the use of FIT later on within this section. Roland, would you like to bring a little bit of your thoughts regarding the Nordic study?
Yes. Yes, I think that it's just a very early days to look at the results. I mean, if you look at the flexible sigmoidoscopy screening trials, I'm not sure that they reported quite so soon as this. And we're seeing, in effect, 17 plus years out in flexible screening. So, but I agree with Evelyn. I think the future for certainly European countries is to use FIT-based screening. And if I may, I would like to suggest three things that will make a big difference. One is we need to sort out the productivity of our units, which I know is not good, to make more space to do the procedures properly. Second, the quality, obviously. But the third, for England, I think we need to copy Denmark and Holland and have a wider age range and a lower FIT threshold. In Denmark and Holland, correct me if I'm wrong, Evelyn, but 20 to 24% of cancers are screen detected now. And in our country, it's 9 to 10%. So we really need to address that. And to achieve that, we need to create more capacity by doing things, I would argue, more efficiently.
Very, very important points, Roland. And talking about other methods of screening, I would like to introduce now our next video where we are demonstrating colon capsule on detection of polyps and colorectal cancer.
I'm Joanna Parisi. I'm a consultant gastroenterologist at UCLH, and I'm leading the capsule endoscopy service. During the pandemic, as you all know, we had a lot of challenges in endoscopy, but those challenges have also created grounds and opportunity for innovation. So we started doing a worldwide first service of doing capsule endoscopy at home, a completely remote procedure, which hasn't happened elsewhere, and where the whole endoscopy can happen at the patient's own residence. And what we quickly realized, although this was started during COVID restrictions and lockdowns, we witnessed that actually patients were happy with the service and they were very keen to engage, and many times they would prefer it instead of other procedures. Today I'm going to show you a remote colon capsule patient journey, and we will go through this process together and also have some live feedback from the patients themselves and their own experience. So tell us, Michela, what happens when a patient is booked for a colon capsule at home? Do you speak to them at all before the procedure?
So we have a pre-assessment clinic. So we aim to call patients a week before their appointment date. So this is the time where we will be reviewing patients' medical history, and at the same time we need to investigate if patients is experiencing any chronic constipation. So if we do identify this, we will be offering patients medications that could improve their gut motility. So this is prucalopride.
And how do you make sure that the patients can do this at home and they know what to do exactly and they have enough support to do this on their own?
Okay, so before the procedure, our bookings team will be sending a video about video capsule, like what to expect on the day. We will be doing a step-by-step tutorial as well on the day of the procedure.
And did you ever have any problems with patients that actually they were ready on the day, but they said this is too difficult or too challenging, and you had to call them back to the hospital to have this done on site, or any patients that couldn't swallow the capsule and again, everything had to be cancelled and all the equipment to be brought back on the day?
We have done 150 remote procedures. So all of these procedures are successful. So I did not encounter any patients saying that they weren't able to follow the instructions that has been given to them. And then all of them managed to swallow the capsule. So patients with anxiety or patients that has like problems with technology, these issues are being picked up during pre-assessment. So during pre-assessment, if we manage to pick this one up, we won't advise the patient to do it remotely. So this is the time where we will be advising them to come into the hospital so that we can give them a full support instead of doing it at home.
Right, so we've packaged all the equipment, the recorder, the capsule, the belt, and the bag. And then the consent form and other documentations. The patient would have been verbally consented a week or so before, and then all they need to do is just to sign the consent form. So we package this and we send it by courier. So once the patient received the package the day before, we connect with them on the morning of the procedure, and then we help them to put on the belt. So this is the belt, got the front section and the back section. And then we got some wires which are antennas that picks up the signal. So we help them to put the belt on. So this goes to the back and then connects the back to the front from this end. And then we instruct them to put on the antenna which goes over the head, just like that, across the body. And then there's an adjust at the back, which will adjust the belt.
That's it. And then place it on top of it. That's correct. So that's one side done. Now the other side.
The other side.
Yes. Can you see there's a shiny piece there in front of it?
Yeah. Yeah.
There. If you lift it up. That's correct. Lift it up. And then you're going to fold it to make your size. Yeah, well done. So that's the on-off button. So once you switch it on, it should come on. You should see the lights all flashing. That's correct. And you can put it in the case now.
Okay.
Yeah, press and hold the button, and then that's it. Correct. Okay, that's fine. Yeah, that's all done. So all we need to do now is to swallow the capsule when you're ready. You can do it with water. You can do it without water. It's up to you.
Once we dock the recorder into the docking station, then we come up onto the computer, and then we select the particular recorder that we want to create the video, and then just start creating the video.
So Graciela is a 43-year-old lady who was referred by her GP for investigation of her lower GI tract through the do-we-wait pathway. She was experiencing a new onset change in her bowel habit, alternating with diarrhea and constipation. She had some new onset abdominal discomfort and fresh red PR bleeding. So she was referred to the do-we-wait clinic where she had a telephone consultation, and she was offered a colon capsule at home. So this is how we are reviewing the video and reading the procedure, and this is the ileocecal valve there, and you can see how, this patient had a good bowel preparation. You can see it's quite a clean bowel. You can adjust the speed, and you can see how the capsule falls into the transverse colon, and many times it will go back and forth. So even areas that you feel that may not have been covered very well, usually the capsule will go back and you may see this area again.
So tell us, Graciela, how did it feel when you were first offered the colon capsule endoscopy instead of a colonoscopy, for example, or other procedures? Did you know about it?
No, I didn't know. I was surprised about it. I didn't know in NHS they have this procedure, do it this way. So.
And is it good to have everything done from home? Does it help, you think?
I think so, because you can have your normal life. As the only thing is you need to have a bathroom closet. So it's better if you're in your house to go all the time.
If we would ask you to have an investigation for your bowels in the future, would you prefer this test, or would you prefer a colonoscopy, or what are your feelings about this?
I think if I can avoid the procedure, the colonoscopic procedure, that I need to go to the hospital, pass for injection and everything, I will avoid it. And I think most part of the people will avoid it So it's easy if I can go only for the capsule.
Okay, thank you very much. Thanks.
So Joanna, thank you for joining us. I mean, that sounds incredibly impressive. I mean, we've already heard from the Nordic trial that we're really struggling to get patient participation to engage with having a colonoscopy. FIT might be the answer, but what are your thoughts? Have you solved the problem in terms of lower GI investigation?
So as Evelyn presented the Nordic data, obviously there's a significant percentage of patients that don't want to have a colonoscopy. And obviously the adherence is better when they're FIT positive, but when they have symptoms as well, some of them, as the patient mentioned in the video, they have a perception that they don't have anything significant. They have other things going on in their life, so they feel that actually it's too much to find an escort, to have sedation, to come to the hospital. They want to avoid the hospital if they can. And all these factors, plus the fact that patients have a fear of the colonoscopy sometimes. And one of the reasons that they don't want it is because they fear that they may have discomfort or pain or anxiety around the procedure. And so this is where we found out, and we're not presenting the data here, but we found out that the patients feel much better when they have that procedure at home. It's non-invasive. They don't have anxiety about it. They don't have embarrassment about having the bowel preparation and having to travel to the hospital to have the test. And when we take feedback from them, they say they would prefer to have this test at home in the future rather than having anything else.
Okay.
But why do you say they don't have the trouble of the bowel prep? Because I think the bowel prep should be even
No,
better
the embarrassment of having the bowel prep. So the patient mentioned in the video that if I'm going to take the bowel prep, which he didn't like, of course, I want to be near my bathroom rather than traveling and coming to the hospital. Of course they don't like the bowel prep.
But they all prep at home, right?
Yeah, but they have, what she said is that I would like to be near my bathroom rather than having to travel.
After you prepped?
Yeah.
Okay.
Yeah. So is colon capsule suitable for everyone, or do you have an ideal patient in mind who you would do a colon capsule on?
Yeah. So the colon capsule is not going to replace the colonoscopy, obviously, and it's not a test that is suitable for everyone. And to become cost effective and to be a good test, it has to be a test that is complete, successful, and doesn't find anything, or it doesn't find anything significant. So the conversion rates to colonoscopy or flexible sigmoidoscopy have to be low. And what we found is that a careful selection is quite significant. So we try to do the capsule in a patient that is young, so low risk of having significant pathology, a patient that doesn't have gut dysmotility problems, constipation, being on laxatives, anything that might risk a procedure that is going to be incomplete. And patients that we expect that when they will have the procedure, it's going to be a complete procedure and it's not going to find anything significant. So our conversion rates to colonoscopy or flexible sigmoidoscopy are 20%, which is much lower than other centers. And I think this probably relates to the fact that you want actually someone that may have IBS, may have symptoms that they need investigation, but you feel that everything is going to be normal.
And so what role does FIT play in this? Because obviously we got FIT for screening, but we also got FIT for symptomatic. And are you able to cope with 2-week wait patients for the colon capsule service? And what does the FIT level affect what you do?
So some of the FIT levels, because we use the cutoff of 10, right? So the low positive FITs that are much less likely to have significant neoplasia, and we expect that there's going to be a significant number of normal colonoscopies in the end. These are the patients that need to be investigated, either because they do have symptoms or because they have tested positive for FIT, but we expect that they will have a normal procedure. So these patients could go for a colon capsule instead of a colonoscopy. And obviously patients that don't want to have a colonoscopy for whatever reason, this is a cohort, that can go for a colon capsule. We do know that some specific cohorts are less likely to adhere to a colonoscopy, and these could be also patients that we can target.
And John, bringing you in, so we've had actually a question from the audience about fit below threshold, so fit less than 10, do they warrant investigation? What's the weight that you put on a fit result, a negative fit result, in terms of providing reassurance?
So I think we do need to have some sort of fences, Ed. So we need to use the full armamentarium. So that nothing, you're right, colonoscopies remains the gold standard because you can diagnose and treat, but you'll need other modalities, capsule being one of them, CTC being another one, and I think you need to match your patients accordingly. So in remote areas, Scotland for example, out of Hebrides, having the ability to have a colon capsule prevents the patient from travelling. You mentioned a number of patient groups which may be useful. I think another group that we haven't considered are patients who are anticoagulants, who have recurrent FIT positives, who keep coming year on year for colonoscopies, and maybe these are an ideal group to do a capsule if they've had a negative colonoscopy as an index procedure. I think for people who have got a FIT threshold which is negative or below 10, you've got to ask what the likelihood of pathology is, and I think in the absence of other symptoms, I would be trying to change the pathways. So rather than offering them colonoscopy, you need to treat whatever the problem is. It's a colonoscopy I don't think will help there, and it's just going to consume resource, I think, and I would include capsule as part of that resource.
Yeah, absolutely. I mean, Evelyn, we're fortunate in the UK. There's been a big capsule uptake in Scotland. The NHS England have promoted use of colon capsule as a way of managing colonoscopy capacity. What's the situation in Netherlands? Is it something that you welcome, colon capsule, or is it something you're a bit suspicious of?
Not a lot. I know there's some research going on in Rotterdam. We have participated in one of the earliest trials, coordinated in Italy, and I wasn't. I mean, of course, there's a lot of development that makes it better. But my biggest concern, apart from the bowel prep, is that patients don't like the bowel prep so much. So we were discussing about having to come to the hospital when you prepped, but still they have to do a very thorough prep. Probably even more than for a regular colonoscopy. So, and patients, if you survey them, usually find the prep the most difficult part of the whole colonoscopy procedure, and you're giving that same prep. So we felt kind of obliged to then, if we would offer a service, trying to read out the capsule immediately and have them on the table for colonoscopy if needed. That, I think, would be additive. But on the other hand, I totally agree with John. I think many of those patients with low probability anyway should probably not have a colonoscopy. That's my whole thing. And for example, our FIT positives that have a negative colonoscopy don't participate in screening for 10 years. They are just not invited. That might be too long. We don't know yet. We are evaluating that now. But I think, again, being strict on indications for full colonic inspection should be much less, whatever method you use, because this is a costly method and still non-invasive, but a little bit invasive as well. And that's even apart from being sure you really saw the colon well, because if you look, you can't distend all the folds. You're not always sure. You look behind the fold if there's some remnant left. Have you seen it well? I mean, you are much more experienced with it now than I was at that time, but there's still a lot of uncertainties. The battery that starts in time when it's in the ileocecal valve and it's not finished before it finishes the colon. I mean,
but the bowel prep, it's a very important point, because changing the bowel prep and changing the boosters to procalopride that we currently use routinely has made a massive difference, not only on the cleanliness, but also on the duration of the procedure. And that means that then the patient's preference and the patient's satisfaction is much higher, because now we have capsules that most of them, they pass within 2 or 3 hours. So they don't need to take all the boosters that they are expecting to take, because the procedure finishes in a much shorter duration. So I agree.
Battery problems then are probably much less. So
and all the problems are improving, and you're right. It's a work in development, and already I think it's in a much better place compared to how it used to be a few years ago, and hopefully even better in the future.
Terrific. Well, on that positive note, we're going to transition now to inflammatory bowel disease. and we're going to hear from my colleague Rosa Vega talking about IBD surveillance. Rosa, over to you.
Thank you, Ed. So let me just go one slide back. So what I would like to do in this very short presentation is to highlight the difficulties we have on IBD surveillance and see how we can all speak the same language. So patients with inflammatory bowel disease, we know they are at higher risk of developing colorectal cancer, and in fact they account for up to 10% of all deaths related to inflammatory bowel disease. And we know that the risk factors of colorectal cancer are due to the duration of the disease, the prolonged active inflammation burden. Patients that have a first-degree relative with a sporadic colorectal cancer that was diagnosed before the age of 50, they are also on a higher risk of developing cancer. Obviously, patients with primary sclerosing cholangitis, that they all come very often to our list to be surveyed on yearly basis, and patients with colonic stricture or dysplasia in biopsies 5 years prior to the diagnosis of the cancer. The natural history and prognosis of low-grade dysplasia, though, remains uncertain, and management options vary, and as we become better on interventional endoscopy, there are also endoscopic treatments that can be offered to these patients, but they are always challenging. So the aim of these few slides would be to have an overview in terminology when reporting dysplasia in colonoscopy surveillance, because we all need to speak the same language in order to understand the case that we are facing. And I think the ESENIC International Consensus in 2015 really brought this common language into a nice description. Also, how do we manage IBD dysplasia and have a bit of overview of an easy algorithm. And then I would like to introduce the UC Care tool that it's been designed and validated here in the UK by a couple of centers to help communicate to these patients the management strategy that we are proposing. First of all, probably for people that have been doing this type of surveillance for a very long time, we all probably remember when we were having our discussions with pathologists about the terms like DALM, this plastic-associated lesion or mass, or adenoma-like mass, or non-adenoma-like, and they were concepts that we were using in relation to IBD surveillance. And with the ESENIC consensus, all this terminology has been put in the archive cupboard. And this is the new terminology that we would need to use when we are reporting our screening IBD colonoscopies. That's been designed with the help that we are using high-definition endoscopy platforms that probably help us to have a better look on the mucosa that we are assessing. And the need of uniformity in communication is crucial because we are going to be referring our patients to probably IBD expert colonoscopists to provide second opinions or treatments. So when they receive these referrals, it's crucial to understand what we are doing. So the terminology described in the ESENIC consensus is a Paris classification adaptation. And in essence, you divide the dysplasia into visible dysplasia and invisible dysplasia. And I'm going to start by the bottom of the table. So invisible dysplasia is any dysplasia that has been identified in random biopsies, and it comes as a surprise that we didn't see anything, and all of a sudden the histology shows that. If we are talking of visible dysplasia, as it says, is we see something that is not quite right, and then we will describe it between being either polypoid or non-polypoid. If it's polypoid, we will describe it as a pedunculated or sessile, and then non-polypoid will be either superficial, elevated, flat, or depressed. As you can see, quite similar to the Paris classification. Other general description terms that are very important in order to see the aggressivity of these lesions is to describe if they have an ulceration or if the borders are distinctive or indistinctive, because as we know, indistinctive borders, they are very commonly found in patients with IBD that have dysplasia associated to it. And all that, it's going to give us a bit of a clue if there is a role for endoscopically resection of these lesions. We know that if the lesions have distinctive margins, if they don't have ulceration, and if the access is easy, perhaps we should attempt to remove them endoscopically. And they are usually removed completely under direct visualization. It is very important always to go back to the resection area once we completed the excision and make sure we don't leave any suspicious areas behind. So doing a good wide field called snare or using soft tip coagulation is important to prevent recurrence and make sure we have treated the lesion completely. And then obviously it's important to have the histology confirmation that is a non-aggressive lesion, and also taking biopsies from the margin free of dysplasia are very helpful for our pathologists. Just a couple of examples. For instance, here we have 3 pictures, and the picture at the top of the slide, we would describe it as a visible dysplasia because we can see it at sort of going between 10 to 1 o'clock on the slide. If we use the slide as if it was a clock, is non-polypoid and it has indistinctive margins. Obviously you don't see the NBI here, that would help, but it's a lesion that you have to be a bit suspicious that probably has either low-grade dysplasia, high-grade dysplasia, and difficult to characterize the full extension. This lesion was removed and you have the histology results. The lesion at the bottom, again, is visible dysplasia. That one is polypoid, and the margins are more distinctive. So it was removed endoscopically, and the histology probed a small focus of high-grade dysplasia within the context of overall low-grade dysplasia. Here is another lesion, and I'll give you a couple of seconds to put your thoughts together. So this lesion was non-polypoid and had indistinctive margins, so very difficult to know where the lesion finishes and the normal mucosa begins despite the absence of inflammation. And the histology from biopsies taken had proven low-grade dysplasia. And this lesion, again, I'm giving you a couple of seconds to think, is it aggressive or not? Should I attempt to remove it on the surveillance screen? And apart from being non-polypoid and with indistinctive margins, a clue aspect of this lesion is that it's ulcerated, and in fact was high-grade dysplasia in biopsies, and the patient had a colectomy and was proven to have an invasive cancer on the colectomy specimen. So what is the strategy plan for these lesions when we see them? When we find invisible dysplasia, so in a sense is biopsies that we have taken, we haven't documented any visualization of abnormalities, and they come back showing dysplasia. If it's low-grade dysplasia, perhaps if we are not IBD endoscopists, we should consider for an IBD endoscopist to have a second look to make sure that this dysplasia is not visible. And if that's not the case and it's low-grade dysplasia, probably the strategy would be close surveillance and bring back the patient in 6 months' time to ensure that A, we haven't missed the lesion, and secondly, there is nothing evolving a bit more rapidly. If we have high-grade dysplasia, again, you would refer it to an IBD endoscopist, and perhaps you would be considering, depend on the findings, to propose the patient to have a colectomy, which is always a very difficult conversation. Invisible dysplasia means we have seen the lesions. If it's polypoid and it's easy to resect and is less than 2 centimeters and we think we can clear it completely, probably the endoscopic removal would be the way forward. If it's a non-polypoid lesion, and is larger than 2 centimeters, considering a tertiary referral where the colonoscopist is confident on either large field EMR, ESD, or hybrid ESD, should be considered. But one thing I would like to just spend a couple of minutes is of how we communicate that to the patients. Having been in the IBD clinic and seeing these patients very often, and sometimes having the difficult conversation of perhaps proposing colectomy, in very often patients that have no symptoms and have quiescent disease is proving a bit of a task, because it's quite difficult for them to understand. So that's the reason why between St. Mark's Hospital, UCH, and other centers, we designed, especially all led by Keith Curtis and Misha Kabir, an ulcerative colitis cancer risk estimator. And the usefulness of that is that it's a very novel patient-friendly cancer predictor, and it's accessible to everybody if you type the web page that is in the slide. Basically, it was designed after a very extensive analysis of risk factors and outcomes of 172 patients that had a diagnosis at the point in time in their natural history of the disease of ulcerative colitis and low-grade dysplasia. And what it provides is the patient predicted cumulative high-grade dysplasia and cancer risk given in year time follow-up up to 10 years, and also on a visual pulling chart of 100 patients. Once you type the web page, it will ask you to introduce a bit of information that is quite quick. So basically, it's going to ask you if you can see a large visible low-grade dysplasia lesion, so if it's more than 1 centimeter, if the patient has moderate or severe active disease in the histological biopsies that you have done. It will also ask you if the low-grade dysplasia lesions are multifocal, and also to see if when you resected the low-grade dysplasia lesion, providing that it was unifocal and small and you did the resection, if it was completely resected or not. So you type these few parameters that takes literally 2 minutes, and what you get is these 2 nice graphs that are very patient-friendly and they can understand the risk. So for instance, in the previous example that I entered the data, I can explain the patient that the risk of developing high-grade dysplasia and or colorectal cancer in a year time is only 1.4%, and the risk of developing it at 5 years it's 6.8, and at 10 years 13.1. And then this sort of a pulling graph as well give them the visualization of how many patients with the similar characteristics would have developed high-grade dysplasia in 1, 5 or 10 years with different color coding, and I find it very useful. Thank you very much, and over to the studio.
Great, thank you, Rosa, for an excellent summary of how to do it and what the data is. So we're going to go to a clinical case now, and this is a patient who I was responsible for doing their colonoscopy on. So he's a 66-year-old gentleman and was given a diagnosis of pan-ulcerative colitis back in 2002. Initially treated with 5-ASAs and azathioprine, but latterly he's been through both vedolizumab and currently adalimumab. And he was noted to have villiform change in 2018 and cellular atypia in 2021. And so this, for me, is a fairly typical patient on my list, quite high risk. We use an Olympus 1500 colonoscope again with the X1 processor and again a water jet. And what we want to achieve with this case is to understand how to perform virtual chrome endoscopy surveillance, appreciate the difficulties in dysplasia identification in inflammatory bowel disease, and to understand the importance of villiform change. And I've got 4 short videos, and I thought I could go through the panel and just ask them to help me out. This is something I find very challenging myself. So Roland, if you're still on the line, just to warn you, I'm going to be directing the first case at you, and you tell me what you think and what you would do, and then we can go through each clip as we go. So could we try the first clip, please? So we're at the hepatic flexure in this IBD surveillance case, and we can see a sort of villous lesion there, pretty small, probably about 3 millimeters in size. We've just got it underwater there. You can see the views we're getting under MBI and near focus, and it's demonstrated very well with surrounding looking normal mucosa. So, Roland, are you still with us? Is that something you'd like to comment on?
I'm still with you.
Brilliant.
Yeah. Hi. So, so my feed is not brilliant, so it's a little bit not perfect.
John will help you out if you need it.
Yeah, but it looked like a discrete lesion, and if it was a discrete lesion, I would lift, excise with a good margin, and biopsy the area all around it.
Okay. Everyone in the studio happy with that was likely dysplasia and needs to come out? Yep. People are nodding. Great. Fantastic. I hadn't planned on telling you the answers histologically, but I guess just to confirm what Rosa was talking about, that did indeed come back as showing that it was a visible dysplastic lesion in the setting of colitis. Okay, we'll run the next clip, please. And maybe so we're at the hepatic flexure in this IBD surveillance case, and we can see a sort of villous lesion-looking mucosa. Okay, just clearing some blood out of the way here as we approach the sigmoid. It does interfere with the MBI, and there's probably just a subtle patch here where there might be, in my opinion, just a bit of villous change towards the centre of the screen there. So just going to do some biopsies on that. Okay, finally we're just coming in. Pause there. So we actually skipped one of the clips, but Evelyn, did you see there was a small patch there of, there looked to me like normal surrounding anatomy, and then that slightly sort of swirly appearance that I would associate with villiform change. Is that something you would recognise?
Yes, but I wasn't sure whether the surroundings were really normal.
Okay.
I would have liked to see it a bit more, but yes.
Okay. And I think what this tells us is it can be quite hard. Are you using virtual chromo endoscopy completely, or do you ever use dye? Or
yes, we do. Officially in our unit, still we use dye spray for IBD surveillance, especially for the fellows working with supervisors. Although we now have data, but not definite data, I think that in expert hands, and that's what we also say in the ESG guideline, virtual chromo might be as good.
Yeah.
But that's still, I think, a debate to be made.
That's interesting, and we've made the switch here. But John, what about you? Are you still using dye or virtual?
I think we use both, Ed. I think there are several factors. I think the quality of the technology is improving dramatically. So the optics at the far end, the ability to have digital enhancement without fading any of the image quality, also very powerful. If you've got near focus, it's also very good. And then you've got the experience of the endoscopist. I think for these lesions, they can be very difficult, they can be very indistinct, and I think if you're unsure, being able to also then add dye in a normal white light environment may actually delineate a lesion which you may have picked up using MBI, and I don't think it's an either or. I think you use the tools in the box that you need to find the lesion really, and it can be exceedingly challenging. I
think all of that's true. We've got the second clip back now actually, so John, this one is for you. Okay, so we're coming back from the hepatic now, we're just cleaning up. You can see the whole thing's being done under MBI, just washing some blood away there. And we've got a sort of disturbance in the pits here. There's areas of sort of what looks like a sort of absent pit pattern, and then these long, slightly geographic tongues of slightly villous looking mucosa. Thoughts? Is that all post-inflammatory or could it be neoplastic?
I think it could be neoplastic. I mean, the issues you've got are the very people who are at risk are also the most difficult people to assess. So if you've got active ongoing inflammation, they're much more likely to develop dysplasia. But actually, to do this properly, you really need the background mucosa quiescent, and that's not always possible. So then you're in a clinical dilemma: is do you go for a localized resection, or do you say really you need a colectomy? And I think you have to be cognizant of the fact that colectomy is cure for these people. It's a traumatic thing because you're not preserving their organ, but it ultimately cures the patient. But the risk of you doing endoscopic surveillance is you've, one, got to be very good at it, and two, you've got to be hyper vigilant. And in something like that, the technical aspects of that involve, firstly, mapping the correct area, which we've just alluded to is not that easy. And secondly, the underlying fibrosis makes the technical resection very difficult.
Yeah.
And you know, you don't want to make, like everything in life, you don't want to make the situation worse. So I think you would approach that with caution. I agree with Rosa's assessment. You need to go to a tertiary referral centre, but I think the options need to be made very clear to the individual. You know, their choices will have impact down the line. You know, one's a cure, one's really high vigilant maintenance surveillance, probably, you know, for lifelong. For, you know, it's a big undertaking.
Yeah.
Yeah, and the control of inflammation is a very good point, and the fact that this patient had rattled through a couple of biologics relatively quickly once the villiform change was identified was for exactly that reason. You need to get stamp on the inflammatory control so you can then appreciate any dysplasia that's developing. Sure. Absolutely. So we'll go to the final video now.
This
so this is in the rectum now.
Atypia before, and we can see on the left-hand side there, just rotating it through now to 6 o'clock. This to me looks like fairly evident villiform change. You can see there's a sort of three-dimensional quality to it, like you'd imagine a villi in the TI would look, and these structures are sometimes hard to spot, but here they look fairly distinct to me. You can see the surrounding mucosa looks relatively normal and uninflamed. There's no discrete lump, I should say. There's no polyp for me to try and tackle. This all just looks like mucosal change, which is concerning for me for dysplasia. And we're just going to come back now towards the anal verge, just as we're coming out, and here you can see some more villiform change there, which is perhaps a little bit more evident there, just on the border with the squamous mucosa.
Okay, so Roland, if I'm going to be, I might still be unfair going to you, but were you able to see the for me, of the 4 clips, the most obvious sort of villus change? Were you able to make that out?
Absolutely, it was very clear there, Ed, thank you. So that would be sort of very concerning, and I wouldn't attempt to do anything with that myself on that day. I think the question I would put to my colleagues is, would they biopsy that before referring it on? And I think whatever happens to that rectum, that needs an MDT discussion about what the strategy should be. Because I think you can start trying to treat something like that, particularly on the anal margin, and get into trouble very quickly.
Okay, John, you're a colleague.
I'm not a fan of biopsies unless they think there's cancer, really. I just think there's no point. It's clearly abnormal. It will have dysplasia in it. The decision is whether it comes out or it doesn't come out, and if it's coming out, by what technique. I think if there's an area of depression or ulceration or disruption of the pits or lack of pits, and you've got a concern for a cancer, I think that would be an indication to biopsy at will, really. But I think the risk of biopsy is you wait for the result to come back before you make any decisions. Well, I don't think you need to do that here. I think you just need to have the discussion with the patient in the context of disease, extent of disease, personal wishes, and expertise available to take that on or not. That would be for me anyway. So.
Okay.
Yes,
same
I
approach?
totally agree. If the dysplasia is evident, I don't see any reason doing so. Especially not here, because I think the location is extremely challenging for radical resection without operation. Even for operation, if it's because it's going so low, it was really at the dentate line.
Yeah.
Even then, you should discuss with the surgeon how to remove really radically that lesion. So
Yeah, this guy's not getting a pouch, is he?
No, although
No.
if you are doing a resection, this is perfect for a mucosectomy. So whether that is an ASD or a TEMS mucosectomy,
Yeah.
and probably ASD is better because you can separating the dentate line with adequate lignocaine. ASD is perfect. It bleeds a lot, but it's a perfect technique for this.
Yeah.
Yeah, but on the other hand, if it's so difficult to be able to delineate, I think that's going to be very challenging as well.
Yeah. No, I think he's looking at a surgical option at some point.
Yeah.
Thank you very much. We're going to leave that there now. That was excellent. Thank you. And thank you, Roland, for joining us. And we're going to go to the third and final part of the colorectal discussion now on resection. Thank you.
Welcome back. So here we are in our last session of the colon symposia. And let me introduce you to a new member of the faculty that just joined in. So Amin Aji, consultant surgeon at King's College. Thank you very much for joining. It's a real honor that you are here. And Professor Brian Saunders, he joined us in the very first session from St. Mark's Hospital, and Professor Helmut Messmann from Augsburg as well. So in this session, we are gonna focus a little bit more on resection of advanced and complex polyps, and hopefully towards the end of it, we will have a good overview of how we can manage that. But first of all, I will hand over to John Anderson, that is going to give us all his insights on using the diathermy machine. That is very important when we are tackling very large polyps.
Okay, thank you, Rosa. Always said that a good workman never blames his tools, and this is a critical piece of equipment if we're doing hot snaring or you're using ASD or something similar. So I'm going to cover some really basic stuff so you understand the equipment you're using and not simply putting your foot on the pedal. I haven't got any disclosures. What you've got on screen is the old Irby Vio 2, and things have moved on since then. So we've got a new Irby, but fortunately for you guys, we've still got on one side a yellow pedal and on the other side a blue pedal, and we've got some settings. And what do these settings do? Well, in essence, what you're doing is you're converting energy, electrical energy, into a force that enables you to dissect through tissue. And you can either on the right-hand side cook the tissue, and that cooking of the tissue occurs relatively slowly and it allows you to occlude the vasculature, and effectively you are coagulating and sealing vessels, preventing bleeding. Or you have a rapid rise in temperature and you cut through the tissue, you effectively vaporize the tissue and you use that as a cut section. And I'm going to go through the physics behind that and some of the principles behind that. So when you come to put your foot on the pedal, you know what to expect from putting your foot on the pedal. But in essence, the left-hand side is vaporization and cutting, and the right-hand side is desiccation and coagulation of tissue to enable you to stop the bleeding. So some diathermy basics. Essentially what you're looking at is current density, which is the concentration of electrical energy at the point that you're using. So you've got current flowing through, and where you get the current, you get the snare around, and you tighten around the snare, you get a heating effect, a localized heating effect at that point. And that's where you get increased current density. And that's an important principle you need to bear in mind. Now, if you put your foot on the pedal, several things can affect the outcome on the tissue, and they're on the screen there. But in essence, what we really look at are three things, which is the power setting which you've set, the time at which you apply that power, and the tissue area that's contained. And the tissue area becomes really important. So what you'll see is the machine will do exactly what it says on the tin, but the variables really are how much tissue you've gathered, and to an extent how you actually manipulate your instrument. So your technique being used, so do you squeeze through fast or do you squeeze through slowly? Because they will have different effects in the tissue. Do you shake as you cut through, or do you not shake as you cut through? They're all going to have an effect on the tissue outcome. But in essence, the three things you want to look at are the power, the time, and the tissue area you have got together. But as I say, the current density is the key thing. So if you're looking for you guys doing basic EMR, one of the things you want to think about is how much tissue you've got in your snare. And I know there's a difference of opinion. Some people like to hold them snare and some people don't. What we like to do is mark the snare, and then we're very sure how much tissue you have within that mark. So let's talk about the blue pedal. It's the coagulation pedal, and you'll see on, as well as setting the level of the energy that you're delivering, you can also increase the effect. And what the increased effect does is it increases the depth of the coagulation and the area affected. So the higher the effect, the increased depth of coagulation you get. And you've got a lot of choices on these new machines. The Vio 3, you've got lots of different modalities, but I think the majority of you will be using these two. Either forced coagulation, and that's really for resection of your pedunculated lesion, or soft coagulation, which we often use for marking the edges or treating the edges of the rim of a piecemeal AMR, and can also be used for coagulation within the field itself if there's any bleeding. I think if you go to advanced therapies and you're using ASD, you're going to use a lot more of the settings further down, but for the majority of people, we'll be sitting with these two settings. So for a peduncular lesion, you want to use the blue pedal, and I call it what I call as a slow cook. And you want to set it for maybe 25 watts, and you want to close through in a slow controlled fashion to allow that snare to seal the vessel which sits and runs through the center of that stalk. I've seen people use the blue pedal and then they switch to the yellow pedal to do the final cut. That is completely illogical because the vessel sits in the middle, and that's the thing you want to see with the blue pedal. So you need to combine a shearing force, which is the mechanical action of the snare, combined with the electrical energy of the coagulation to ensure that firstly you seal the vessel, but also you transect through the stalk. And if you remember my previous slide, on that list of you heating the tissue is carbonization. If you don't have sufficient current density because your snare isn't tight enough, what happens is you heat the tissue up and it carbonizes. And you know carbon is a poor conductor, and that's when you're trying to close the snare and the nurse will say the snare is closed, and of course the polyp hasn't fallen off. And the reason is you've carbonized the snare, and you're in a difficult situation there because it's very difficult to uncarbonize something without taking it off. And often it's stuck to the tissue at that time. So you do need to have a coordinated team approach where you have the correct setting, you have the correct amount of tissue in, and you apply the correct current. Just try my slide. And the yellow pedal, you need to think about the cut pedal. Now, the thing about the cut pedal is it's a jolly clever piece of kit. It has the modern processors have fantastic data cycles with feedback, which detect really tissue resistance and what's happening at the front end to ensure that you get a perfect cut. And you can still adjust this. You can increase the effect, and what the effect does is it introduces a coagulation cycle into the cutting. So as you go from being pure cut effect 1, and as you increase it to 2 and 3 and 4, you increase the coagulation. In addition, you can adjust the duration of the cutting interval itself and the frequency of which that occurs. So there are lots of ways you can adjust the setting, but most people who are going to use a cut setting are going to use Endocut Q, and you probably will have a coagulation added to that, so you'll have an effect 2 or effect 4. And the clever thing about this is it doesn't really matter what number you dial up. It does to a bit, but the machine will actually detect the resistance and only deliver the energy that you actually require. So it's rare that you reach the limit of the setting that you've put in, certainly for doing EMR. I think for ESD you need to be a little bit more precise because it functions in a slightly different way. But for your EMR work, if you get use the yellow pedal and you have some added coagulation, you will get a nice clean cut. And we use this for more sessile lesions and for lateral spreading tumours. And the graphic at the bottom shows that the blood supply to these is thin perforating vessels. And you can cut through those really, really quickly. And what you want here is you don't need to seal those vessels because they're so small. The action of the diathermy will do that for you. What you're interested in is preventing a deep mucosal injury, which leads to a delayed perforation. So here we don't want to seal vessels. We want to cut through things really quickly. And hence we use the yellow pedal. And as an extra safety measure, we would then put a lift in, which does two things. Firstly, it helps the snare find the plane in the submucosa, but also gives you that safety buffer of allowing the heat to dissipate to prevent thermal injury to the muscle layer down below it. And a typical setting for this would be using it in a VIO2 would be maybe 100 or even up to 150, with your blue setting at 20 or 25, and as I say, you use effect 2 or 3 and you'll get a nice cut. And the effect that you see will be a little bit dependent on how quickly you close the snare, but also which snare you use and how stiff it is and how thick the braids are. And I think it's really important you're familiar with your settings and your snare. And if you change something, you either upgrade to a new VIO 3 or you change your snare, you need to make sure that you're getting the same effect using similar settings if you change anything. Just a couple of points of interest. Why does the patient not get a shock? So when you're using a monopolar probe, what happens is the conduction goes down the accessory, in this case the snare, through the patient's body and out onto the plate. And the thing is, it's a high frequency alternating current, so they don't get shocked. And actually the current density is at the point where the snare is around the tissue. That's where the current density is high. As it flows through the body, the current density is very low, so there's very little effect in the rest of the body. So it's a completely safe thing for the patient unless the pad isn't on properly. And I'll just bear in mind that people worry about hip replacements and metalwork within the body. Actually, that's never going to heat up with the amount of energy we use. So rather than asking the patient which hip they've had replaced and which knee they've had replaced, just make sure that the patient plate is attached properly to the skin, because that will make it safe, not where the hip replacement's been. You can take that out of your questionnaire. It's a misconception. And the other thing I want to talk about is internal devices which will have an effect, and we talk about pacemakers or any form of stimulators. And the thing is, the conduction of the electricity isn't really going to damage this, but it can force the thing to trigger or malfunction. And obviously, if you've got a defibrillating pacemaker, what you don't want to do is be halfway through your polypectomy and then shock the patient when they don't need a shock. Equally, if you've got something like a spinal or a brain stimulator in, you don't want to damage that piece of equipment because it's very difficult to then go and replace it if that is the case. So just coming to the end here, just some take-home messages about this. If you've got a pacemaker in, you need to confirm the type of device. Because if it is a defibrillating pacemaker, you need to have it switched off. If it's a pacemaker for rhythm, you move it to a forced asynchronous mode, so you just get the pacemaker to go all the time, so it's not affected by the diathermy. And as I say, if you've got something in situ, you want to try and put the patient plate a little bit away from the device to sort of draw the current away from where the electrode is. And in terms of during the procedure, you would obviously need ECG monitoring, and normally you would liaise with your technicians to have the magnet there to switch the pacemaker on or off. One more slide. Oops, go back one. Just go back one there. So my take-home messages are this. You need to understand your diathermy. It's not fair to expect the company to set it up and set the right settings and then for you to just put your foot on the pedal. And I know that's what a lot of you do. I think you need to understand the basics of what you're doing. The critical thing really is coaptation and current density, and they're critical to the effect that you see in the diathermy. And if it's not what you expect, you need to check what you're doing, the attachments and the settings. And in general, flat things, you slice off cold or hot, and we cut those off. For pedunculated things, we want to coagulate them because that's what causes the bleeding. And my take-home message is this. If you apply the right diathermy, it stops the bleeding and will prevent delayed perforation. If you put your snare in the wrong place, you can still cause a perforation. But if you do the technique properly, it should stop bleeding and prevent perforation. And then you move away from the pre-treatment, post-treatment of all the problems because you got the diathermy right. And of course, if it bleeds, that's another talk, and I'm only allowed 8 slides. Thank you.
Thank you very much, John, and sorry we only allowed you 8 slides, but I think you did a brilliant job on summarizing the diathermy around polypectomy. So we are going to introduce the next case. It's a patient that came through the bowel cancer screening program with a FIT test positive and had bleeding per rectum. The equipment that we will use is the 290 video colonoscope from Olympus, the navigation system from Olympus, the water irrigation from Pentax, injection needles of 25G from Pentax, and the Captivator 2 single user snare of 25 millimeters from Boston, and also the resolution clip 360 from Boston. And in terms of learning outcomes, understand how to approach large pedunculated polyps, optimize water immersion for pedunculated polyps in sigmoid colon, and consider post-polypectomy strategies to avoid delayed bleeding. So please go with the case.
The two of them. I'm just gonna clean the water a little bit, exchange it for water with no fecal residue, and try to withdraw with a water immersion. What I'm stealing as I am coming back, because what I want is to avoid the loop in the sigmoid colon. So you see I'm just exchanging water. There are other small diminutive polyps that will need to be removed. We are going to deal with the large polyps today. And when the patient comes for a 6 months follow-up, then we will... right, so that's the large polyp. Probably the stop is originating around 10 o'clock. So I'm going to try to, with clockwise torque, bring it to 6 o'clock, and then use the water. Use water, rather than air to remove it. And have it here. So it's quite a thick stop. But we have it in a good position. So I'm going to inject, and I want to inject very slowly. Needle up and injecting. Keep injecting, needle back, cut. And inject it here, needle out. Inject, needle back, cut. Okay. Just give me the 25 millimeters captivated nail.
Yes.
So again, I'm going to the proximal side of the polyp. Now, because I'm gonna tackle the head of the polyp, I want the head of the polyp to be at 6 o'clock. And again, I'm just removing the air and filling it with water, because that helps first with comfort, with stability, and also the polyp floats a bit and it goes into the snare much better. So open the snare for me, and I'm pulling the snare back and I have it open inside the channel. Now I'm going to negotiate the polyp head with the snare, just with gentle maneuvers, making sure, using the water, that the polyp head is being pushed away. Now I'm dragging the colonoscope down and just close the snare ever so slightly. I like to do it myself, so I'm gonna bit of water, and because it's quite a thick stalk, now I'm gonna use the air to make myself a bit of room, and I'll use first a bit of coagulation, and now the effect tool, and the polyp is out. Good. And now I'll just place a clip. Let me review the site. With a bit of air. Give me the clip before we move. So that's the third side, and I'm putting a clip open, just trying not to clip the polyp in it. That will be it. Okay, so fully open, yeah. Close. Yeah, be closed. And oops. You need to open, yeah? Have you opened? Okay. Give me another plate. Remember to open. Yeah. Right, open. Just open it. That's it. And just move a bit to 93 if you can. Yeah, just put it like that. Yeah. Close. Open. And close. Open. And close. Yes.
Right, so large pedunculated polyp. Amin, I'm going to ask you a question first. What is your approach with these large pedunculated polyps in the sigmoid colon? Because always it's in a very difficult position, usually difficult to access. Do you inject the stalk? You don't inject the stalk? There's not a lot of data either or. What is your practice in order to make it easier but also avoid maybe bleeding during the dissection? What do you do?
Yeah, I think, Rose, that was a great demonstration of good technique. And I think the steps in that technique, just to portray to the audience, were very much, injection of the stalk, which is what I would do. When you open your snare, actually dragging your colonoscope back, so you're making sure you don't ski up with your snare and take the head of the polyp, so you ensure you're completely around the stalk of the polyp, and then using coagulation as you did, to resect it and to close with clips. I think it depends on the position. Sometimes it can be quite tricky and it can be quite unstable. So what's important is to try and identify if there is bleeding, severe bleeding, can you get access to that same point? And I would encourage people to turn the patient regularly to make sure that you've got access to areas if there is severe bleeding. Because if there is and you haven't got access and it's unstable scope, that makes things extremely difficult. So do think about what complications could occur before embarking and pressing your pedals, so that you can be very clear. And sometimes when you have a very large stalk, it may not be possible with access with the snare, and you may need to use a knife to actually resect that in a more safe manner. But I think your approach was very good, and it's my preferred approach if the scope is stable and we're able to get the snare around the stalk.
Good. And Helmut, to you. Once the polyp has been resected, do you do anything to prevent bleeding, providing that it's been a very dry cut, you don't see any bleeding at all? Are you happy to leave the stalk alone, or?
I agree with, I would do it in the same way. So I would inject the stalk, resect, and then clip the remaining.
Clip the remaining stalk.
I would clip it, but the data are not very good. There are no big randomized trials to my knowledge. We update now the ESG guidelines, and in these guidelines we recommend for stalks larger than 1 centimeter to do a prophylactic injection or a loop, or if the polyp head is larger than 2 centimeters to do something prophylactic. But as said, data are not so convincing. And
so you mean prophylactically treat the stalk before doing the resection? And
then or after, both is possible.
Is that sometimes I find that doing prophylactic treatment of the stalk prior to the resection, it makes the resection a little bit tricky as well, especially if whatever prophylactic method you use, you don't leave enough distance between either the clip or the loop and the head of the polyp, and then you are trying to negotiate with the snare. It can be a little bit tricky.
That's true. I don't use clips. Looping is sometimes also a bit tricky. And I would change the position to get really an impression how big is the stalk, how long is the stalk, use gravity to see the whole polyp, the whole stalk, and then get in a position where you can use your snare and resect.
And do you do it underwater in pedunculated polyps? No. Because one thing I have found is that obviously when we are in the sigmoid colon, it's a bit of fiddly, we are spending a bit of time, the visualization is not good, and you keep insufflating CO2, which distends the patient. Obviously a patient here in the UK, they are on conscious sedation, they can become uncomfortable, and then you need to rush through the polypectomy. And since I am using a bit of water immersion to keep the colon distended while I'm working and injecting, makes the patient to tolerate the whole polypectomy a little bit better, so you don't have to rush at the end because they feel a bit uncomfortable. Brian, any tips?
Yeah, I think the first thing always is patient safety, and these big stalk polyps are often in the sigmoid. It may be in diverticular disease. Your access may be difficult. Sometimes if a patient's uncomfortable and restless, that's a big problem, and you may be better actually deferring that resection, bringing them back on a propofol list when they can be adequately sedated. Amin alluded to the fact that the key thing is to maintain endoscopic visualization and access onto the point of cut. So you don't want to over-inject the stalk, because sometimes that can reduce your visibility. I don't like endoloops. I don't use endoloops. I find they get in the way and they make the procedure more difficult. But I've actually slightly changed my practice now for these very big stalk polyps. I now do an ESD. I don't do a snare excision, because I'm worried about that immediate bleeding, which you can unpredictably and sometimes get. With an ESD approach, particularly if you use something like the SB knife, you can coagulate, cut, and sequentially work your way through the stalk, coagulating the vessels as you go. It takes longer than snaring, but I think it's a bit more controlled. And I also like to have a plastic cap at the tip, because the plastic cap allows you to manipulate the stalk, and if you do get bleeding or you're having problems visualizing the line of cut, you can use that for tamponade.
That's very, very good tips. Right, so now I would like to hand over to Aminaji, who is going to give us a bit of an overview of how to assess large laterally spread lesions in preparation of what we should do in terms of management. So Amin, over to you.
Thank you very much, Rosa. So just first of all, really thanks to the organising committee for inviting me. I'm just going to take you through in the next 8 minutes, our assessment of these large non-pedunculated polyps and how we would assess and plan the resection strategy. So you know that the options for resection, often are either piecemeal resection or en-bloc resection with ESD, or indeed full thickness resection or laparoscopic surgery. And often I find that decisions are made on local expertise rather than actually on endoscopic diagnosis. So it's important that we make an accurate endoscopic diagnosis prior to actually embarking on any treatment algorithm. And of course, we need to assess our patients thoroughly using white light, ensuring that we've changed the position of the patient, having adequate insufflation and deflation, and then detecting areas that could be of concern, and of course, understanding the classifications so then you can guide your resection strategy. We have actually looked at this in the past, and what we've shown is that multimodal assessment with thorough endoscopic diagnosis and magnification endoscopy is much more accurate than using some of the other modalities such as histology and MR or CT. So endoscopic diagnosis really is the key. And the way we would do this really is using pit pattern and magnification endoscopy. This is images that you're very familiar with. This is using indigo carmine as dye spray and also crystal violet to try and identify areas of 5I pit and 5N pit, which are akin to either high-grade dysplasia or early or deep submucosal invasion. And equally, you can actually subdivide and look in a bit more detail of the 5 pit. This can be divided into irregular, which is 5I, or non-structured, which is 5N. And furthermore, we can subdivide the 5I pit into low grade and high grade. And this is where crystal violet becomes extremely important in our practice. Just go for the next slide. So this is 5I low grade, where we can see that actually it is irregular pit. But what I usually say is that when there's irregular pit, it is very regularly irregular. So if you look at the margins, when you have 5I pit, if the margins are fairly regular, then this is 5I low grade. And equally, if you've got 5I high grade, what you'll find is that the irregular pit, the margins of that area are very irregular. It's what you call a rough margin, and that is more akin to 5I high grade. And then, of course, there are 5N, which is non-structured pit, and you can't see any of the dye there in the crystal violet, and this is deep submucosal invasive cancer. So as you go from left to right, what you have is 5I low grade, which is high-grade dysplasia, 5I high grade, which is early submucosal invasion, and then 5N pit, which is deep submucosal invasive cancer. And what we use in our practice is JNET type 2A, looking at the vascular pattern. And the important aspect here is to identify areas of JNET type 2B, which is irregular caliber and irregular distribution of vessels. And then these areas require indigo carmine and crystal violet examination with chromoendoscopy to evaluate further. We've also been using in our practice endocytoscopy, and this is using 500 times zoom, which is using methylene blue and crystal violet, and you can see that this is very much akin to what we would see on histopathology. And you can see on the left there's very normal cells and hyperplastic on EC1, and then centrally you've got the very organized nuclei and the slits of the tubular adenomas, and on the right you've got more irregular and swollen and distorted nuclei, which are akin to either early submucosal or deep submucosal invasive cancer. Just going to go back, apologies. So here we're just going to, I'm really going to focus a little bit for the next few minutes about lateral spreading tumours, and these are the tumours that we often get referred for endoscopic resection. And you can see that as you go from top left to top right, you've changed in the actual morphology. So the top is LST granular, which is either homogeneous on the left, or on the right it's related to mixed nodular type. And then you've got LSTNG in the bottom slides, which are non-granular, and they can either be flat or pseudodepressed. And as you go from top left to top right, you increase the risk of submucosal invasive cancer and also increase the amount of submucosal invasive and more multifocal points. So this is our algorithm at King's. What we would do is magnification endoscopy and use spectral imaging as well, looking at Kudo-Pitt pattern and JNET pattern. And then we would identify if it is actually related to 5i pit, then actually those patients will go on to have en bloc resection. Let's take these in the context of the LSTs. If it was LSTG homogeneous type, then the risk of submucosal invasive cancer is very low, and therefore patients can often have piecemeal EMR. This is our data initially from when I was at Showa University. Take the next slide. This is the data from Showa University, and in fact it doesn't show on there, but what it does show actually of the LSTG homogeneous type is that there is a 0.8% risk of submucosal invasive cancer. And therefore patients can have EMR. If you've got LSTG mixed nodular type, then the risk of submucosal invasive cancer is between 8 and 19%, and therefore these patients would often require en bloc resection with ESD, ensuring that you resect not only the nodule but also the surrounding tissue, because in 14% of individuals the cancer is in the homogeneous type rather than directly below the nodule. What about patients that are LSTG non-granular type? And these patients have a much higher risk of cancer, up to 41% risk of submucosal invasive cancer, and therefore these patients will require en bloc resection. So just to summarize that, if you've got patients with 5i pit or LSTNG, they would have ESD en bloc. If you've got patients that would be LSTG mixed nodular type, then these patients will require en bloc resection in our practice now. And these patients often would require en bloc resection, and then you need collaboration with your pathologist to try and identify the areas of submucosal invasive cancer. And then finally, if you've got scarred areas, then these patients would often require knife-assisted or preferably endoscopic submucosal dissection, but your R0 rate is much more difficult. And then finally, if you've got LSTG homogeneous type, then these patients would go on to have piecemeal EMR, but then there's a caveat of thinking about your recurrence rate and what you do and deal with your recurrences. So in summary, really, I think, in our practice, certainly we've found that ESD is certainly increasing its presence, and we're using more en bloc resection to try and treat patients that have higher risk of invasive cancer. But I think decision making is absolutely crucial with accurate endoscopic diagnosis, and therefore having a defined strategy for resection for your patients. I thank you very much for your time.
Thank you very much. I mean, a very comprehensive overview of how we should be assessing these lesions, and moreover, very helpful in order to plan the mode of excision that we require. So we are going to present now a case of a large lesion removed with large field EMR. So it's an 83-year-old female diagnosed with a large hemicircumferential sickle lesion on a CT colonography, and the patient previously had a failed colonoscopy due to intolerance and was having early dementia, but was assessed in terms of mental capacity and had capacity to make decisions. So the aim of this video is to demonstrate this piecemeal large polyp removal and tricks to reduce the recurrence.
So this is a large prolific lateral spreading tumour in the right hand side of the colon. We're just going to start with the lift, having evaluated the lesion. Don't be afraid to inject through the lesion. That's completely safe so long as you're happy it's not too high grade. And we're doing this thing where we're tenting the lesion up with the lift, what we call dynamic lift, so that the lesion goes in the direction you intend. Put as much fluid in as you like. This is just a mixture of saline, adrenaline and dye. And you want, particularly on the right hand side of the colon, a bigger lift as possible because this is going to require a lot of energy. This is a Olympus 20mm snare master snare, and this has got the additional wire wrapped around it, which makes it a grippier snare. Got to be careful just as you pivot the snare that you don't perforate. The end is quite sharp. Now you can be too ambitious with the amount that you grab on your first bite. The first bite is always the most important for a piecemeal EMR. So I'm going to close up on this bit here now, and what I always do is I just relax the snare slightly, and that just lets any muscle drop. So we're relaxing and then we're tightening again, and that gives me the confidence. And we're going to cut now, and as we're cutting, I verbally let the nurse know how quickly I want to go through the tissue. So we're just going to simulate that on the next bite. So again, quite a big lump of tissue there going around the inferior aspect, and we're going to close up on that. And as we close, right, we're going to be happy the amount I've got, and I'm just going to relax. Just relax for me. That's good, that's good. And then just tighten, 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 tighten. And we're going to go through on 100, 200, 300, and that's cut, 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 please. That's very good. And it's through. And you always check the base, make sure that there's no perforation there. Bleeding we're less concerned about in a lesion this size, but obviously you can go through big vessels. So again, another big bite. We're going to relax the snare. We're going to open the snare slightly, just like that, and then we're going to close up again, and then we're going to go through again. And I'll tell the nurses 100, 200, 300, and then cut, cut, cuts, and we're all the way through. So you just proceed really in a bit by bit process. It's iterative. I'm looking now at the right hand side of the lesion, and this is going to need another lift because we've only lifted the left hand side. So I start injecting before I go in, and then I establish a plane, and then we blow it up, just coming back with the needle slightly to allow the lesion to come towards me. And then you try and go in a part of the tissue you've already lifted. It just makes it easier to find the plane. And again, big lift, we're putting in several mils at a time, and just satisfy yourself that you're generating a significant enough sandwich of lift. So when we're deploying the snare, we always go from normal tissue to abnormal, and in that way you avoid leaving behind mucosal islands, because they're always a nightmare in terms of increasing your risk of recurrence. So again, we're going to just relax the snare slightly before we start cutting. So we relax the snare and then we tighten again, and that allows muscle to drop down. And we're going to cut. And you just have to be patient. Clearly you don't want to be cutting too long because of the risk of post-polypectomy syndrome. And you can see as we're going through this, we're just taking it on a step-by-step basis, and pretty much we're very fortunate with this lesion. The polyp is really just falling into the snare, making it very straightforward to remove. Always important to know where gravity is when you're removing a big lesion like this. You can see that the bits are falling off to the left. If I was to get a significant bleed, then the blood will also fall off to the left, and that will allow me to treat whatever vessel it was that was bleeding. So always ensure that gravity isn't sat on the lesion, otherwise you'll find that you begin to struggle. So we're coming towards the end of the process now. You'll notice I've used the same snare throughout, and just as we begin to finish with the hot snare, I'm already planning with the team to switch to a cold snare once the final hot snaring is done. And we use a cold snare really for tidying up. So all the donkey work is done by the hot snare. Very happy with that. So now we're going to switch to a cold snare. So this is the Boston Scientific.
This is a Boston Scientific captivator snare.
And this just gives us much more precision. It's a nice snare. It's nice and stiff, and that allows me to apply pressure. And you'll see the technique. This is our rim of our lesion here. I'm on near focus so I can look for recurrence. And with the cold snare, you just work your way along the circumference of the lesion, and you just cut your way around it. And the idea is obviously that this is going to reduce your risk of recurrence. So again, you're just pushing in and cutting, and it's quite a quick process to do. And it's very important you do this around the circumference of the lesion, as well as obviously in the submucosal bed of the defect that you've generated. And that will give you reassurance that your risk of recurrence has been minimized. Again, it's just pushing down to allow the tissue to go in. You suck at the same time. That takes the tension off the wall and allows the polyp to come into the grasp of the snare. You can see quite a lot of effort there, just pushing down onto the lesion, but completely safe. You can never do any damage with a cold snare. You can use it on the mucosal bed as well. There's a bit of residual tissue here which is just stuck to the defect that I've generated, and it just takes a second just to clear with the cold snare. Once we've finished cold snaring, then it's just a question of tidying up with snare tip soft coag. So I asked my nursing team to switch to soft coag from forced coag, and you can see the snare tip out there now, and you try and hold it against the area that you're interested in, and you just need to apply enough energy with the blue pedal until you begin to see it fizz like that. That's it. Can be quite hard. You're obviously coping with respiratory artifact here, and you're just using a very precise form just to apply a little bit of energy to the defect bed. Anyway, you think there is pink viable tissue, or whether there could be cells left behind from your piecemeal resection. But we're coming to the end of the process now, and that all looks good.
Right, so that was a demonstration of a large field EMR, and sometimes I find that making the right decision is quite difficult, especially because you need to take into account the patient, and in this particular case it was an elderly patient that had symptoms, so probably needs to be treated, but it's difficult to judge which would be the better action to take that will cause less harm and will provide a bit of benefit to the patient. So Helmut, what have you had done with this lesion? And again, it's a bit difficult to say black or white what I would do.
It's still a matter of debate also in our country, doing now EMR, piecemeal EMR, or ESD. So this was a LST mixed type with a low risk of invasive cancer, probably. We do now a randomized trial, actually, for the colon, not for the rectum lesions. I mean, the rectum lesions are, I would say, in the majority, we will treat it with ESD, although the lateral spreading granular type lesion, because we have no recurrences. In this situation, I think we need data. The Japanese for sure would do a ESD. In Germany, majority wouldn't do a ESD, would do piecemeal EMR and then reduce the recurrence risk, and we discussed either with snare tip coagulation or with hybrid APC. This is also a good option to reduce the risk of recurrences.
Okay. And Brian, if you have to approach this lesion and you are planning to do a large field EMR, are you bringing the patient back? Are you allocating enough time? What do you do in terms of non-technical skills that will set the resection to a success?
Well, this patient was interesting from the history that you gave, and it's not uncommon. An 83-year-old with early dementia, she may have other comorbidities as well. I think it's very careful that we remember that we're treating patients, not polyps. And it's fine doing a technically brilliant polypectomy if it's in the patient's interests, and we always have to balance that. And the way you do that is by sitting down with the patient or the patient's relatives and discussing the options. And I often do this. I'll sit down, I say what the risks of this thing turning into a cancer and affecting her life is in the next 5 years, which actually in this situation is pretty low. It's probably, what do you think, 15% chance of it turning into a cancer? Compared to what is involved in an endoscopic resection, which is at least 2 further colonoscopies and bowel preparation. Elderly patients don't like bowel preparation, and the risk of a major polypectomy, the main one being delayed bleeding, which however well we mitigate, it still occurs, it's still a reality. So I think that's an important step, but if the decision is then made to go ahead and remove the polyp, I think you do whatever you feel is safest and quickest, but you must always aim on the first attempt to remove the polyp completely. So what Ed was describing in terms of carefully looking at the polyp and resecting the margins and making absolutely certain that you've removed the whole thing. Because the nightmare scenario here is that you don't fully remove the polyp, and then you put her through a polypectomy, and then recurrent procedures occurring, and you haven't sorted the problem out. Technically, I quite like doing a hybrid for these bigger lesions, using a knife to cut around the margins, so I know I've got a clear margin, and then snare resecting, knowing that you've got the clear margin. If you can't do that, and you do a conventional piecemeal EMR, then soft coagulation or argon plasma coagulation around the margin.
Okay. I mean, obviously you have a very big tertiary referral center that receives a lot of probably these lesions, and if we just concentrate in the lesion itself now, what do you value the most with the referrals in terms of having a good plan that it's going to work when you have the patient coming to you, that you don't need to then re-scope and re-evaluate? What you would say if I am referring a patient to you, what do you want me to do? Do you want me to take biopsies or not? How do you want me to describe and document?
I think that's a really important point, because I think in our practice about 55% of our patients would require re-scope and imaging prior to making a decision regarding treatment. So I think at the outset there are certain parameters that we should document, including good photo documentation of the polyp rather than taking biopsy. The first thing we need to think about is this endoscopically resectable or not, and if you feel it's endoscopically resectable and you're referring it on, then we would advise not to take biopsy and just refer with good photo documentation. Of course, we'd want the parameters in terms of access. What is the access like? What position is good for this patient? Are they tolerating it under sedation, or whether they would need further sort of propofol, etc., deeper sedation or general anesthesia, and the morphology of the polyp. We would want some description about the pit pattern and the spectral imaging. not everybody has magnification and full magnification endoscopy, but you can do that with careful imaging, even with near focus or with a closer look. So having those details and good photo documentation then gives us a much better idea of how to schedule and what time to schedule for these patients. Of course, if there are videos that can be sent, and we're working currently with some of our collaborators to see whether we can have our referrers have videos that can send and be streamed, can be sent to us to our platform. And if that's the case, then that gives us the best feel of what that polyp actually looks like and how we're going to remove it.
And what do you do, Helmut, in your practice in Augsburg in terms of when you receive these patients? Do you have a strategy or a pro forma? How do you want the other doctors to communicate with you so things can be planned and we avoid the scoping? That is quite an increased number, 55% you said, I mean, of patients that perhaps we need to re-scope again and is another procedure in between. Do you have any strategy?
Well, we have the same problems actually. I mean, we are also a huge referral center, so the majority of our patients are admitted with the question, can you resect this lesion? It was almost seen by a surgeon, and indication for surgery was clear, but it has shown also in published series that an expert center can avoid surgery if you have the experience. So in the majority, it makes sense to rescope this patient. Although we have images, the quality is not as good as I would expect. But I always say, don't touch these polyps. Some people resect the polyp partially and said, Dr. Messmann, I have resected this polyp at least 1/3, so you must be now quicker. I made some tattoos that you will find the lesion and did some clipping. So please don't touch. It works meanwhile, but in the past, in the history, there were awful treated polyps, partially treated polyps with tattooing and clipping. This makes life really hard and endoscopy resection almost impossible.
So basically we need to wash the colon, wash the polyp, high quality pictures, try to describe it with meaningful language and make sure that we don't touch it if we think it's endoscopically resectable, we don't tattoo it, so we don't go underneath a black forest when we are doing submucosal work.
I would agree if we have wonderful images, that's it. Or video clips, that would be the future.
Excellent.
I think the tattooing is a problem, isn't it? Because with the submucosal injection with saline, it does dissipate, towards the oral side of the lesion and often underneath. So actually, if it's a very big lesion, we're always going to see it. So probably no point even tattooing it unless you want to send for surgery, and that's a different issue. And if you are going to tattoo and you feel you really absolutely have to, be quite much on the anal side, between 5 and 10 centimeters.
Brian, talking about the lesion, so we have a good bed after we have removed the EMR. Do we do anything prophylactically to prevent bleeding? And there is a question from the audience asking if we would use any hemostatic powders or gels to prevent delay bleeding. What's your view on that?
Yeah, I think it's really important to emphasise that snaring off the polyp is just the beginning. Actually, the key bit of a good quality piecemeal EMR is examining the defect afterwards very, very carefully, going meticulously around the margins to see if there's any evidence of residual polyp and either avulsing or resnaring or ablating, and then finally the margin, ensuring that you've got a clear margin. So also looking for vessels. Are there any cut vessels? Because a cut vessel will often go into spasm and not bleed at the time of the procedure, but it may well bleed 2 hours later, particularly if you used adrenaline in your injection solution. So just making sure, do any additional areas need coagulation or clipping? And then, depending upon the shape and the size of the defect and the comorbidity of the patient, that will then determine whether I close the defect with clips or whether I apply something like Puristat, a nanogel. We don't entirely know whether it works or not, but it certainly makes you feel better as a.
Well, there is a randomized control trial happening at the moment that we have taken part that hopefully will bring the answer.
Good results in that. But clipping there is a good evidence base behind clipping, particularly in the right colon. And I'm particularly cautious if there's any area of exposed muscle or if there is any area of hematoma within the defect. In that situation, I would close with clips. You also have to be very careful around the appendix orifice, in the very apex of the cecum. That's a high-risk area for bleeding. So examining the defect, working out whether it's a high-risk defect for bleeding, putting it in the context, is the patient going back on anticoagulation, and then applying clips or Puristat, or a combination of the two. I will always put at least one clip on, simply because if the patient comes back with a bleed and they need interventional radiology, and it doesn't happen very often, but if you do enough, it will happen eventually. Then the radiologist has a good marker for where the resection has occurred.
Okay, that's very good tips and very good discussion about it. Now, as Amin alluded in his talk, there is room for endoscopic submucosal dissection in some of these lesions because of the risk of cancer. And now Professor Mesman is going to give us a bit of an update on the latest European Society of Gastrointestinal Endoscopy indications for endoscopic submucosal dissection. So over to you, Helmut.
Oops. For the invitation to be here in London live. Thank you, George. This is an excellent meeting, and I really appreciate to be here at UCL, where I have been as a fellow a couple of years ago. Now my task is now to speak about ESD in the colorectum. I was delighted that your meeting promoted ESGE days. The deadline for abstract was yesterday. I have good news and I have bad news. The good news, we have the highest number of abstracts ever, more than 1,000. The bad news, UK can do better. UK is not among the top 10. So number 1 is Italy, Spain, Portugal, Morocco. Germany is number 9, and I hope you have still 7 days left for ESGE members to increase the numbers. So please support ESGE. Now, let's start with my presentation. You have seen the slide meanwhile several times. Before you start treating a polyp, I think it's essential that you have a plan, that you know what technique is best ideal for this type of polyp. And usually the chainnet classification, I think, is the most ideal classification in my eyes, and it's also very often used in Japan to differentiate the different polyps. So ESD is for sure for the type 2B lesions ideal. The type 3 lesion, similar to NICE 3, is indication for surgery. There is no treatment necessary for hyperplastic polyps, and we can discuss about type 2A lesions. I would prefer to go for ESD in the rectum, and in the cecum, still piecemeal resection is the treatment of choice. This is the guideline of ESGE about the polyp management, published in 2017. It will be updated next year. And you saw today how to approach to pedunculated polyp. Those with a larger stalk, with a larger head of the polyp. Prevention obviously is sensible. If you have small polyps, we discussed this morning, up to 1 centimeter, cold snare resection is ideal. Polyps larger than 1 centimeter needs a special imaging technology, and then we should divide in those polyps with non-invasive cancer or suspicion of submucosal invasion, and those who have a suspicion for invasive cancer. And here is the place, as you see, for ESD. There are not large randomized trials. This is a study a couple of years ago from Japan comparing EMR and ESD, and the take-home message at that time was, okay, we can treat with ESD larger lesions. It takes 3 times more longer, in this series, 2/3 were cancer. The block resection is higher, the recurrence rate definitely lower, and at that time the perforation rate was also significantly high, which now goes down to almost the same number as for EMR, and also in bleedings there were no difference. Now this is the actual ESGE guideline on ESD. So we had a guideline now for upper, for lower GI, and this is what we recommend for colorectal lesions. First, very precise description of the polyp, so the size, the morphology, using Paris classification, the location of the lesion, precise margin delineation, and then as said, Janet classification for describing vascular or surface pattern. And according to this classification, you see in the NICE-2 situation or Janet 2A, mainly with low-grade dysplasia, piecemeal EMR is still the gold standard. In a situation where we have now Janet 2B, and I showed you these images, depending on the location, ESGE recommends ESD. And in Janet 3 or NICE lesions, a surgery is indicated. But however, it's sometimes quite difficult, even for Japanese experts, to define what is a Janet 2B lesion. So the probability or the accuracy is not 100%. These are data from our unit. We published 2017. You see, we divided into study periods, and what you can see, the recurrence rate decreased from 6% to 3.3%. And if you had a block resection with ESD, then you have no recurrence. So none of 40 patients had a recurrence. So that means you don't need a surveillance endoscopy after 6 months as we do for piecemeal EMR. So ESD is, in my view, also a kind of green endoscopy. We save resources and avoid unnecessary control endoscopies. Looking at our early cancers in this study, in this period, we saw that initially we had a curative resection rate of only 14%. So the majority needed still surgery after treatment, and in the second study period we are now about 50%. Why did this change? Because I think we make now better diagnosis. We exclude patients where we think this is a Janet 3 or NICE-3 lesion and avoid unnecessary treatment. So comparing data from Asia and non-Asia, there is still a difference. You see the block resection rates, RCO resection rate. Asia is still doing better in this situation. When we look in non-Asian, and there were also our data from Augsburg included, you can see in a center where we do a lot of ESD, you can achieve also in Europe the same numbers as in Asia. So meanwhile, I think many centers in Europe approach this high curative resection rate or block resection rate as published from Asia. Last year we published our German ESD registry on more than 1,000 neoplasia in the upper and lower GI tract. We had 20 centers. The red one, this was our center, and the blue were high volume centers, and then also small volume centers. And the take-home message for this lesions were that the higher the volume, the better the outcome, which is for sure not surprising. We know it also from surgical procedures. So as you can see here, a significant difference in curative and RCO resection rates according to the numbers in these centers. Here we have the data from the colon and the rectum. In Germany, you see the numbers in this study was quite low. Only 78% were included in this registry. The majority performs ESD in the rectum, and you see the perforation rate is much higher in the colon as compared to the rectum, where we approach only 3.4%. So my take-home message, if we want to perform or treat with ESD, I think it's much easier in the rectum and more favorable. because of the low risk of perforation. The ideal size is somewhere above 3 centimeters, I would say. A smaller lesion can be easily treated with a block resection. The morphology plays a role, as said, Chained 2B lesions and Paris 2C lesions. And at the end, I would say the experience of the center is an important issue, and you should perform in your center at least 30 cases per year to have a good outcome. Thank you so much.
Thank you very much, Helmut, for this very nice overview. And now we are going to present a case of endoscopic submucosal dissection performed in a patient. So we haven't got the slides, but I'll give you an overview of the case. It's a patient, 76-year-old, that came as part of the bowel cancer screening program and had laterally spread lesion mixed type of about 5 by 3 centimeters large, that was mixed type with a small area of what it looked like a Genet 2B. So in terms of the equipment we are going to use, we have the Olympus 1500s new generation scopes. We are using a Fuji conical cap and a speedboat inject 8 French, that is a slimmer version of the original speedboat inject that goes down 3.2 channel colonoscope and has advanced bipolar radiofrequency and microwave for coagulation. And injection needle is from Pentax, and the learning points will be understanding the indications and technique of endoscopic submucosal dissection, how to approach it, and try to familiarize of exactly how different this technique differs from large field EMRs. So please, with the case. So we reached the mid-transverse colon, and here we have the lesion. That is a laterally spread tumor, granular type with a nodular component, and on narrow banding we can see quite homogeneous speed pattern with a JNet 2A. So I'm marking the lesion with a speedboat inject 8 French with a microwave modality, that is the modality used for coagulation in this device. And here we have the lesion marked and occupying probably a third of the circumference. Needle out, inject. So I'm going to create, keep injecting a proximal gate to begin with. So I live with gelofuscin and 1 in 200,000 of adrenaline and some indigo carmine for the mucosal cut. Right up. Right up. So I'm using the speedboat inject 8 French, as I mentioned, left up. Which is a device that cuts with bipolar radiofrequency. Keep it left up. And because it's bipolar, the energy is very well controlled and there's no so much deep penetration. You have to orientate the device in order to cut, and it has to be in real on tension to the tissue to cut. But you use
much less energy to be efficient. Okay. Now I have opened the distal gate. There is a blood vessel, so I'm going to coagulate it with microwave, and you have to be in contact with the blood vessel for the coagulation to be effective. Right up. I'll coagulate maybe this blood vessel a little bit more, and because it's microwave and there's less increase of temperature, needle out, inject, 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 inject. And now to trim and create the tunnel under the lesion, I use Orice from Boston, which is a vegetable-based polysaccharide, and it's quite viscous and the lift is quite prolonged. Okay. Let's coagulate. Have to press the pedal for a little bit longer, as the increase of temperature is much less. And when you see the bubbles of water, means the coagulation is being effective. You have to be in direct contact with the blood vessel to achieve an effective coagulation. Neutral position. And it's very important to have a good communication with the assistants, as this is a teamwork dissection. Left up, right up. Slowly we are getting beneath the tunnel, although the blood vessel bundles from the nodule are proving a bit difficult, the access to the submucosa. Okay, we can see the submucosal space a bit better. So the muscle layer is at 6 o'clock at the bottom, right up, right up. And we have the polyp on the top and the blue space. You can see a blood vessel there. The back, okay. And now cut it and coagulate. Because the speedboat inject has an insulating hull at the inferior part of the device, that allows me to be working in proximity with the muscle layer. Therefore, I'm avoiding all the capillary bleeding that I would have otherwise. Right up. And as you can see with the microwave, there's hardly no charring of the mucosa. Inject, inject, inject. So inject, 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 inject. Needle back. So I am proceeding to do the mucosal circumferential cut. Left up. Okay, that's the left side disconnected. And we are disconnecting the right side. Nearly there. I'm going to the left. Excellent. Okay, now we will start by disconnecting the submucosa on the sides because the tunnel is already done. This area very frequently inject. Okay, a bit more left up, that's it. It's an area that very frequently bleeds because of the blood vessels attached to the nodules. So I'll coagulate. Before I proceed to cut. Okay, coagulate a little bit more because very often there is blood vessels there. Oops. And now we have a bleed. Okay. I'm gonna try to isolate the bleeding with the cup and identify the blood vessel. It is important to have a dry fill for the microwave to be fully effective. Let's see if I can isolate the blood vessel. I need to reposition the cup and achieve good compression. Yeah. Now the flow is going down. And let's see, I think the blood vessel is just beneath that small flap. I'm just gonna try to push it with the cup so then I'll have a better access to the blood vessel with my device. Yes, I can see the blood vessel there at 9 o'clock. So device out. Sorry, not yet. Right, device out, yeah. Let me just maneuver the cup a bit. So I'm just bringing the blood vessel to 6 o'clock. Now press the microwave for the full length of 10 seconds and repeat the cycle. Okay, we can see the bubbles of water. Now I'll withdraw the device very slowly. Okay, and now withdraw the cup and flush, and yes, hemostasis has been achieved. Okay, not long to go. We just need to follow the mucosal cut, just a few strings left to dissect. That's the proximal gate. That is useful because it's a good guidance. Right up, right up. It is important not to rush the very last minutes and avoid having a bleed that delays. The full dissection. Nearly there. Too close to the muscle, so I'm going to use the cup with the tip up just to lift this flap away from the muscle and cut it successfully. Okay, it is off. So we are getting close to the proximal gate. And that's the last flap. There we go. It is always important to inspect the dissection bed and make sure there are no large blood vessels oozing or any perforations. And as you can see, the excision bed is very clean right down to the muscle layer.
Right, so here we are back in the studio after a very condensed and summarized TSD, because in total this case probably took 2 hours and 10 minutes to finalize because of the challenging position into the mid-transverse colon. So anyone would like to comment on general ESD? For instance, why we don't touch base in terms of training? Because in view of the new ESG updated guidelines that you, Helmut, presented, it seems to be a more clear indication and broader indication of which lesions we should be performing ESDs now in Europe. The previous guidelines in 2017, they were very restricted, and in fact, if we all had to learn in Europe to perform ESDs in such challenge lesions, we were already on a bit of a step back. So what are we going to do in order not to make it available? Not every single endoscopy should learn to do ESDs, but in order to make patients to have these techniques available regardless of where they live, that they have a center that it's reasonably close for them to be deferred to have this advanced interventional endoscopy. What should we do in order to formalize training and to make sure that that happens? Because it has taken me a while to learn how to perform ESDs. It's not something that you learn overnight or just observing over the shoulder your colleague.
Yeah, you're right. I mean, actually, I do ESD since 2003, so that's a long time, and it was learning by doing, so nobody trained me in Europe. I think we were the first in Germany. Meanwhile, we know in Germany at least which centers have a number where they really can then be a center for ESD, and this should be the first step in each country to say how many centers make sense for us, because this is not a technique which should be available everywhere. On the other side, you're right, we offer now a lot of training centers, more than in the past, where ESG has a curriculum for ESD. So this all, I think, improved ESD over the years and becomes more available and attractive. And comparing the situation right now with 10 years ago, I think we made a huge step forward. We are clearly behind Asian countries, but I'm optimistic that in the next 5 years, in each country, ESD is available technique on specialized centers and can replace surgical treatment where we still do too much surgery, I would say.
Yes, and I completely agree. And I think one of the points, obviously, we can go to some training courses or hands-on courses, but one of the things that probably are lacking is what do we do when we go back home, and perhaps we should structure some training modules that then they include the mentoring aspect as well. So I think maybe as we are developing into ESD performers, we should have our obligation to mentor the other people that we consider would be nominated to perform this type of procedures in order for the patients to access to them in more broadly spectrum. And that's a bit of a lacking probably in Europe, because we don't have so many individuals performing ESDs, and therefore the mentoring it's a bit limited.
Yeah.
So is there any, do you know if in terms of positions like, I don't know, the BSG or the ESGE, are any programs that are going to take that forward so that the training is robust? It's not just anecdotally by who you know, or if you think you could do it because you are a skillful colonoscopist and you have a friend that can overlook at your shoulder. Anything more robust that then it can be offered to the next generation, perhaps, of interventional colonoscopies?
I can only speak on behalf of ESG and not PSG, but as said, we have a curriculum. We offer we have a couple of training centers in Europe for different techniques, and the majority also knows this is a center which offers where ESD can be learned, and people come in our unit, for example, for 4 weeks and see a lot of ESD procedures, so it's not necessary to go still to Asia. The trainings courses which are offered in Europe are in vitro or in vivo on living animals, but you're right, there is no structured teaching to say, well, do it in this way, what ESGE offers right now, and then you get a certificate from ESGE, you are allowed now to do ESD. This is for the moment not available, and also in my country, not in Germany.
Yes, and I mean, obviously you have a very big center that performs a lot of very complex endotherapy, and you train as well quite a lot of people in King's. What, for the audience that are observing us, what would be for you the tips to encourage people or discourage people to do ESDs that you have been doing for a practice that you have been doing for a very long time? If someone is watching us, hopefully, and thinking, oh, it's perhaps a technique that I could offer because it's not available in my sector, which sort of tips would you give them?
I think there's a lot of things that we can learn from the laparoscopic surgery introduction around the world, and how we structured that in terms of breaking down the procedure into defined steps and having strategy for beginners and intermediate and advanced endoscopists to do certain areas of the ESD. I think the best training is to have an in-house mentor. If you have an in-house mentor, then actually you're going to progress yourself in terms of your training at the most rapid rate. But unfortunately, we don't all have in-house mentors that can be there and available all the time. So the question is, how do we replicate that? And I think with the ESG curriculum and the training curriculum that we put together, it gave you some aspects of what you need to do in terms of your training in the lab, and what procedures you should start with, and what your goal should be in terms of R0 resection and complication rate. But when you do start, you do need to have, certainly I would say, observation with an expert center, and then have some way of having some ongoing mentorship. And we've done a bit of this in the past 3 or 4 years, and COVID sort of made us look at things differently, using different streaming platforms, and we've used Proximy, for example, to mentor within Europe, and that was within the Forward program that was set up by Pentax. So having some training in the lab, having some observation, and then having some mentorship that can initially start face-to-face, and then you continue that relationship online.
Yes.
So we currently have those programs that are in place, in our institution, where we have and support others to set up services in their hospital. But I think there's no substitute really for visiting,
yes,
observing, and you know, coming to meetings like this to try and understand what it involves.
Exactly.
But I would encourage people to look at the curriculum, and I think it's a good baseline to see what you need to do.
And we know that more from industry point of view, there are some programs that have been set up that are more structured. As you said, the forward program in Pentec, Creo Medical has put the Pioneer program, Olympus also has their own program set up, and that's a bit of a start. But probably us as gastroenterologists and people that are in BSG positions, ESGE positions, probably recognizing the lack of training and trying to shape how we could amend that probably is very important. Thank you very much. We are going to move to the next session. That will be our virtual polyp MDT, so very curious of what we all make up of these lesions.
Right, hello, welcome back. We're now going to do a polyp MDT, and we thought we'd try and bring together all the learning from this morning into the final part of the colorectal session. We're joined online via Teams by my radiology colleague, Anisha Patel. Hello Anisha, hi. Thank you so much for stepping in very much at the last minute to assist us. So we'll just go through the slides, and really just what I wanted to show was that polyp MDT, for those people who don't run a polyp MDT, I think is very much an essential. It allows both surgical and endoscopic perspectives, which are often quite different, and it allows a proper discussion of what the right endoscopic approach is. It requires a radiology input, obviously, and also histopathology, and it's essential, and we've talked all the way through this morning about the importance of high quality photo and video documentation. And obviously you take in patient factors related to that, so age, presence of comorbidity and all the rest of it. And I think it's got a very important educational role for people who attend, and certainly I think we learn a great deal from the MDTs we run here at UCLH. So I'm going to go straight to the first case. So this is a 63-year-old female who was constipated, had a fit test done that was positive. She'd possibly had some weight loss. She had a plain CT done because of the weight loss, and we'll see those images in a second. And she had an initial colonoscopy which demonstrates a splenic flexure lesion. I'm going to bring up the polyp for the benefit of the MDT audience. And Amin, I'm going to ask you, once we've gone through the radiology, just to describe the polyp to us and what you think the options are for this patient. But first of all, Anisha, could we go to the plain CT? Is anything visible at all?
So unsurprisingly, no. I'm scrolling through the images, which hopefully you can see. We're closely interrogated the splenic flexure, where we saw the lesion at colonoscopy. No obvious mass. We're looking for a minimally raised lesion, so we knew it might be occult on CT, and indeed it is. But we can tell you that we didn't see any gross extramural spread or locoregional lymphadenopathy. And obviously we did the staging for distant disease on this study as well.
Great. And Anisha, if there was an established cancer there, just with a plain CT, an unprepped CT, how useful can that be? What's the pickup, would you say, for colorectal cancer, in established colorectal cancer, just from a plain CT?
Very dependent on the size, but I would say very good in terms of T2 or above tumours, bulky T1s that are put in the middle, just by virtue of their size, we're very likely to pick up.
Great. Okay, thanks very much. Okay, we'll go back to the endoscopic images now, and Amin, I'll put you on the spot. What are your thoughts?
Yeah, thanks, Ed. So this is LSTNG, and you can see that this is pseudodepressed type. Looking at the initial endoscopy images, the spectral imaging that you can see is not a magnified view, but certainly you can get a suspicion, probably some mucus in the central area potentially, but we need to wash and just check that area carefully, because that central area which is demarcated is the area we need to evaluate the most. In some areas, without the magnified view, you can see JNET type 2B. In the periphery, you can see JNET type 2A. I would be very keen to evaluate that central area carefully using magnification and chromoendoscopy to assess and look at pit pattern. But this is, LSTNG pseudodepressed type, and if the magnification is favorable, then these patients would be suitable for endoscopic resection and ESD, but we need to evaluate that carefully first before making that decision.
So South London give a vote for endoscopic resection with ESD as the most likely approach. What about North West London, Brian?
Can we put the picture back up again for a second? Yeah. So obviously I agree entirely with the description of the lesion. There's one extra thing, or a couple of extra things that I would always do in this situation, because you're worried about that central area and whether that could be deeply submucosally invasive cancer. I really like to palpate the lesion. I use the biopsy forceps and I just touch it, and you can get a lot of information from just the feedback on the amount of tissue resistance palpating that area with the biopsy forceps. If it's rock hard, I'm probably going to send this patient for surgery. I'm not even going to touch it. If it feels soft, obviously after you've done your imaging, after you've looked at the pit pattern carefully, then there is an option of endoscopic excision, and either by ESD, or sometimes if you can get it in a dependent area, fill that area with water. Underwater EMR is very good in this context. But I'm certainly very concerned about that area of demarcation in the centre. That could easily be an SM3 lesion.
Yeah, and any comment on the utility or otherwise of lifting versus non-lifting with this sort of lesion in terms of deciding on endoscopic resectability?
The problem with non-granular lesions, particularly the pseudodepressed, is they have a desmoplastic reaction, so they don't lift in the centre anyway. So if you inject, you then can't do underwater because you've made the tissue stiff around the lesion.
Yep.
So if I was considering ESD and maybe I was going to bring the patient back, I might do a trial lift to see if there was adequate lifting. I think that's quite a reasonable thing to do, being careful not to traumatise the lesion or inject through the lesion, but at the edge. That often gives you additional information. But I'm quite suspicious of this lesion, particularly on the MBI view.
Okay, yes.
And I think retroflex view is often very important as well in this situation to try and identify, when you deflate and insufflate, what the feel is of that central area and what it looks like on the oral side. So I think you've got to, so if this was sent to me at King's on a virtual MDT, I would always assess these patients again with magnification and do a full thorough examination to make a decision whether it's resectable or not.
That's interesting. So, and would you reassess and then do something on that colonoscopy, or would you then bring them back for a further
No,
procedure?
I would reassess and then bring them back, because I think it's a splenic flexure in the colon. We need to look at stability, what the access is to the oral side. We need to obviously make a diagnosis, and if we make a diagnosis and think it's not resectable, then you've wasted your couple of hours of slot. And also, look at tolerability for the patient, because if it's going to take you an hour or 90 minutes to resect a difficult lesion in the proximal colon, then some patients may not be able to tolerate that under conscious sedation. So all those decisions, I think, would be made on repeat examination.
Okay, that's fantastic. Well, I'm going to go on to the next lesion now, because time's ticking on.
You're not going to tell us the answer?
Certainly not, no. There is no right answer. It's all about the discussion.
Was it a cancer? Come on, you could tell us.
No, it looks like high-grade dysplasia.
We perform an ESD and it was high-grade dysplastic.
So we'll go to the next lesion, please. So I'll need the slides up. Second case, 76-year-old woman with a long-standing history of IBD-U, only on 5-ASAs, good control. A large lesion was found in the rectum on the colonoscopy she had for PR bleeding. And Anisha, we've got an MR to look up.
Yes. Lovely. So I'm just going to scroll through images. We've got an MR rectum for you, and we identified the lesion quite easily in the upper rectum, and it measured around 3.5 centimeters, this intermediate signal polypoidal mass involving the posterior wall. See that MRI really lends itself to examination of the rectum, which is a relative structure. We're delineating the polyp quite well. There's a thin of hyperintensity just at the base of the polyp where it is the rectal wall, and that hyperintensity we take to be the submucosa. So in this lesion, we would say that it's, as we can see, the thin rim of submucosa preserved, and this is likely, if at all invasive, to be an early SM1 or SM2 rather than a T2 or SM3 lesion. We're also able to see a nice clean muscularis propria, this low signal going around the edge with muscle signal. So there's no extension beyond the muscularis propria, and we can also look at the mesorectal fat to show that there is no lymphadenopathy or tumour deposits.
Okay.
So we would have called this a T1 at most, possibly SM1, SM2.
Brilliant. Thank you, Anisha. I'm actually, because of time, I'm going to skip through the slides and we're going to go straight to the image. So if we can go back to the slide deck. And Rosa, would you describe the lesion to me in terms of what we're looking at?
So yes, this is a lesion. It seems quite low in the rectum, and it has, obviously, is a laterally spread lesion, mixed type, with a large nodule component. That is probably what Anisha was seeing in the MRI scan, but it has also a sort of a spread granular component, just as a little scared into it. In terms of the pit pattern, we don't have a very good representation because there's quite a lot of mucus covering the lesion. There is no ulceration, there's no sort of a depression areas, but I would be quite concerned of this nodule because we know it can harvest high-grade dysplasia or cancer on it, and that would be my call.
Okay, so what would your approach for this then? Would you be calling your friendly surgeons or?
So obviously the MRI scans, we are still learning quite a lot of how to interpret it, and it's very often when we have our MDTs that the radiologists say, I may be overcalling it if it's a T1, T2. I can tell you there's no significant nodules, but in terms of the definition with the relationship of the submucosa is a little bit a bit more dubious. So perhaps I would ask my radiology colleagues to perform an endoanal ultrasound scan, particularly on that nodule, to see if there's anything worrying. On those nodules, it's not infrequent that sometimes you find a bit of muscle retraction sign that makes the dissection, if you are considering an ESD, a bit trickier. So I would interrogate in the MDT with the radiologist if there's any signs of muscle going into this nodule, and that would give me hints if an endoscopic approach would be. But providing that there's no muscle retraction sign, it's very low in the rectum, so obviously a sort of a conventional colectomy and then a very ultra low anterior resection would probably compromise, but Amin may disagree with me with his surgical skills, that the functionality of this rectum later on, despite curing of the disease. So probably I would offer an endoscopic dissection.
Okay. Amin, you've been called out there. Now you are so unique in my experience in that you can wear several hats all at the same time, which I'm always enormously jealous of. So should we be considering an endoscopic approach, or should it be a transanal surgical approach or a conventional surgical approach?
Yeah, I think, for these rectal lesions, and often with MR, there's a couple of points. One is, what we want to check is there EMVI or is there any lymph nodes? The main decision making is all based on the endoscopic image and the magnification image, rather than on MR or ultrasound. In our practice, we would do MRI, ultrasound, and magnification. Magnifying on the nodule, we know, has a lower sensitivity of just below 70% compared to the flat lesion. So actually, it's really going to be dissection by ESD, an en bloc resection that will give you your final histology. But what I usually say to patients is we need to think about what they would do if this was a cancer. And then we need to think about what plane of dissection we're going to go into. So if they said to me that if they had an 8% risk of cancer, which is what this nodule will have, and they would want to have lymph node harvest with a low anterior resection, but they want to wait for the histology, then we know we mustn't breach the muscle, because doing that resection with breaching the muscle would make the low anterior resection more difficult. So this will be a submucosal dissection by ESD. But if they said to us, well, actually, at no counts we want to have any lymph node harvest, even if the risk is high, then you could even, during the procedure, if it's going into muscle, which 40% of these would do with muscle retraction, go into the intermuscular plane, but still preserve the longitudinal muscle. So I think in the discussion with the patient initially is really important, but we would base our decision making on the endoscopic image. We would do ultrasound, but we would, generally speaking, go on the endoscopic image and do an ESD to try and preserve the muscle layer so that we can give an informed discussion with the patient with the histology.
And transanal ultrasound, or? Yeah,
so actually we've moved away. So we do both 3D ultrasound with the transanal probe using the BK, and we also use high frequency mini probe ultrasound through the scope. Yeah. So the mini probe ultrasound on the nodule, the focal length is very short, so it's difficult to get the image. So you'd have to do a combination and do even a 3D ultrasound. But actually your decision making is going to be on the endoscopic diagnosis rather than anything else.
Okay. Brian, I'm going to give you the last comment on this.
So, there are a couple of things, I think, which push you towards thinking very seriously about an endoscopic excision or a local excision of it. One is that a low anterior resection is a complex operation. You've got the added complexity of the fact that they've got colitis, and you're not going to cure the colitis necessarily by doing a local resection, should you do a pan-proctocolectomy, and then it's a very major surgery. The other thing is this is on the posterior wall, so even if you need to go into the intramuscular plane, you can do that quite safely. Even if you needed to go full thickness, there's going to be no immediate complication the way there would be if you were above the peritoneal reflection. The flat area looks very easy to resect. It's really just the nodule, but you have space to go underneath and create a tunnel underneath approaching the nodule from the anal side. So I think technically, and you've got a nice area of demarcation where the edge of the lesion is. Sometimes in colitis, the lesion is ill-defined. Here, the lesion is quite clearly defined. Yep. So I think there are a number of things pushing you towards doing a local excision. If you subsequently remove it and there is cancer there, it's then another discussion about should they go on to have an anterior section. Of course, you would try not to perforate, because that would then affect the surgical outcomes possibly.
Terrific. Okay, well look, that was incredibly helpful. Unfortunately, we've run out of time, but I want to thank everyone here in the studio and Anisha in radiology, and then also all the delegates at home watching the proceedings this morning. We're going to wrap it up now, so thank you very much for following us, but do stay tuned because coming up is all you need to know about GI bleed. So thank you very much.
Okay, welcome back. We've now got a session which we don't often see or do as part of a live endoscopy course for pretty obvious reasons. GI bleeding. And it's a very important thing to address because, of course, it is even for old hands like John Morris here, it is the scenario that can get our pulses running. And there have been important advances both endoscopically and medically over the last few years. So we're very keen to address these during this session. Delighted to have on the sofa with us Vinay Segal, colleague from UCL, John Morris from Glasgow, and the new Vice President for Endoscopy for the BSG, and my colleague John Potts, Royal Free and UCL. So let's start with the first case. This is a 71-year-old man within the bowel cancer screening program. He was FIT positive. He was receiving apixaban for atrial fibrillation, and that which was discontinued appropriately. And he had a colonoscopy. A polyp was, not a terribly big polyp, was removed. A couple of clips were applied to not very exciting stalk of this polyp, and then surprisingly he came back with an acute colonic bleed, and at emergency flexible sigmoidoscopy there was a pulsatile ooze from the stalk tip. 3 further clips and next powder were applied, and we can get people's views as to whether that is what they would have done. And he was discharged 48 hours later. He was then readmitted with a large bleed, hemodynamic instability. We're going to talk about the reversal of apixaban and the performance of the subsequent endoscopy. The equipment, we're using the Olympus EVIS X1 colonoscope, and as you'll see, we're using the over-the-scope Ovesco clip. Now I'm going to go over to over to Ed Seward to describe the case.
Right, thank you very much. So this was a case I was involved with, and the issue was that there was a large amount of metalwork on the polyp already, and despite all these clips, the patient had been bleeding. And so a decision was made to go for an Ovesco clip. So I wanted to get some adrenaline on board, because the issue was I needed to remove the clips on the stalk before I could get the Ovesco in place. So what I wanted to do, rather than snare the stalk base and then come back with the Ovesco, is to, I wanted everything in a oner, because what I was very concerned about was I would cut through the stalk base and everything would just descend in a red mist. So you can see I've got a conventional hot snare down a scope carrying the Ovesco clip, and we're just cutting through the stalk at the moment. I pre-injected just to get some adrenaline on board, again, really just to give me time to establish hemostasis if everything went south rapidly. So there we go, we've just gone through the stalk there, and so now we have just a defect in the mucosa there that I'm going to attempt to deploy the Ovesco on. So you get nice and close, you just treat it really like you're banding a varix, and you suck it up into the well of the deployment chamber, and then just like you'd fire a band on a varix, you twiddle the device around, and the clip fires hopefully over the area that you'd intended to. So what you'll see is it fall back. There's the mucosal defect there, and it's got a clip either side of it. So that's a good result, and you can be reasonably happy you're going to get hemostasis on that, I hope. Right, back to the panel.
Okay, so not a terribly exciting polyp, but all sorts of mischief that we then had to get involved in. Vinny, the story of this case: not a very big polyp, not a very thick stalk. Any measures that you take endoscopically, and then we'll turn to John more generally. Endoscopic approaches to prevent problems in this setting at the index colonoscopy from an endoscopic point of view.
Yeah, I think a pretty unimpressive polyp actually, and a very kind of devastating almost consequence from a bleed actually, which is quite bad luck I think in summation. I noticed that the patient had a prophylactic clip applied to the stalk before the resection. I know that's kind of done a little bit, but it's not something I do routinely. I would kind of liberally pre-inject the stalk with adrenaline. You may even want to do 1 in 200,000 adrenaline instead of 100,000 lifting solution. And actually, it sounds slightly odd. I would actually, if it's going to bleed, I'd rather it bleed in front of me so I can deal with it there and then.
Okay.
And this patient's obviously had a very unlucky course with quite an early bleed and then a later delayed bleed despite hemoscopic measures thereafter. So I think, would I routinely apply a prophylactic clip? Probably not. It would really depend on the case-by-case basis.
And finally, the endo loops, they were something that people were using quite a lot a few years ago, right? But perhaps not as much as...
I think you struggle to find them in your unit at the moment.
Yeah.
Particularly more junior trainees would probably not be very familiar with actually deploying them. I think there was a bit of a story about them kind of increasing the risk of transmural injury when you apply a diathermy. I think they've very much fallen out of fashion, to be honest with you.
That's interesting.
But it may be useful as a kind of rescue tool, I think, but not first line.
Okay, that's helpful. John, standing back, if you like, the measures that should be considered or may be considered in this specific case to just reduce the risk of problems and comments you'd make about that.
Well, yes, I mean I think there's some odd things about this case. We're told this was a 1 PS lesion, left colon, pretty distal. We were not expecting that this was going to be a big bleed. I think the operator probably wasn't at the outset. And yet, here we are. We talked a little about this yesterday, that whilst we follow the guidelines in terms of discontinuation of the DOAC, the question in my mind is actually, did the patient do that, or did they follow the instructions?
Yeah.
And then it's about, for me, it's about avoiding the problem. So, what was the resection technique? This would not have been something that you could have, or you would have even considered to put an endoloop on. We still do use endoloops, incidentally. Flat lesion, nothing really to anchor the. So I think the principle was there. If there was an index of suspicion, then put a clip on. Of course, that makes sense. I probably wouldn't inject in that situation because I think it makes it more difficult to get the compressive force of the polyp. But there's no this is a beautiful example of when something that in clinical practice seems like it's going to be straightforward doesn't turn out to be.
And so on that question about clinical practice, within our units now, we do thousands of colonoscopies a year. The vast majority of patients, even having a polypectomy, have no problems at all. But, we've all seen cases where the safety net hasn't worked, the patient hasn't been quite clear. Do you have any sort of advice or rules around being sure that the patients understand what to do and how to do it if they go home? Because this will have been a straightforward day case procedure, won't it?
Yeah, I mean, where I've seen bleeding like this, George, has actually been when someone has actually recommenced the DOAC, because whilst the endoscopist may have had a suspicion, maybe I should put a clip on, I should be doing something, then the discharge information doesn't alter. So for me, the discharge information does alter because I would be actually delaying the restart. The clinical indication for the DOAC is low. Atrial fibrillation, the risk of another day or two. I think, if I was concerned about that I would have done.
Yeah.
Coming back to the actual process of the case, to me it seems reasonable. We do actually advocate, even in the BSG guidelines, that if you have an isolated bleed, so not in a polyp, actually there's a limited role for an endoscopic intervention. So, for example, a diverticular bleed. This is a different situation altogether. And I think it's very reasonable in your first approach to be considering the clips. But as Ed beautifully showed, if we go down the standard clipping approach in these polyps, which again I think is reasonable, then it is going to interfere if we decide to go for another endoscopic approach. As happened here, very unusual to have to come back a third time. And I must say, I think by that stage I'd be thinking about, are we looking at interventional radiology? Is there something anatomically amiss here that we've missed?
And I think that the point you make, and we'll move forward in a minute to this, is the issues around other things going on. It's not so long ago that as endoscopists we had to worry about aspirin and the rare patient who was on warfarin and what we did about that. And now there are so many new antiplatelet agents, DOACs, etc. I think it's fair to say that many clinicians are still not completely clear and comfortable what their advice should be in terms of the patient coming for a relatively routine colonoscopy, and also, a lack of awareness about what pharmaceutical approaches may be appropriate when we need to reverse some of these agents. We all know, oh well, patients over anticoagulated with warfarin, we give them vitamin K or we throw in the FFP, and we know that we can't do much about aspirin. You're there with that, but actually, and as we're going to find out, within the area of DOACs, which an exponential number of our patients are now on, really, compared with 5 years or so ago. I think that they represent an anxiety for, well, actually not only endoscopists, but also for the acute medical or the acute surgical team, being presented in casualty with this, with a patient who's come in with a big bleed and is on a DOAC, for example.
It's so critical that you have a clear pathway here, and I think we've seen throughout the last 2 days that bleeding management is a single transferable skill. If you want to be involved in advanced endoscopy, you need to be able to deal with the consequences of that. So important that the clinical pathway, which is actually to stop the bleeding, is not delayed by actually dealing with the pharmacological issues. That these happen in tandem, but should not delay that this patient needed, an intervention.
But that's a brilliant link through to a presentation that Vinny Seagal is going to give us on this whole issue about the patient pathway and the role of some of these medical therapies. So I think we go over to Vinny to tell us all about it.
Thank you, George and team. I'm hoping to spend the next few minutes with you providing an update on a field that's actually rapidly changing, and that is DOAC reversal in the context of acute gastrointestinal bleeding. As George alluded to slightly earlier there, we are going to be seeing more and more patients on DOACs, and as a consequence, we know that the main side effect of DOACs is actually GI bleeding. So as gastroenterologists, this is something we are going to become increasingly familiar with, particularly as NICE have updated their guidelines to include DOACs now as first-line therapy in patients for thromboembolic prevention in atrial fibrillation. These are my disclosures. So why is this important? Well, as gastroenterologists, GI bleeds are something that trouble us the most. It is the most common acute GI emergency that we are all involved in. We know that NSAIDs are the sort of causative factor in approximately a third of cases, and despite our best efforts and despite improvements in endoscopic technology as well as hemostatic therapies, the mortality rate still hasn't really budged from 10 to 15%. So there is a gap in addressing this unmet need. There have been numerous societal guidelines and position statements published on GI bleeding, which I'd encourage you to read, and they really go into depth about endoscopic therapy and how we can treat patients with rebleeding or rescue therapy. But what I'd like to focus on today and moving the mindset slightly to pre-endoscopy care and what we can do to get these patients safely to the next phase of treatment. And really, I unashamedly would say that there's a real mantra that I follow, which is the common theme from all these guidelines, which is resuscitation, resuscitation, and further resuscitation before you get this patient to the next phase of care. So we know that more and more patients are on DOACs, but the latest BSG consensus statements merely tell us that we just need to interrupt the drug and get them through to endoscopy. And we're able to get away with that approach a lot of the time based upon the very short and predictable half-lives of these agents. And that is something we've relied on for a while. We do give FFP occasionally, but mechanistically that doesn't make sense. And I'll give you some interesting data. We all give FFP for patients to reverse warfarin-related bleedings, but actually, although warfarin lowers FFP lowers the INR, it doesn't actually affect mortality, which I've read with a lot of interest. So this is just a selection of the numerous different antiplatelets or DOACs that patients are on, and we're going to be seeing more and more of this. What I'd like to focus on here is really rivaroxaban and apixaban, as well as edoxaban to slightly less detail. So, as I said to you earlier, DOACs have a very short half-life, and because of that, we can get away with stopping the drug. There is no routine clotting test, such as an INR, that we can use to measure the anticoagulant effect, and fortunately, they are less likely to require reversal. So andexanet alpha is a recombinant decoy molecule which mops up anti-factor Xa drugs such as apixaban and rivaroxaban. And I actually wouldn't call this a reversal agent. What's unique about it is that it's actually an antidote. It's an antidote to anti-factor Xa drugs, and it acts rapidly within a couple of minutes, which is very helpful in the context of acute GI bleeding. So these are some early proof of concept data in healthy individuals taking apixaban and rivaroxaban. And what I'd just like to show you is how quickly the drug seems to lower the levels of apixaban and rivaroxaban. So this kind of set the scene for papers that followed thereafter. And really the main paper that most hematologists and gastroenterologists now are increasingly aware of is something called the ANNEXA-4 study, which was published in the New England Journal of Medicine in 2018. This was a study of over 350 patients who presented with either life-threatening intracranial hemorrhage or gastrointestinal hemorrhage. Actually, some important things to point out here is that atrial fibrillation was the most likely reason for patients needing a DOAC in 80% of cases, and actually in the study population only a quarter were GI bleeding. But what this curve demonstrates for you here is the rapid onset of action of andexanet in reducing levels of apixaban and rivaroxaban, and that was sustained through up to 12 hours. If we focus on GI bleeding, the primary outcome of this study was to look at the rates of excellent or good hemostasis achieved, which was judged by an expert committee panel that was independent of the study investigators. And overall, for all cases of GI bleeding, it was deemed to be 85%. There's been some further work in this field, and this is a table demonstrating an indirect comparison between the ANNEXA-4 study, which I've just described, and the ORANGE study, which was a very large registry of anticoagulation reversal across the UK. And what they compared here is in GI bleeding, the mortality of andexanet alpha was lower than in those patients treated with FFP, although the risk reduction did not achieve significance. But it does ask the question, is there something better we can do with these patients? Because of this data and registry data from the United States, it's important to know that andexanet alpha is now approved for use both in Scotland and also NICE approvals. It's also recommended and becoming part of ESGE guidelines on the management of GI bleeding. So again, something we need to be aware of and factor into our decision-making process. But the question is, who do you give this to? And this is the critical point here. This is licensed for life-threatening GI bleeding. Now, I've asked a lot of people what their definition of life-threatening GI bleeding is, and I get a lot of mixed answers. So at the moment, we're trying to form a Delphi consensus statement to answer this in more detail. But really, for me, it is that patient that I would be called up in the middle of the night and have to come in and scope that patient. That's the kind of acid test for me. Would I wake up and come up and scope this patient? And if the answer is yes, you need to really get the drug on board if appropriate. So the key thing is here, the patient needs to have taken the drug within 18 hours of the presentation. And I think if the last dose of the drug is unclear, then you probably would give it in an acute situation. And some useful things to point towards a life-threatening bleed, including those patients that are hemodynamically unstable, despite your best initial resuscitative measures in the emergency department or the acute medical unit. Those with persistent hematemesis, that tells me someone is still bleeding at very high risk of aspirating, and anyone that you can't stop your anticoagulation in, which is less likely. Those are the patients in whom you want to consider reversal with andexanet. This is a schematic showing the numerous different reversal agents available for different antiplatelets. And I think the message to take from this is that this does not replace standard resuscitation. If you see a patient with an acute GI bleed, you've got to fluid resuscitate them, give them blood where appropriate, send them to higher level care if necessary with airway protection, and then consider giving the drug. The reality is gastroenterologists will be involved in the decision-making process because these are sick patients, so we need to be aware when to give it and when not to give it. And really I see this as a bridge to getting the patient either most commonly to an endoscopy suite or even interventional radiology for a CTA, depending upon the appropriate circumstances. And really, this will need to take part and be included in local guidelines, but also care bundles, which exist already and may require a bit of iteration moving forwards. And I think that's going to be the next steps with increasing awareness with our own community and adopting use of this drug, provided it is given in the appropriate circumstance. I hope that was useful, and I'll now head back to the room with George and co.
Coagulation factor 10A plays a pivotal role in the final common pathway of the coagulation cascade. Factor 10A assembles together with factor 5A on the platelet surface, forming the prothrombinase complex, which is responsible for the large-scale conversion of prothrombin to thrombin. Inhibitors of factor 10A work by one of two distinct mechanisms. One of these mechanisms is related to direct factor 10A inhibitors, such as apixaban or rivaroxaban. Direct factor 10A inhibitors bind to the active site of factor 10A and neutralize the activity of the prothrombinase complex, thereby reducing clotting. Ondexxya provides targeted reversal of factor 10A inhibitors, rivaroxaban and apixaban, anticoagulation activity through a specifically designed mechanism of action. Ondexxya is a modified factor 10A protein that acts as a factor 10A decoy. It does so by rapidly binding with high affinity to factor 10A inhibitors. Ondexxya exerts its effect by binding and sequestering the factor 10A inhibitors rivaroxaban and apixaban. Another observed effect of the Ondexxya protein is its ability to bind and inhibit the activity of tissue factor pathway inhibitor, TFPI. Inhibition of TFPI activity can increase tissue factor-initiated thrombin generation. Therefore, it sequesters the factor 10A inhibitors away from native factor 10A, prevents interaction, binding, causing a reduction in free concentrations of factor 10A inhibitors and neutralization of their anticoagulant effects. By sequestering the anticoagulant, factor 10A is active. That allows for restoration of thrombin generation, which is necessary for clot formation and fibrin generation. An important consideration is that reversing factor 10A inhibition therapy exposes patients to the thrombotic risk of their underlying disease. Anticoagulant therapy should be resumed as soon as medically appropriate. Although the primary mechanism for reversal of anticoagulation is binding and sequestering the factor 10A inhibitors rivaroxaban and apixaban, Ondexxya can also bind and inhibit the activity of TFPI, and inhibiting TFPI can result in an increase in tissue factor-initiated thrombin generation. For full prescribing information, please see the full Ondexxya summary of product characteristics.
Well, good afternoon, everyone. And to continue the theme of upper GI bleeding, it's my pleasure to discuss with you really the current state of the art, if you like, in management of non-variceal upper GI bleeding. These are my declarations. As a clinician, one of the first issues that I think we're faced with is which risk score should I use? How can we decide, to stratify the risk in individual patient groups? And that information is helped by these studies that are here. Apologies, we're having a bit of a technical problem. Yeah, so these sort of studies that Adrian Stanley produced, published in the BMJ, and you can see on the upper left of this slide, the blue ROC curve, showing quite clearly that the Glasgow-Blatchford score performs better than others in terms of predicting the need for intervention and or death. So the ESG guideline, which was published in 2021, made a very clear statement about this, that we should now be all trying to unify our practice across indeed Europe and perhaps even across the world, that the Glasgow-Blatchford score should be the one that we use so that we all speak a common language. The big advantage, of course, of the Glasgow-Blatchford score is our ability not to admit patients with GI bleeding. So a score of 0 or 1 indicates a very low risk of any adverse outcome. And therefore, we would advocate, certainly in our practice, that if a patient has a low Blatchford score, they can be discharged home. For those endoscopists amongst you in the audience, one of the key questions is, should I get up in the middle of the night and when should I actually arrange for an emergency endoscopy for my patient? A really good summary of the position here is in this slide from the Larson data. And I think one of the things that concerns us is when should I scope an unstable patient? And indeed, what about their comorbidities? Does that influence my decision making? And the good news is, of course, that it does not. And a very obvious descriptor here showing on the upper border the patients with a high ASA risk, the upper curve, and the lower curve is those patients with a lower ASA risk. The message is the same, that actually we can delay the scoping of these patients until a sweet spot, if you like, optimize the resuscitation as we've heard today, and then these patients could be endoscoped. So we're recommending that patients should be endoscoped early, defined as within 24 hours, but there's no additional advantage in scoping these patients beforehand, so urgent endoscopy within 6 hours. The only exception, as Vinny has said, is in patients where they remain hemodynamically unstable. The next issue that I want to discuss is the issue of how we describe, how we communicate with each other, either during endoscopy or after endoscopy. Now, the Forrest classification has actually stood the test of time. The Forrest classification is actually over 50 years old. Again, was designed or was first described from Glasgow. And I think it's very important for trainees in this audience to be familiar with the Forrest classification so that we actually are all speaking in a common language, and this is going to help us in the event that the patient rebleeds. On this slide, you can see clearly the highest risk stigmata is the spurting visible vessel on the left, and the solid green bars on my slide indicate the risk of a significant rebleeding in the event that the endoscopic intervention was applied. And that obviously helps to inform our decision with respect to when we should intervene. So when should we intervene and how should we intervene? Well, again, the ESG guidelines are very clear on this, that in patients with high-risk stigmata, so that's the patients with an F1, Forrest 1A or B lesion, then we should be pursuing dual endoscopic therapy. So that's a combination of an injection with adrenaline or epinephrine, along with either a thermal or a non-thermal mechanical clip. So dual therapy is de facto the optimum therapy. There is some variation in this, and if we, for example, we see a very prominent vessel, the evidence would support that actually monotherapy with mechanical or thermal devices is equally as effective. The real key message here is monotherapy with injection is simply inadequate and should be discouraged. So what about the newer endoscopic modalities? And I say this advisedly because we first started using hemostatic sprays over 10 years ago. We described them in the SEAL registry. And now these are offered for the first time, the tantalizing prospect of a slightly easier device to use, particularly if there was an operator who was perhaps inexperienced. Also the potential for rescue therapy, given that, for example, if dual therapy was not successful, the endoscopist was then faced with, did they send the patient straight to interventional radiology, or did we have a rescue opportunity? And of course, finally, for the catastrophically large bleeders, these may act as a bridge to get the patient from the endoscopy suite and to, for example, interventional radiology. So whilst we regard these as potentially new, they're over 10 years old. We have hemospray, we have Next powder, relatively easy to learn and to use. And I think these, whilst their evidence to support their use is somewhat limited in terms of RCTs, clinical experience, clinical practice tells us that they definitely have a role in this sphere. But what about the sort of new developments and potentially other devices here? And I just want to focus a little bit on over-the-scope clips. We've seen a great example of that in this session so far. And the paradigm for managing patients with endoscopically may have changed and may have been changing very rapidly. I would encourage you to look at these new devices, learn how to use them. But I really want to just focus on, for me, what was the first real pivotal study, randomized control study in the context of rebleeding. So these are the patients de facto at the highest risk, published in Gastroenterology. You can see here that patients with recurrent peptic ulcer bleeding were randomized on a one-to-one basis between standard therapy, and again for us, standard therapy would be a further trial of dual therapy compared with over-the-scope clips. Remarkable difference, as you can see in the midpoint. The primary endpoint of this was reducing further bleeding, and a highly significant difference using these OTSC clips. And so I think we're now taking notice. And the question, of course, is where exactly do these fit in? I think there's no doubt that in a rebleeding situation that we should be considering OTSC clips as our de facto prime therapy. The paradigm may change further, and that these may move up our armamentarium to the point where actually these become primary therapy. But there is some conflicting data now, and I think it's too early to say that. I just want to talk a little bit more about alternative anticoagulants or antiplatelets. And again, this is something that I think is very important for trainees and other clinicians involved in managing our patients with GI bleeding to understand that whilst intuitively it might seem the right thing to do to stop the aspirin therapy that the patient is receiving, usually for cardiovascular prophylaxis, then actually this can be very, very risky. And so ESG has recommended that we do not discontinue aspirin, that we continue this. Now, the real issue, of course, is how do we remember to put all this into clinical practice? Because a large part of our care of these patients happens before a gastroenterologist is involved. So I just want to describe to you the upper GI bundle that we developed at the BSG to try to synthesize all the appropriate steps that should be undertaken in this context. 6 R's, as you can see them on the screen here, from recognition down to reviewing the patient, 13 domains, and simply designed for front door acute care to make sure that the things that we would expect to be done are done appropriately and in a timely manner. Now, does it work? Well, we implemented this in Scotland, across all the units in Scotland, and we asked our trainees to be involved in the implementation project. So do bundles change care? Well, I just want to give you an example of some of the results that we gained. So firstly, was the Blatchford score documented more or less after we initiated the project? And you can see not only was the Blatchford score described more after we had introduced the bundle, but it was directly determined by the use of the bundle, so significantly affecting clinical practice, so somewhat reassuring. But what about hemoglobin? We haven't talked about that because of time, but you can see again here very clearly that actually having a target hemoglobin set was affected by the bundle. So our front door colleagues were actually changing clinical practice based on the use of the bundle. What was most tantalizing, and I can't share all of these results with you, is that we actually were able to demonstrate a shortening of the length of stay for these patients based on whether the bundle was used or not. So I've gone fairly quickly through the data today. I thank you for your attention.
Okay, so great great overview there from John Morris. I'm a little bit older than you guys, and I want to pose the question about who should be doing the endoscopies in acute upper GI bleeds. And I well remember that in 1995, when I was a brand new registrar, having done almost no endoscopy, I was on the GI bleeding rota in the hospital I worked at, and I had a consultant covering me, which was great, except he said I only do flexible sigmoidoscopies. And so I felt slightly exposed. And I suppose, you know, a question is who should be doing out of hours GI bleeding? You know, Vinay, you're newer to the game. Should the consultant, if the patient needs a scope in the night, should that always be the consultant? You know, what would your view be?
I think ultimately, if you've made a decision to come in the early hours to scope this patient, by definition they are very, very unwell, very unstable. So I think you've got the sickest patient on your hands. You need the most expertise available. You'll often do this patient in intensive care or theatres. Airway protection comes first as well. And it's actually getting all those steps in place before you even put the scope down. And I think in terms of operator, I think it should be personally a consultant or someone with a lot of senior experience on the bleed rota to actually deliver that endoscopic care that's needed. It's
and John, in some ways, because it's often even more dramatic, you know, liver services, do you think they've become a little bit more ahead of the game than the sort of non-varicose service in provision of care?
Yeah, I think so. Certainly in the large liver centres, I think there's been a recognition that these are the highest risk patients. I think the management is a lot more than just the endoscopy. In my mind, variceal hemorrhage is often the most fulminant form of GI bleeding. And actually, if you're going to get a successful outcome, it starts with a successful foundation with all of the pre-endoscopic management, at a timely endoscopy appropriately prepared, and then all the post-care. And I think, in 2022 that should be consultant-led if it's not consultant-delivered.
Yeah, John.
I think this is a really good question. My answer to this would be somewhat different. It should be a competent endoscopist who can deal with every eventuality. And I'm afraid to say that one of the things that we've learned is, as the technology has moved, not everyone, even consultants, have kept up.
Yeah.
And so it's really important that we upskill the workforce, but also that we make it possible for people to learn these techniques in a safe environment. So using these, for example, on a morning bleeders list. As you know, George, we've introduced a national GI bleeding course designed for both trainees and for consultants to address this issue. We simply can't have someone who's able to deal with ulcer bleeds but can't deal with varices. We've got to look after the patient.
And actually, I'm broadening right back, actually, even away from GI bleeding for a second. I was talking to one of our faculty colleagues who was talking about the phenomenon which we all recognise of focus of training being on fellows and trainees and pre-consultant grade. But yeah, I mean, the example I give, my supervising consultant couldn't do an upper GI bleeder. It was many years ago now, but John, you're now VP for endoscopy. Is there something that we could be doing? This is just a UK question, but it will extend right across the globe to seeing that senior doctors don't lose the opportunity to be trained in, over the scope clips is a great example. Many senior endoscopists will not have familiarization with them. Is there something structurally we could put in place?
Oh, I'm certain. And I don't think there's one answer to all of this. As Vinny said, this is a condition par excellence with a high mortality. So it's inherent that we should do so. We know that the trainees who were reporting to JAG at the time of CCT were reporting perhaps having used the clip 5-6 times, had used thermal methods 5 or 6 times, and yet they were automatically put on GI bleeding rota when they CCT. So perhaps there's an issue for mentorship. I think the 3 elements we have here is, number 1, can we improve the quality of the pre and post endoscopy care? I think that's where the bundle fits in.
Yep.
Number 2, are the endoscopists competent? And these training courses specifically designed to address, can you use a bander? Can you use the sprays effectively? Can you, etc. But it should be open to all grades.
Yeah.
And it's a personal reflection at that point. But I think thirdly, it's so important that if you don't have a consultant who can do this, or you don't have a service, or you're working in a hospital that's remote from someone who has this, it is actually organising the service so that you get the optimum outcome. So don't put your bleeders list in the afternoon. Don't stop, don't say that we can't scope at weekends, work in teams. So look at your service and actually work out what would be the optimum patient journey. So lots of things, we're working on it.
Brilliant. I think that's a fantastic overview. And in fact, we'll now move forward to Vinay. We've John's spoken about the over-the-scope clips. You've got a good case to expand this discussion further.
Yes, there's 2 cases. If we can start the video, we can show the over-the-scope clip in action really here, in 2 kind of extremes of GI bleeding. So this is a 70-year-old gentleman, been on aspirin for secondary prevention, who's come in with a GI bleed. We see this very commonly, and you've got a nice visible vessel here. You can see that I've gone in with a distal attachment cap, and that's kind of my go-to. In anyone I suspect a GI bleed, I start with a distal attachment cap, because it can be very helpful in the small bowel to push apart those folds that you may miss lesions on otherwise. So I've gone out, and you can see there's the jaws on either side at sort of 9 o'clock and 3 o'clock position, and you've got to be brave here. So you're gonna suck this lesion into your cap, and you're gonna hold down on that suction for a while till you get almost like a red out, as if this were a varix, is how I think about it, and you deploy your clip. And you should really expect to see immediate hemostasis here. And as John showed in his presentation here, the STING study, the STING-2 study showed a very impressive immediate hemostasis risk. So this is another case, actually. This is a very interesting case of a gentleman referred from elsewhere who'd had 2 attempts at conventional endoscopic therapy with clips for what was told to be a bleeding duodenal ulcer in the second part of the duodenum. So first things first, he's got fresh blood in his foregut, so there's an active bleed here. Again, distal transparent attachment cap. First thing I do, I've been caught out with this before, make sure they don't have a vessel or a lesion elsewhere. I've spent a long time looking in the duodenum and missed a bleeding ulcer in caesura. So just do that quick sense check yourself. So you get round to the second part of the duodenum where you're seeing a clot there in the 12 o'clock position. And this was a tricky one because access was challenging. So you'll see in a moment the lesion of interest will be on the right wall. And there's an ulcer here. And I'm not convinced this is just an isolated ulcer. This may be part of a separate lesion here, actually. So once I was comfortable with the position, I pre-injected with adrenaline here, quite liberally, just to kind of find my way a little bit better, settle any bleeding that was ongoing at this time. And you've really got to think of here now, when you go with your Avesco, what position are you going to place your clip? Yeah, think about the dimensions and the orientation of where you want your clip to fire. So it's not the same for all patients. And you can see I've agitated a little bit of bleeding here, which is what I like to see, actually. I want to see it bleed because I want to know that what I'm delivering will be effective ultimately. So a pre-injection here, and once that's complete, we'll load the Avesco device on. So I'm just demonstrating here. I've put the jaws here, the 1 o'clock and sort of 7 o'clock positions intentionally based upon what I've seen going in initially. So because of the actual position of this lesion, it's, for video purposes, it's hard to show it sucking on, but with the eye of faith, you'll see a really nice end result here. So get on fast to the lesion as much as you can. I should probably say this patient was tubed. It was done in the intensive care unit, and the patient was in kind of the safest possible place to do this. And that should really, I can't echo that enough. So again, suck really hard on here, and you're going to just watch for a real release, and you just turn that wheel till you can turn it no more, because you really want that clip to deploy fully here. So if we just wait a moment, we'll come back from here. And ultimately you will just see the clip having, there we go, there's a slight release, I don't know if you were able to appreciate that on the video, of the clip firing. And we'll come away from the lesion now, and I'll probably re-inspect with the cap on to make sure we have achieved what we'd call immediate hemostasis in this case. And so it was the angulation here that was tricky, and I can understand why they struggled locally. There were no clips on the lesion as well, actually. So whatever had been done before had come off, which was interesting to see at the start. So we'll just pull away slowly. And there's the clip that's been fired. And just a re-inspection here again. You want to make sure that you've done the job properly here. So. And you'll just see the clip coming into view here in the sort of 4 to 5 o'clock position. And I think we could be confident that we've achieved hemostasis. So the patient was then sent back to the local hospital afterwards. Just two examples of quite different extremes of GI bleeding and the utility of the over-the-scope clip.
Okay, yeah, no, a couple of very nice cases. Playing devil's advocate, that first case, I think that was the index. That was the index endoscopy. There was, probably a visible vessel there. Would it have been wrong to inject with adrenaline and apply a conventional clip? It would seem fit with John's algorithm, or were there features there, perhaps the broad area of ulceration, the relatively flat ulcer with the vessel at the bottom of it, which would say to you, do you know what, we want to grab that with an Avesco at the index endoscopy? What was your?
I don't think there's any right or wrong here. I think if somebody went with conventional through-the-scope clips in combination therapy with adrenaline, it wouldn't be wrong. My anxiety in that case was it was a rather broad-based ulcer, and I felt I wouldn't be able to get enough purchase if I used a standard through-the-scope clip. And it was, by definition, a high-risk lesion. You've got a visible vessel there. So we went with the Avesco to really get as much purchase as possible on this, and the patient did very well afterwards. And it's just being comfortable with the device. I think that's what John came to, being comfortable to set it up and use it routinely, and training courses will support that, like you said. And there's a little bit of an anxiety, I feel, with getting the Avesco out and setting it up.
Yeah, I mean,
but it doesn't take long.
And I'll be interested to get John, your view, because I think that you know, the scenario of through the scope clips is that they're through the scope, you're on the lesion, you're there, you're ready to go. I'd like to tease out the scenarios in which, John, you might say, "Yep, go with through the scope clips," versus nope. At the index endoscopy, this is where I would go for, coming out with the scope, putting the over the scope clip on, and going back down. Can you give some view on that?
Yeah, so actually, I would have gone with the standard approach for the first case, and I completely supported the clip in the second case. I think there were some very good teaching points actually in the video that Vinny didn't. So if you're dealing with a bleeder and you're just not sure where is the vessel, actually the injection of adrenaline, just slowing down the bleeding to allow you to identify exactly where you're going to strategically put your clip is a good one. I particularly like the idea that you injected downstream in the posterior part of the duodenum. That necessarily will bring the lesion on fast to allow you to deliver the endoscopic therapy. Which one? Well, look, I think there's a wave of enthusiasm around OTSC. We've seen it in this meeting. The data initially, Sting 2, I think, is a fantastic study. There was a pretty high failure rate in the standard therapy, so let's drill down in the evidence here. And I've had a chance to speak to the authors of that paper. Perhaps a tendency, because it was open label, to readily convert to the OTSC. So potential biases there, but nevertheless, good quality evidence. However, the Sting 1 study, again, you would be thinking we will be using OTSC in every scenario. But actually, having the opportunity to discuss this with other faculty, Professor Chu from Hong Kong, we don't see this degree of rebleeding. So I think it really boils down to how competent are you with the standard approach, because they actually recently had an equivalent study published, as you know, that perhaps allows us, with all technologies, to just take stock and say, look, yes, fantastic to have this in the armamentarium. Ready for prime time? I don't think so just yet. Rescue? Absolutely.
Okay, that's very interesting. And for decades now, we have been focused on dual therapy. Upper GI being dual therapy, and whether that is, whatever that dual therapy was, I think, over the years that has moved from probably being, adrenaline and some form of thermal treatment, very much to adrenaline and clips, through the scope clips. Over the scope clips, you mentioned the benefit of adrenaline, but do you think that there is, one should be, shall we say, mandated to still use dual therapy, even if going for over the scope, or does that complicate things further?
No, personally, I wouldn't necessarily advocate the adrenaline. I think if you've got a clear plan and you have access, because access, we have to obviously the difficult anatomical areas in GI bleeding, of course, are high lesser curve, posterior wall of duodenum. So they remain the difficult access points for example, OTSC. Beautiful case, first part of duodenum, anterior wall, that's going to be easy to deploy. Ultimately, George, I think we need to be careful that we're not over-treating, and so recognizing the lesions, that's where I made the point about the Forest classification, is that you and I can recognize a spurting vessel, and the really good data, actually again from Hong Kong, which showed a very high correlation coefficient for agreement for this. Whereas, a non-bleeding visible vessel, we were actually almost as good as a random choice as to whether what we were seeing was I'm talking about gastroenterologists and clinicians. So I think we need to do a lot on lesion recognition, and where, just to be a word of caution, I think there's an evolving message in the literature about the Forest 1B, lesion, perhaps being not quite as high risk as we thought before. And actually that's not true. What actually is happening is that there's probably a Forest 2 lesion there, a visible vessel 2A, with a little bit of ooze peripherally around it. That's being classified as a 1B. So we need to be really clear, in my view, about what we're dealing with when we start to make these differentiations, and are we really good enough to make that choice?
Yep, very nice. And John, I thought one of the things that Vinay showed, great teaching point there, was that in scoping a patient with an acute GI bleed, one's eye gets drawn often to the duodenum, because if there's blood in the upper GI tract, it's often also in the duodenum. And your really good teaching point about retroflexing, just being sure there's no bleeding elsewhere. And I don't know if the data's changed. You might tell us later, John. But the mantra about bleeding in the second upper GI bleeding in the setting of portal hypertension has always been that even in patients with portal hypertension, at least 30% of upper GI bleeds are non-variceal. Would you have any comments to make about the mechanism of doing a really good examination in the setting of an upper GI bleed?
Yeah, I think I guess our experience is in the sort of variceal or the portal hypertension setting, and I guess I don't know if the data have changed from what you just quoted, but I think it's correct that a substantial portion of patients with portal hypertension have non-variceal or non-portal hypertensive causes, and so before you go down with your BANDA, assuming you're going to scope someone with varices, it's important to do a very good diagnostic examination, idealised circumstances, unstable patient, ideally intubated, all the things we've sort of spoken about, to make sure you don't miss the lesion that's, a dura foire that's bleeding in a patient who happens to have cirrhosis and well-covered varices, for example. And we see that not that infrequently, to be honest, that the patients with varices actually are bleeding from a non-variceal source.
Yeah. Okay. Brilliant. Okay. So, wow, we've covered a lot of ground. We've talked about pharmacology and medical therapies in GI bleeding. We've talked about mechanical measures, clips, and both through the scope and over the scope. Let's move now to the other area that in various areas of diagnostic interventional endoscopy come in, and that is hemostatic powders. And we've got a couple of cases to show, just to inform discussion about them. Let's go to them.
This patient is undergoing an EMR for their dysplastic Barrett's esophagus. This is the fourth and final EMR, and it is being performed by one of our trainees. You can see that as the resection takes place, the trainee pushes the snare away from them, creating tension, and thus as we cut, the lesion is ripped from the mucosa rather than cut through. This creates an immediate bleed. It is successfully recognised by the trainee, who goes into the stomach and removes the elastic bands before pulling the scope out and cleaning the cap and clearing their views. The trainee then re-intubates the esophagus and finds the area of bleeding. The cap is utilised here to create tension against the esophageal wall to tamponade the vessel and therefore try to minimise the bleed and aid with visualisation. You can see now that the vessel has been identified, and the snare tip is used on soft coagulation to correctly coagulate the vessel. You can see now the vessel has been largely stopped, although there's still some ooze, and further soft coagulation is applied. The bleeding now has been entirely stopped, and the decision here is now whether one applies further hemostatic therapy to minimise the risk of rebleeding, or whether one is satisfied. The decision was made to use Next powder to minimise the risk of further bleeding. The catheter was passed through the endoscope, and you can see that by being able to control the speed of the powder being applied, one can ensure that you're getting an accurate coverage of the lesion, so that one can be assured that the hemostatic powder has been applied correctly without losing complete visualization. Once applied, the powder is then activated by applying water, which creates the gel. Bleeding from tumours is, as we know, a very challenging area and can be very difficult to control. Here you can see a gastric tumour that we applied laser therapy to in order to try and coagulate the area as best as possible and minimise the risk of ongoing bleeding. This you can see has been successfully applied to this patient's tumour. However, we felt, given that this was a recurrent bleeding tumour, that we could further provide hemostasis by using Next powder, which again was liberally sprayed over the tumour base and then activated with the gel. Hopefully that was a couple of nice demonstrations there of the application of Next powder. Now, what I wanted to do was demonstrate Next powder in the cold light of day and how to set it up, because what happens is we're called, it's 3 in the morning, we're exhausted, there's a bleed, and now we've got to work out how to set this thing up. And actually what I love about Next powder is it's very simple to set up. So it's a fantastic device with great innovation, and I'm going to demonstrate now. So the box comes like this, and I've actually cheated a little bit and taken some of the packaging away here to make my life a little bit easier in this demonstration, but it obviously comes in 3 separate packets. And what I'm going to do is I'm just going to demonstrate how to set it up so that when it happens to you in the cold light of day, hopefully you can set it up effectively. So very simply, all you have to do is take this part of the device and slide it in here, and you feel a nice reassuring click. You then have the little powder. Make sure you don't make the mistake of tipping it upside down. That'd be a rookie error. And all you have to do is screw it into the device here. And the final step for setting it up is just pulling out the little black piece of paper here. Now you're basically good to go. And all you have to do now is make sure your lever's down, and we're going to switch it on with a little switch here. Now, the advantage, and what hopefully I demonstrated in that example, was that this lever controls the pace of which the powder comes out. So you don't lose your vision by suddenly having previous iterations of hemostatic powder where you would press go and suddenly you have a whiteout. Actually, you can control the pace of the powder that comes out, make sure you're hitting the right target. The other advantage, which I'm going to demonstrate now when I switch it on, you'll hear the noise, is that it has a constant low pressure of air flowing through the channel of the piping. And what that means is that the piping itself doesn't clog up if it hits water or anything like that. So you don't have that problem of when you pass it through the scope and then all of a sudden you can't pass any powder out because it actually clogged up. So I'm going to switch that on now, and you'll hear a whirring sound. So there's the whirring sound of the paddle. And all I'm going to do now is just lift the lever slightly. You don't want to lift the lever the whole way. And you'll see that the spray just comes out in a controlled fashion. I can slow that down, or I can speed that up if I want to. And it just controls the power very nicely. So hopefully that's a nice demonstration of the hemostatic powder, and its lovely innovative creation there with the low pressure air that comes through the catheter and the controlling of the speed using that little red lever. So I'm going to hand back to my colleagues now to talk about the use of hemostatic powders in acute GI bleeds.
Okay, thanks, Dave. Again, this is these are the innovations that have come through over the last few years, and I think all of us have had experience where these hemostatic powders have made a difference in the individual patients. And Vinay, scenarios. What do you think we should be looking or expecting to achieve with hemostatic powders?
Yeah, it's a good question. I think I still think the jury's out about whether they will replace first-line conventional endoscopic therapy. I think we need more data on that. That's for sure. But there are certain scenarios where it may be helpful. I think Dave demonstrated very elegantly this very sort of broad tumour in the stomach, which was generally oozing, and so you can cover a very wide area there with a hemostatic powder, and there's good registry level data to show that can reduce important outcomes like transfusion requirements. So that's important. Anyone personally in whom I'm unsure about achieving hemostasis, or I'm concerned, maybe comorbidities, advanced stages, maybe someone that I may consider using it as well. But I think the jury's still out about whether we can use it as first-line therapy. I'm not sure what the rest of the panel think.
Well, John, and a scenario that we, well, both Johns actually, but a scenario that we occasionally are involved in, shall we say, sphincterotomy bleeds. Do you think there is a scenario in which hemostatic powders have anything, that can be a stressful situation? We all know that the mechanics of duodenoscopes and the duodenoscope bridge is that things like clips are difficult. We're worried about putting a clip across the pancreatic duct. Getting the needle out can be difficult. Do you think there is a holding measure? Do you think there's any therapeutic role, or do you think you just completely almost literally muddy the waters using hemostatic sprays in that setting?
Yeah, I have to say I don't have much personal experience of using them in that setting, but I guess the algorithm would alter as to whether you're in the position to do another ERCP or you're in an endoscopy room without fluoro or without the ability to do another ERCP.
Tell us why
So I guess I mean I think our normal approach is to use adrenaline injection to get immediate hemostasis, and then with a fairly low threshold now, I'd say, to go to another ERCP and place a fully covered metal stent to tamponade if you're in that position. And I think often the sphincterotomy bleeds that cause problems are often in multi-comorbid patients where their tolerance of repeated procedures is low. You want to do ideally a definitive intervention. Their other alternative is possibly quite large area of embolization via IR. So I think you want to do one definitive intervention that has the highest chance of securing sustained hemostasis. I think if you're in the setting of an unexpected sphincterotomy bleed where you're not in the position of doing an ERCP, and then there may be a role, because, as you say, getting a clip out of the end of a duodenoscope is a real challenge, and not for the sort of faint-hearted, just for the risk of pancreatic injury. So I don't think there are much data to guide that, but that would be my immediate sort of thoughts on that.
And I mean, thank you. And John, in other areas, there's not much data, but certainly, anecdotally, on occasion, I've had the experience where I think the bleeding point is in the first part of the duodenum or is coming from somewhere in the gastric fundus. I really can't identify it. And almost as a diagnostic test, I have occasionally used hemospray to see if then that exposes, if you like, what you might call a herald ooze. Have you ever tried that? Do you think that's
I understand.
Useless?
I understand exactly why you might do that. I mean, for me, the hemospray, the next powder, three main indications. One is rescue, and we've talked about that in a sphincterotomy bleed or some kind of catastrophic bleed. I don't think it's spray and pray. I mean, I think you need to have a target.
Spray and pray.
Having said that, the second category is of course bridge, where you know that you're not going to be able to stop. If you've got a fistula, you're not going to stop it endoscopically. You need to get that patient to IR. And of course, the third thing, and I think this is relevant particularly to hepatologists, is actually what I would call the orphan indication. So we saw a beautiful example here of managing a bleeding gastric cancer. Traditional endoscopic methods are very, very poor at stopping that. But where I really think it has got a role is actually in the post-banding ulcer bleed, which again traditionally has been very difficult to treat, and we've used it very successfully in that circumstance.
Interesting. And extension of that, you're going to be telling us about varicose bleeding in a minute. Again, the problem of YouTube. You can go onto YouTube and you will see people who have said, "Oh, this patient came in with an esophageal varicose bleed, and I used a hemostatic spray, and all was wonderful." Do you think there's any logic to that being the case, and do you think there's, and I don't know if there's any evidence to that being the case?
I think the limited evidence that there are suggests that you might use that as an out of hours absence of a of an experienced endoscopist to deliver more definitive endoscopic therapy for variceal hemorrhage as a temporizing measure and as a bridge to a daytime, say, endoscopy with for example, band ligation as the standard of care. I don't think the data would support that hemostatic powders would be the solution to a sustained solution to variceal bleeding.
Okay, very good. And a point that I think we alluded to a little bit earlier, but it's something that in the UK is of importance and maybe elsewhere is anaesthetic support. So anaesthetic support, we know that these are the highest risk patients for multiple reasons, comorbidity, large hematemesis, etc. John, again, sorry, wearing your VP endoscopy hats, we a few years ago had a hard push, and I think quite a successful push, to say within our practices, certainly for complex elective therapeutic endoscopy such as ERCP, we really should be having an anaesthetist involved. What about the acute out of hours GI bleeding service? Is it something that we should be pushing for, to have an anaesthetist, mandated perhaps to be part of the service?
I'm not sure if I would use the word mandated, but I think it offers a huge advantage, George. So that ultimately, when we're talking about successful endoscopic therapy, we're talking about delivering effective therapy, but access is important. So your case where you have a lot of blood clots, so we've got to know how to get access to the lesions. We've got to we can't deliver effective therapy. So, for example, the ESG guideline on variceal bleeding is advocating the use of IV erythromycin as a prokinetic ahead, because the blood clot is the enemy of successful endoscopic therapy.
Yep.
To allow us to do that in a measured way and not be worrying about, so I'm not sure we definitely need an anaesthetist, but actually make sure you've got an ITU fellow or someone there that can help to make sure the patient is still being managed in terms of ongoing resuscitation. And if there is any question of compromised capacity, then by that I mean the patient's obtunded or confused, absolutely.
Okay.
Do this with anaesthetic support.
Yeah, right. Certainly anecdotally, many years ago, doing endoscopies on encephalopathic patients with variceal bleeds, you can have a wonderful endoscopic outcome, and the patient who's aspirated and with a bad outcome, that can be.
But the other part of that team is the surgeon. Whilst the surgeons have backed away from active involvement in out-of-hours GI bleeding, if you're coming in the middle of the night, if you've got a patient who's requiring blood to be put in under pressure, get the surgeon in the room with you. They're not going to be involved in the initial resuscitation. But if the patient's intubated, the patient can go straight to theatre, and I've had this experience, over many years, straight to theatre, surgeon is there, saves the patient's life.
Yeah, I think that's gets back to your point about bundles of care and delivering the service, that we can tend to think in upper GI bleed in terms of, right, what are we going to do with the endoscopy? But as Vinay discussed a little while ago, understanding the pharmacology, the extent to which that may impact on care, but also, what's plan A, what's plan B, and if we don't get endoscopic control, it's no good then waiting another 3 hours to see if you've got control, and then in a huge emergency contacting interventional radiology or surgeons, as you say, at the very least having their involvement and their awareness, if nothing more, I think is really important. We'll be moving on in a short while, but Binay, John actually mentioned blood clots. Are we still pulling clots off bleeding ulcers?
Well, I personally, depends what situation you're in, and it depends who's doing the endoscopy. I would say if you're comfortable to deal with the consequence of removing a clot, and you're competent to make that decision, and that's a question for a whole other forum, where that competency comes from and how you measure it, then yes, you should do. I think there's also lots of little tips and tricks that you can do to actually manipulate clots. So you could actually move the patient. You could actually, they don't always have to be in the left lateral position. You could put them prone or supine, and you could also use Roth nets and removal tools to actually improve access and visibility, really. And those are the little tips and tricks that you can do, and much easier when the patient's sort of airway is protected and fully asleep.
But also that point about, having in place the next plan.
Yeah.
It's no good saying, right, give me a snare to take off this clot, the ulcer hoses, and then you're then wasting that extra 2 minutes while somebody goes to get the clips or goes to get the adrenaline, or I'm sure you've seen that, John, as an example of suboptimal care, that sort of scenario.
Yeah, and we've seen some fantastic endoscopy in the last 2 days, but this is not a single operator procedure. This is a team game. We talk about endoscopy non-technical skills, team briefs. So 100%, before I would start on a bleeder, briefing the team, have we got injection? Where is it? Yep. If this goes wrong, where is the blood? And don't tell me we've lost the cable for the diathermy. Let's get that all ready. And where is the next powder or the hemospray? I don't want it in the next room. I want it in this room.
Yeah.
So that we're absolutely good to go.
And the blue Venflon in the back of the hand and all the.
And I think the other issue here is, on the occasions in the UK, for example, where you do have to come in out of hours, it's very unlikely that you'll have your endoscopy team with you. So they're actually trained to use these. So it's critically important that we are able ourselves to use these devices. Yep. The devices rarely, if ever, fail. Actually, we as endoscopists fail to not be competent enough to utilise them.
Excellent summary yet again, and that actually links us very, very nicely to the area that probably more than any other in GI bleeding requires the awareness and the presence of a skilled team, and that is the area of portal hypertension and gastroesophageal varices. So delighted to go over to my colleague John Potts to tell us where we are with this really important area.
Thanks very much for the intro. It's a real pleasure to be here and talk to you for a few minutes about variceal management. So I'm a hepatologist and biliary endoscopist working at the Royal Free. I've got a large number of colleagues who specialise in portal hypertension, and so I've benefited from their expertise in preparing for this. I'll just go on to the next slide if I may. So I've got no significant disclosures. Next slide, please. So I'm just going to go through in a few minutes, revising the evidence on surveillance and prophylaxis for esophageal and gastric varices, because there's some major changes that have occurred in the last few years. And then I'll focus talking about acute variceal hemorrhage, the initial treatment and non-endoscopic management, then just go through some tips, tricks and pitfalls at the endoscopy, and then also discuss the post-endoscopic management. So if we go to the next slide, please. So variceal surveillance, there's really been a paradigm shift in the last few years, and the current BSG guidelines are from 2015 with an update around the COVID-19 pandemic. And really the focus even 7 years ago was all regarding endoscoping all cirrhotics at diagnosis, judging on the basis of medium or large varices or those with high-risk stigmata for bleeding, regarding prophylaxis with beta blockers, and then annual surveillance scopes for those either with grade 1 varices or every 2 to 3 years if patients didn't have varices. And really there's been a paradigm shift that's been driven by a change in the way we think about advanced chronic liver disease, and really that actually variceal bleeding is a representation of the progression of the underlying liver disease, and the focus is no longer on endoscopic stigmata but really on the presence of clinically significant portal hypertension. And so that's a hepatic venous pressure gradient that exceeds 10 millimeters of mercury. That's clearly an invasive procedure measured via the transjugular route and not available in all centres. But there's an increasing recognition that there are lots of tools that we have available to us in many hospitals that allow us to non-invasively diagnose those patients who do have clinically significant portal hypertension. And that's based upon the combination of the surrogates for portal hypertension in the terms of thrombocytopenia and also the liver stiffness at transient elastography, i.e. FibroScan or other similar technologies. And what's become very clear and is from the Baveno 7 guidelines published last year after the discussion conference, is that actually those who've got low liver stiffness measurements, less than 15 kilopascals, and without significant thrombocytopenia actually have a very low risk of having high-risk varices. And these patients really, potentially we could undertake either no surveillance or do a single scope at diagnosis and then just survey them non-invasively with liver stiffness measurements. The Bavena guidelines have moved further still, and this has not yet been incorporated into the major society guidelines like ESGE, but potentially there are a population where the liver stiffness measurement exceeds 25 kilopascals, and actually those patients may just benefit from non-selective beta blockers regardless of endoscopic findings without the need for surveillance. Carvedilol is the preferred prophylaxis now. It's a once daily drug, generally better tolerated. In terms of the role for primary endoscopic band ligation, this really is reserved for patients who have been proven to be intolerant of non-selective beta blockers. So the patients coming to your surveillance list that are still going on really only are getting band ligation if they are intolerant of beta blockers. And I'll just give a quick plug to a UK-wide trial being run by colleagues at King's, which is a trial looking at patients with small varices that to this point we would not have given prophylaxis to, and randomising those patients either to beta blockers or placebo and looking at the development of variceal hemorrhage or other decompensating events. And that's a trial I'd really encourage you to engage with. So if I can go on to the next slide, please. The rest of the talk is going to just focus on the endoscopic management. And I guess this is probably the most important and what I would say is the take-home slide, because really the foundations of a successful variceal bleed admission are founded in the pre-endoscopic management. So as Vinay has said, this is resuscitation, 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 but over and above that there are some specific things for the liver patient that you need to be considering and doing. Antibiotic prophylaxis is well evidence-based. There are concerns about antimicrobial resistance, but broad-spectrum antibiotics for between 5 and 7 days in all comers with cirrhosis presenting with GI bleeding. We know well from the New England Journal paper that a restrictive transfusion strategy is advantageous, and that particularly is the case in child B cirrhotics. Appropriate correction of coagulation factors and the appropriate use of vasoactive drugs like terlipressin. And as we've heard, this is a team approach. The patient's going to get through the episode with the help not only of endoscopy, but gastroenterologists, hepatologists, and your critical care colleagues. The ESG guidelines now recommend prokinetics such as erythromycin to improve endoscopic views. And really these are the patients we should be prioritising for out-of-hours endoscopy once they are stable to do so. I would highlight that the need for airway protection should be considered in all comers with unstable GI bleeding, but no more so than in patients with variceal bleeding. And if your patient has hematemesis and or any grade of hepatic encephalopathy, you should mandate that they have an airway protected endoscopy. And if this is the foundation on which you build your house, and if you get this wrong, unfortunately everything else that follows will fail. So in terms of esophageal variceal management, the standard of care remains variceal band ligation. We've spoken a bit about this already, but careful examination, often without the bander, to assess the bleeding site and get your landmarks, ensure that there's not a secondary source of bleeding. Banding tends to be undertaken from the GOJ up to a maximum of 10 centimetres and normally within the 5 centimetres distal to the esophagus. My practice is to inspect after each band is placed for proximal decompression, and as is often the case in endoscopy, less is more. 3 to 5 bands are normally sufficient. In terms of the role for sclerotherapy, then there is still a role potentially for glue injection even in the esophagus, although the standard of care remains variceal band ligation. I don't know if the video will play, but this is a case where uncontrolled bleeding mandated an urgent intervention. I'm sorry the video is not playing ball, but where we use glue in the esophagus, which is very occasional but can still be performed, and glue is probably preferable here to sclerotherapy. Moving on to gastric varices, so band ligation is not recommended outside of gastric varices that are in continuum with esophageal varices on the lesser curve. So the standard of care for gastric varices is glue embolization at initial endoscopy. We've just heard that preparation is key, and I think if you've got a patient with variceal bleeding suspected, you should prepare all the kit in advance, even if you don't open it up, to have it available in the room. And if we know that a patient has got gastric varices either on a previous examination or on their imaging, we prepare all this kit in advance. I think if you've got the ability in a stable patient to consent them specifically for this, then you should do, because there are significant risks of glue embolization, particularly causing stroke, as is shown in this CT. We inject with saline first, check there's no subcutaneous bleb, and then our practice at the Royal Free is to use a 50-50 mix of glue and Lipadol, rarely using more than 4 mils. And I'd recommend you use a saline chaser to flush out the needle as you withdraw it and avoid some of the problems that can occur. We do follow these people up, but only once with a single examination. Going on to the sort of gluing pitfalls, I hope these videos will play, but this is from my colleague David Patch's directory called Brown Trouser Moments, and this is an injection of glue into a gastric varix where you can see sort of top slices of the gastric varix, and a steady hand and a beta blocker itself is probably required by the endoscopist to regain control of that situation. The other scenario that one wants to avoid is gluing the needle into the varix and that becoming attached, and you can see that will be a fairly anxiety-inducing moment. And really the use of a saline chaser as you withdraw the needle helps to form a glue plug, and that would be one of my tips for gluing gastric varices. And because these come up fairly infrequently, they're obviously a source of understandable concern for trainees. In terms of rescue therapies, I think all those undertaking a GI bleed endoscopy should be able to place a Sengstaken and Blakemore tube. I think it should go without saying that airway protection is essential, so this should only be put down in intubated patients. You can use air in the gastric balloon or alternatively some water mixed with a small amount of contrast. Key is to never inflate the esophageal balloon, which can cause a significant risk of esophageal rupture. There's a variety of opinions as to how one applies traction. Our practice is to apply tape traction to the face and not to apply weights or bags of fluids, and always to deflate after 24 hours. And hopefully the video here will play just showing one of the risks of using. I'll try and go back to that. I don't know if the video can play in the middle. Just showing that the risks of a Sengstaken and Blakemore tube where it migrates into the esophagus. And I'm sorry that the video is not playing ball, but if we can go back a slide. Thank you. So the video there, if the team can get that to play, shows an esophageal rupture caused by migration of a gastric balloon up into the esophagus, and that caused significant injury and mediastinitis. And as you can see here, this is a sight you never want to see. And that was managed with a Danis stent. And actually the patient made a recovery after TIPS management for their variceal bleeding. Just coming on to Danis stent, so we've spoken about the post-banding ulcer bleed, which is often very challenging. If we can just play the second video there, the Danis stent is a covered esophageal SEMS that one can leave in for up to 14 days. Our experience is that the best use of these is in post-banding ulcer bleeds and as a potential bridge to a TIPS, or indeed in patients for whom they don't have a curative option, and this might be a palliative measure to allow them to be extubated from the ITU. I'll move on just to my final slide. So the post-endoscopy management really is also key. I think when you're doing a scope for variceal bleeding, an NG placement for feeding is vital. Aim to extubate the patient early and wean off terlipressin, watching for ischemia in the fingers and also cardiac ischemia. Institute secondary prophylaxis with a beta blocker and have a plan to rescope the patient at between 2 and 4 weeks for further banding. Have a rebleed plan at the outset and document it. Are you going to rescope the patient? Should they go for a potential consideration of a TIPS, in which case they need a CT to assess vasculature? Is this someone that really has very few options and whom a Danis might be appropriate? And then also have a longer term view. What's the trajectory of this patient's liver disease? Are they a transplant candidate? Is this someone that you should consider for preemptive TIPS? And the Kaplan-Meier curves there show some data from 2010 showing the benefit of early preemptive TIPS over and above drugs and endoscopic band ligation, which has a sustained survival and rebleed benefit. Is this patient someone actually for whom palliative care is likely to become appropriate? And often it's a parallel plan between the three. So just to sum up, in 2022, we're being guided by surrogates for clinically significant portal hypertension in who we survey. The acute bleed, I would say, is largely dictated by pre and post endoscopic management. But in 2022, child A and B cirrhotics presenting with variceal bleeds should be surviving their episode, and that should be a quality metric that we stick to. And finally, think TIPS, transplant, and potentially palliative care if it's appropriate. Thanks very much.
And some take-home slides that we should probably have on our phones. We're going to show a case relevant to your talk, 43-year-old man with alcohol-related liver disease, grade 2 esophageal varices, who presented with a significant fresh hematemesis and tachycardic, hypotensive, all the things that suggest his patient's having a hemodynamically very significant bleed, who underwent endoscopy, which we're going to see now. We're using the Pentax gastroscope and the Cook 6-shooter multiband ligator. And the focus and outcomes of this is to formulate a hemostasis strategy on initial inspection and to outline the endoscopic management, including the potential role of banding and other approaches, how we band, and the technique of deployment, and the subsequent management strategies, some of which have been discussed for variceal bleeding in the setting of suboptimal hemostasis. So, Vinay, I think you know this case.
Yeah, probably beats the record for the highest lactate I've ever seen in someone still cerebrating. So this was actually a very recent case, only a couple of weeks ago. So you can see here some pretty sporting esophageal varices here. I think you'd find it hard to miss them here. So very, again, coming back to the primary points here, patient was tubed, done in theatres, pretty urgently actually, and it was a very clear plan to get the banding kit on and deliver therapy. And it's interesting to hear John's comments earlier about less is more. So I've often seen a lot of bands inappropriately fired here, and actually you want to just get less bands but more effective bands placed on this. John, do you ever have a cut-off for the number of bands you're going to place? Is there I say no, I'll stop now, or is it based upon hemostasis?
I think if you're using a second bander, you need to ask whether that's the right thing to be doing. Because if you've not got chemostasis after that, you're probably not going to win, and you may cause more problems down the line with ulcers. And so I don't think there's actually an absolute maximum number, but as I say, our mentor at the Rule 3 sort of frowns when we've used more than 5.
Right.
Can this is a nice case to my mind, demonstrating that it can sometimes be quite difficult to advance the scope with the bander on it down to the lower esophagus. Do you in this setting avoid the wider therapeutic gastroscope, or do you think that doesn't have any great bearing on whether you can then safely pass the scope with the banding kit on the end?
Personally not. I think if you just ask your anaesthetist for a little bit of jaw thrust, I think that often is sufficient. But that's just come from experience of introducing bulky devices like the TIF and the Apollo device. So a liberal jaw thrust usually will get you through. And do you think we should always, John, be going down for a diagnostic gastroscopy without the banding kit on, coming out and going down again, having confirmed the problem? Or are there scenarios in which you say, this patient was in, a few weeks ago with big variceal bleed, we're likely to be banding again, we're going to put the kit on before doing the index examination?
There's a temptation to do that second thing, but no, I would go and have a look here because, as we had said earlier in the session, there is definitely a chance that this is not what, bleeding from what you think. And you've got this situation under control, patient resuscitated, intubated. I don't think I've ever gone down with the bander de facto as a primary intervention.
And John, the clear teaching being shown very nicely here is to be absolutely sure that you get a readout. Have you seen the scenario in which there isn't a readout and there is then trauma to the tip of the varix and even more bleeding? Or
I think you can get that scenario. I think the thing that's very difficult is often in the under-resuscitated patient who's had a massive bleed, the varices have decompressed, and actually then delivering endoscopic therapy itself becomes very challenging, because here you've got nicely distended varices and you can target on your red signs and where the sort of smoking gun is, as it were, from the bleed. But I think particularly if you've got an under-resuscitated patient, the scenario you're describing of a sort of shear of the varix as you try and suck it up is higher risk.
Okay, now you've got 20 seconds each, and if John hasn't got time, we'll let him off, to give us the two approaches that you would like to see that will improve the management of GI bleeding care. John, then Vinay, and then John if he's thought of a couple.
Well, I guess for me it's everything we talked about today, but actually additional things. If I go down a patient that's been hemodynamically unstable and I can't find a bleeding point, I'll give 10 milligrams Buscopan, because it just will release the spasm around and also perhaps at the incisura, particularly in the pyloric channel, so you find your bleeding point. And I guess the second thing, and it's probably relevant to the variceal bleeder here, occasionally you go down, there's so much bleeding that you really have no idea. So make a conscious effort to document on your index endoscopy where's the OD junction, and even if you cannot see, start banding at that point, because very often the bleeding will shut off.
Okay, great, excellent. Vinay?
My one comes down to really...
it's two, it's not just one.
All right, having a bit of a surgical hat on, all about access. So the more access you have, the better you'll be able to deliver your treatment. So, and it's usually something simple. So for me, a water irrigator, having that available for all bleeds, and a distal transparent attachment cap is kind of my de facto approach for any GI bleed.
Excellent. John, we've put you on the spot. Wasn't warning you.
I think it's knowing when you're not going to win and pull out, and have a plan B strategy, and think about things like TIPS and non-endoscopic therapies.
Perfect. Excellent. Fantastic conclusion. And I think we are now going on to a presentation by Professor Philip Chu from Hong Kong. Absolutely delighted to have him with us to bring us up to speed in just a couple of minutes with the present state of play of robotic therapeutic endoscopy.
So what a fantastic section on GI bleeds there. That pretty much covered everything you need to know about GI bleeds. But if I'm honest, this section was the bit I'm most looking forward to in terms of the whole of London Live. So I apologise to everyone else that's contributed, because this is the bit I've been most highly anticipating. So without further ado, I'd like to hand over to Philip Chu, who's going to talk to us all about the current state of play of robotic therapeutic endoscopy. So Philip, over to you.
Thank you very much. And I'm really honored to talk about the robotic endoscopic therapeutic system. So may I have yes, thank you so much. My presentation is about robotic therapeutic endoscopy, present and future. So these are my disclosure. So I think looking into the trend over the next 5 years, the early diagnosis of GI cancer will be greatly enhanced by the development of AI in endoscopy. And also we are looking into technology like liquid biopsy. And most of the government around the world is now accepting cancer screening program. With all these effects into the place, that there could be only one end result, which is increasing in the potential of therapeutic endoscopy in treating early GI cancers. So for treatment of early GI cancer, for locally curative intent treatment, then endoscopic resection will be the option. So for endoscopic resection, I think all of you know about ESD, and currently it's not only a locally curative intent treatment, but there is a concept of organ preservation. With the current technology advancement in image guidance, actually we can see a much better dissection over the submucosal plane, and also a more precise observation of any bleeding vessel. And the patient have a better postoperative outcome in terms of a shorter hospital stay and early return of the GI function. But I believe that everybody knows also the difficulty in performance of ESD. And this is a nice photo given to me by Professor Nakajima from Japan. In fact, it illustrates the point that when we are dissecting, we are moving our knife over our forehead attached to in a line with our eyes, like the endoscope sticking the knife over the therapeutic channel. So you can imagine the difficulty in manipulation of the endoscope towards a precise dissection field. And what will be needed for future development of therapeutic endoscopy, I believe there will be an improvement in imaging. And of course, the 3D or 4K imaging will better enhance the observation of the dissection field. And the secondly will be the tissue traction and dissection device. And if we even needed a better tissue approximation device in case we have difficulty in closing the defect. So I have been collaborating with Professor Lawrence Ho from National University of Singapore and Professor Lawrence Free, who is the chief engineer of this system called the Master and Slave Transluminal Endoscopic Robot. And this is actually a robotic arm mounted on a conventional double-channel endoscope. And we have actually conducted the first cohort study with 2 patients from Hong Kong, 3 patients from Hyderabad, India, receiving the robotic gastric ESD back in the year 2011. And at that time, our study demonstrated the feasibility and safety of applying this robotic system for a gastric ESD. So you can see from the image that we have one arm for tissue traction and the other arm for tissue dissection, provided through a conventional double-channel endoscope, which is a very stable platform. Unlike the performance of ordinary ESD, we actually have a fixed distance between the dissection field and also the manipulation of the robot arm. But this system is available only as a prototype. So in order to bring the system and the technology forward, actually this new system is being developed called the EndoMaster E system. It has a totally newly designed flexible endoscopic platform with built-in imaging and also working channel for 2 robot arms and 1 for accessory. And there's also an independent water jet system for clearance of the dissection field. And so we have actually conducted an animal model study for tests and proof of the concept for this system. And we have conducted ESD procedure using the EndoMaster E system in the esophagus, stomach, and also colon of the porcine model to confirm the safety and feasibility of controlling these 2 robot arms and for the performance of ESD. So this is one of the procedure of the animal trial where we are first incising on the mucosa, and after adequate mucosal incision, then we use the left arm to lift up the mucosa and continue the submucosal dissection. So this data has been recently published in the GIE in 2020 on our colorectal series of the robotic ESD and confirming the safety and efficacy of this system. So the trial is a preclinical, and you can see that the average operative time is 73 minutes, and the dissection time is 51 minutes, and the size of the specimen varies between 25 mm or up to 50 mm in size. There was no perforation in this preclinical cohort study. And because of these good results, we actually started on the clinical trial. So at the Prince of Wales Hospital, Chinese University of Hong Kong in May 2020. This is the endoscopy room set up for the Endomaster trial. So you can see the arrangement of the patient, and there will be a patient all put under general anesthesia with a surgeon controlling the robot arm over the surgeon console. So the patient usually started over at a left lateral position under general anesthesia. So this is a video clip to demonstrate the whole procedure of this robotic ESD. And this video is played at around 4 times the speed of the normal procedure speed. So this procedure lasts around maybe 5 minutes in the video clip. So that the total procedure time is like around 30 or 45 minutes. So you can see firstly we would put the right robot arm over the 6 o'clock position, and then afterwards we will insert the left robot arm over the 9 o'clock position. These positions of the robotic arm are ergonomically designed to maximize the best use of the limited size of the endoscopic platform to maximize the performance of these 2 robot arms. So you can see ergonomically the left side arm will be lifting up the mucosa, while the right arm is for the dissection. So the lesion were actually having a pre-injection of some mucosal solution using the Orice gel. And for the mucosal incision, I planned it to actually allow a more mucosa over the near end of the lesion. So one of the reasons is because you can see when we are grasping using the left robot arm, we need a certain amount of tissue for the grasping. So for the mucosa at the near end, we need a little bit more of the tissue to allow us to have a better grasping of the specimen. So, and then afterwards, we would continue the submucosal dissection. And this lesion is around 40 mm in size. So basically, we actually need around 5 centimeters of a dissection of this lesion to ensure an adequate resection margin. And when we are performing this dissection, because of the large area, we need to work actually bit by bit from the different area of the dissection at the submucosa. So you can see now I move back to the right side for the submucosal dissection. Meanwhile, I pay attention to the border of the lesion to ensure that I will not jeopardize the tumor resection margin. And you can see there are actually bleeding that can occur all the time, but using this robot arm, I can actually achieve a good hemostasis. And at the same time, sometimes when we are bleeding over a area profusely, we can just skip that area, avoid that area, so go to another area and continue the dissection to open up more space. And after a while, when I go back to that area, in fact, the hemostasis is much better because the bleeding already slowed down or even stopped temporarily for me to achieve a good hemostasis. So you can see now we are lifting the mucosa while using the left arm and continuing the submucosal dissection. So during this trial, we also think that one of the learning points from using this system is that probably we can open more circumferential mucosal incision in order to allow a complete circumferential incision before some mucosal dissection, so that we can ensure an adequate lateral border. And also you can observe when we have not inadequate submucosal injection, we can always continue further submucosal injection using the needle over the accessory channel. So now we are dissecting over the oral side of the lesion, and that the use of the arm again will be demonstrated by lifting the tissue, allowing us to observe the adequate submucosa. So, we have actually given some buscopan in this case, but still there are significant spastic contraction of the colon. But I think the robot arm actually overcome this spastic contraction by lifting the mucosa adequately. So then I think we also need to open not only the right side of the border, but also over the left side. And you can notice that when I'm opening up the mucosa of the left side, instead of lifting the mucosa, I'm compressing the colon wall. And I think this is another tips and tricks that I learned from using this robotic system, that we can compress on the colon wall in order to expose the mucosa and the surgical dissection plane. So that's probably the tips and tricks, and also not usually available when you're using the conventional endoscopic instruments. So even the usual non-robotic traction technique only pull away, but they will not be able to allow you to push away the tissue. So now after dissecting over the right side, I need to actually tackle the left side, because that is the area that we have needed a further dissection. So we continue the submucosal dissection with the use of the robot arm. So again, unlike the conventional ESD, while we are dissecting really close to the submucosa, now we are moving quicker using the right dissection arm, the trochanteric arm, when you are exposing adequately at the submucosa. So unlike the conventional ESD, where you are moving your endoscope together with the knife for the dissection. So if you have a good position and a good traction, then theoretically this system allows you to have a better dissection, or even a quicker dissection over a wide field of the lesion. So now we are trying to use another tips and tricks, which is to cross the two robot arms, so that I can expose the submucosa while using the left arm, and then the dissecting using the right arm. Because we cannot interchange these two instruments, but we can actually cross the two instruments in order to allow a better traction. So this is another tricks that I learned from this clinical trial. So this is almost the final part of this dissection, and you can see that I am now trying to dissect at the submucosa over the left side, which is actually the gravitational area. So adding towards the advantage of this robot system is in fact the use of the gravity. So again, good planning will be important for the performance of the good ESD. So not only relying totally on the robot arm, but also the natural retraction forces like using the gravity will be also important. So I think this is almost like the final part of the dissection. So now I am trying to again lift up the mucosa and then continue the submucosal dissection all the way to the far end. So, and as I mentioned, if you have a good lifting, then the dissection speed will be actually quite fast using this system. And I think there are also, of course, the limitation in the system. If your lesion is placed over the 1 o'clock to 3 o'clock position, then it's very difficult to use the system to try to do the traction and the dissection at the 1 to 3 o'clock position, because as you had noticed, these two arms are located in the opposite side. So you need to strategically place your lesion to the most ergonomic position to allow the system to work. And so if there is any smoke or any solution that actually stick on the lens, you can actually use the water jet to clear the lens. So this is the final part of the dissection. So after this opening up of the final mucosa, then we can complete the dissection with the use of these two robot arms. So you can see actually most of the cases in the clinical trial, we would be only using the 2 robot arm without the need of additional device or traction device for the completion of the dissection at the submucosa. And so far we have actually performed 43 ESD using this Endomaster system and recruiting 45 cases. So 2 patients were excluded after inclusion because of the advanced stage of the tumor that we found upon preoperative CT scan. And while 43 cases successfully treated by the use of this Endomaster with the ESD. So this is the final part of the dissection, and we take out the specimen with the system, and this is the defect after the dissection. So as I mentioned, these are the results. And actually, most of these cases are located over the left colon or the rectum, but we do have a few cases over the proximal transverse colon and also the right colon. So the complete resection rate is 83.7%, or broad resection rate is 82.5%. The mean size of the specimen is actually 36 mm in size. And I think the current development of the endoscopic system using the master is not only on the dissection, and we are working on the robotic suturing and basing on the master robot. So in future, I think this system will be able to manage GI emergency, closing perforation, or even doing full fingerless resection. So in summary, endoluminal robotics enhance the performance of endoscopic submucosal dissection through a dynamic tissue traction and precise dissection. Our clinical trial confirmed feasibility and safety of the colonic ESD using the Endomaster robotic system, and the future development of suturing allow tissue approximation and will extend the indication for robotic endoscopy. Thank you very much.
Thank you so much, Philip. What a fantastic lecture. I'm delighted in this section to be joined by my colleague at UCH, Matthew Banks, and Amrita Sethi from New York. And actually, a little plug for Amrita here. She's got her NYSGE course next week. So if you're in the New York area and get to New York, please attend it because it's a fantastic course. I was there a couple of years ago and it really was amazing. Now, Amrita, coming to you initially, actually, that was, I mean, unbelievably cool to watch. I loved every second of it. But we've seen over the last couple of days, you know, the outcomes of ESD are really effective. We've seen some great ESD outcomes. We've seen people perform it beautifully well. So what's the unmet need that robotic ESD or robotic endotherapy is answering for us?
Yeah, so that was beautiful. And it's actually watching that, you know, even just a little conversation between us, anyone who doesn't do ESD looks at that and says, that's amazing, I want to do that. And, you know, for someone who doesn't do ESD, how do we get them to not doing ESD, seeing that video, seeing what the potential is, the outcomes that we can have for our patients, and getting them to be able to do it as quickly as possible. Right now, it's intimidating because we know about the traditional avenues to train in ESD, years of observation, you have to pick up the skills slowly, you have to have preceptorship training, and in our current practices, perhaps differences in the US compared to other places, but our current practices don't allow for that amount of time to adapt this type of innovation. And so having the robot, I think, takes away many of steps that are involved in that long period of training and may help us teach and learn this technique so that we can bring these outcomes to our patients much faster. The other aspect that I think has been a big topic these days is ergonomics. And, you know, I was just commenting that if we compared you sitting at the console to someone doing ESD, perhaps someone not as experienced as the Japanese, you know, our bodies are all contorted. We're dealing with the loops in the colon, for example, and really hurting ourselves to a certain extent. We're taking a long amount of time, many hours. So how do we get rid of that burden? And from what I could see, this really allows you to stay still. It takes away the challenges that a difficult colon might present. to ESD, and it really brings it right back down to the technique. So I think
absolutely. I mean, I know from doing ESD, my arms and my shoulders are aching after a little period of time. Maybe I'm taking too long. I think that's probably the problem. Matt, you've obviously tried the robotic stuff. You had some questions and points for Philip, didn't you?
Yes, Philip, great lecture. It's lovely to watch it in action and to see. I think you and I have been going out there for nearly a decade from the first iteration, and to see how it's progressed has been quite amazing. What would you see as the main advantages, other than those described by Amrita in terms of teaching and learning, as well as the ergonomics? And what potential disadvantages do you think there are?
Yeah, I fully agree with Amrita that the robot actually allow us to have a improvement in the learning curve, I believe. And secondly, the better ergonomics, which will allow our professional life to extend. And so I personally actually also have some shoulder and also elbow pain after a prolonged ESD procedure.
It's not just me, thank goodness.
So and then I think also perhaps this system is having advantage for a big lesion. So if you have a big lesion, even the best expert will spend a long time, and also that the ergonomics about the positioning and everything, actually the robot will be able to allow a better traction even without repositioning the patient. Sometimes we also need to reposition the patient several times in order to allow a better traction. I know that currently we have traction devices available, and of course they are low cost and effective, but at the same time, as I mentioned, this system allows you to have a dynamic tissue traction. So you can repeat traction in all the direction in different time of the needed. So when you are, for example, using a clip or the loop or the line technique, you can only add one more, but you can reposition, but that could be difficult. But for this, it is very intuitive. You just grasp another area and track to another direction, then you can allow a better exposure of the submucosa. So I think the difficult lesion or big lesion will also be indicated by use of this system.
I have a question actually. Does this eliminate the need to change the patient's position?
Yeah, I think if you place the position in the right position at the very beginning, then in our trial, we almost never reposition the patient.
Yeah. No.
That's a great advantage. Go on, Matt, sorry.
You do need to reposition the scope as you're moving forward. So this is very much a non-fast technique, very different to using IT2 knife, for example. Yeah. So after you've moved a centimetre or so forward, you then need to reposition the scope, but that only takes a few minutes. So I think one of my greatest concerns with traction techniques, and this is something we were talking about a little bit earlier, and Endomaster, is a little lead to a de-skilling of ESD. But perhaps you leapfrog ESD and training goes straight from those who do therapeutic endoscopy straight to robotics. And I think that's a huge advantage to this technique, because one of the biggest obstacles in the West for ESD expansion is training. To do it well, training takes a long time.
I think it's important that anytime we're talking about new techniques, is that we stress that we have to know the principles of it and remain true to the principles. So whether we're teaching with traction or teaching conventional methods, is making sure that people understand the layer, the planes that we're trying to achieve, the purpose of that for pathologic assessment, prevention of perforation, that sort of thing. And I think that's the important thing to keep in mind because these techniques will change, right? If you talk about pocket or tunneling techniques, we're now no longer saying you have to do a circumferential incision, and so our conventional techniques change, and I think there may be resistance to some of that when you have people doing this for a long time, but I think that as long as we maintain those principles, then having these new types of innovations that make it easier and safer.
I think that brings us nicely, I think, to I guess my last question really, and for Philip's sort of last comments is, I noticed, we noticed that as the ESD case was happening, the arms, I don't know why I'm doing this, but you know what I mean, the arms were in front of you, seem quite far away, and exactly what Amit is saying is actually when I do ESD normally, it's right up close to me and I can make sure I'm not hitting the wrong layers. Is that a problem, or do you think because you've got that other arm to lift things out of the way, it actually isn't a problem because you've got better access? Just talk us through about that sort of aspect.
Yeah, I think initially I also feel that it's a bit strange not to work close with some mucosa, but once you actually get into that system, you are immersed into the dissection. You actually do not, you forget about the conventional ESD and do the new type of ESD procedure with a very stable platform. But I think in the future, we need to improve on the image quality as well. So if you have a 4K imaging at the end of the endoscope, so no matter whether you are close or far, you can zoom in and look at whatever plane and still in a great resolution of the dissection plane, then you don't worry too much about getting into the wrong plane. I think imaging is the key, not the robot arm.
Brilliant, fantastic. Well, look, I could talk about this all day, but unfortunately I'm not allowed to. So we have to bring this section to a close. Thank you so much. That was really an incredible talk. And we're now going to go on to the final part of not the final part, so the penultimate part of the day, but a really exciting point section where we're going to talk about tumour ablation, and in particular adrenal ablation. And one of the few people in the world who actually can do this is our very own Professor Steve Pereira, who's going to come on next to talk to us about it.
Thank you, David, for the invitation to speak on EOS-guided ablation. We just heard a fantastic talk by Philip Chu on robotics as an alternative to surgery, and I'm going to talk about the role of ablative therapies by endoscopic ultrasound as an adjunct or an alternative to some surgical procedures. This is a picture of the University College London campus with our own hospital where we are at UCLH, University College Hospital, in the background. I have no disclosures. As a tradition with this London Live Endoscopy, I'm going to present a hot case for the first slide, which is a patient that came to our endoscopy unit yesterday, and then I'm going to go on to EOS-guided ablation techniques for pancreatic cysts and solid lesions. I thought this would be of interest. This was a patient who's 55 years of age who had a Roux-en-Y gastric bypass in 2012 for obesity. He developed gallstone pancreatitis this year, a few months ago, and developed a very symptomatic 9-centimetre pseudocyst with worsening pain. You can see those pseudocysts there on the left picture. Really can't see the gastric pouch. You can see the anatomy of his Roux-en-Y gastric bypass to the right. It's from our frontline gastroenterology paper from last year, with a small gastric pouch with a gastrojejunal anastomosis. And the pseudocyst, as you can see on endoscopic ultrasound yesterday, about 10 centimetres in diameter. And perhaps you can see the number of wall layers there from the gastric pouch through the excluded gastric stomach into the pseudocyst. And then we'll just run the video on the right again. This is the video of the placement of the lumen opposing stent after the procedure. So coming back from the jejunum, there's some surgical clips, and here you see the 15 by 10 millimetre lumen opposing stent from the hot axios in good position, not causing any occlusion in the esophagogastric junction. So a very good symptomatic response to the patient. With that, it was a 15-minute procedure, 600 mils was aspirated, and one of the newer procedures coming in for patients who've had previous gastric bypass surgery. Moving on to ablation therapy, a number of different approaches. I'll go from the bottom to the top. Photodynamic therapy, we've had interest, particularly our unit, in this procedure where you provide a photosensitizer, usually intravenously, and then provide light, which then develops tissue necrosis. We published this on CT-guided approaches as a first-in-human study a few years ago. Then in conjunction with the Mayo Clinic, our first EOS-guided PDT for pancreatic cancer, published in Gastrointestinal Endoscopy 2021. These approaches require expensive photosensitizers, expertise, not readily available, and we and others have moved on mostly to more approachable approaches like radiofrequency ablation and cryothermal ablation, which Paolo Arcidiacono from Milan has been working on over the last few years. But RFA requires a probe. It requires usually a standard ERBI generator or similar, and the scope goes into the area of interest. You see the endoscopic ultrasound view of the lesion of interest. We're usually interested in pancreas. If it's a cystic lesion, you can use needles to then aspirate cyst fluid to reduce the volume, and then provide a probe into there and provide heat through power to cause tissue necrosis. This is the very first patient we treated. If we can run this video. This was a lady who'd been stuck in hospital with intractable hypoglycemia due to hyperinsulinism related to an 18mm insulinoma. She was unfit for surgery because of chronic airflow limitations. She used home oxygen. And this is a Habib probe. You can see the electrical generation by the probe. We treated her multiple times. It's a rather large lesion, 18mm. She went back to post-anesthetic care unit. She had a reduction in her 10% dextrose requirements. We treated her again the next week. And after a third procedure over 3 weeks, she became euglycemic and remained at home for 18 months before coming back with a small sliver of recurrence, which we treated successfully with no further recurrence. And that's a very good example of the use of minimally invasive approaches generally for patients who are not fit for standard approaches like surgery. This is the French multi-center series. This is a slide from my friend Marc Barthet from Marseille. And this is a study published in 2019 in Endoscopy, a combination of patients with neuroendocrine tumours and cystic tumours of the pancreas, which I'll show on the next slide. Here were 12 patients with 14 neuroendocrine tumours, and they were treated with radiofrequency ablation using the StarMed Tai Wung approach. At 12 months, a response rate of 86%, and that's the second publication. At 33 months, a complete response, a really excellent complete response of 93% in patients who had a median diameter of 13 millimeters of their neuroendocrine tumours and up to 20 millimeters. This is the data from the same paper on the patients with cystic tumours. Most were intraductal papillary mucinous neoplasms, as you can see. Some of them had high-risk stigmata, like mural nodules inside the IPMNs. 17 patients were treated. A slightly lower response rate at 70.5%, although that was maintained at 30%. And I would add that these were rather large lesions, so the median diameter here was 28 millimeters. I'll just show you some data now from our UK multi-center phase 2 study. This is a non-randomized study, but to date will be the largest series done. We had consented 70 patients who went on to treatment over the last few years. As you can see, a total of 16 patients we did not treat, and that was because the endoscopic ultrasound was performed, but for various reasons the operator did not feel it was safe to continue, usually because of overlying vessels or some other reason. So a total of 53 patients completed treatment. Another 17 of those had a second treatment as per protocol at 3 to 6 months. And we don't have all the data present at present. We're collecting that ongoing. But generally mild adverse events, pancreatitis, mild pancreatitis in a few patients, but a variable response you can see on the right. So a 50 to 100% response rate in slightly less than 50%, and that's in line with some other publications. This is another study led by a unit and with Queen Mary University London, which is another university near to us. This is a new technique, which has not been really reported previously apart from a single case report, of using radiofrequency ablation for hypertension. And up to 5 to 13% of patients with hypertension actually have aldosterone-driven hypertension due to aldosterone-producing adenomas. It's very underdiagnosed. It's a particular cause of resistant hypertension. And the protocol here was to find patients with definite left-sided APAs, 30 patients, who were having trouble with hypertension, up to 4 antihypertensive medications, often with potassium requirements as well. They were assessed with a new type of PET-CT called metomidate PET, which is only available currently at Cambridge, and lights up aldosterone synthetase. And you can see on the left, there's a CT with the left adrenal just to the right of the vertebra there that you can see. The left adrenal is easily seen just below the esophagogastric junction. We were using the StarMed probe, which is 19 gauge with variable probe lengths of 5 and 10 millimeters, and then a picture there of the probe going into the body of a left adrenal in a patient. And here's all these, and then coming back, we're just going to run these videos concurrently, I think. So the protocol was to take samples from the normal lateral or medial limb, and that's on the top left. Take samples from the aldosterone-producing adenoma, and you can see that centrally. So 25 gauge needles we were using for this, and this was to confirm the diagnosis histologically and also by PCR to measure the difference in aldosterone synthetase in the two samples. And on the right, this is the 19 gauge probe going into the aldosterone-producing adenoma in the body of the left adrenal. And now you can see that the current's been turned on. You can see the micro bubbling going around the needle, usually to a depth of 3 or 4 millimeters. Each treatment's running at usually 15 to 30 seconds until that's happening. We're also looking at impedance on the monitor as well, and multiple treatments under the same procedure. Usually a procedure taking about 15 minutes at a time. We are doing these procedures under general anesthesia, the patient supine with an arterial line. We have done some also under propofol sedation with a very low side effect profile to date. We haven't published that data, and that's because we just finished our last patient, completion his treatment only last week, and we'll be writing this up. And in conclusion to all that, I think EUS guided ablation therapy, particularly with radiofrequency ablation, and there are new probes coming along. There's a case report using a microwave ablation device in endoscopic ultrasound just this year. There's a growth area. There's efficacy and low complication rates are encouraging, I think. Particular patients who may be suitable for this is those with high-risk cystic tumours. We all see patients with cystic tumours, for example, which have high-grade dysplasia but who are unfit for surgery. And the ablation rates based on the largest French multi-centre study may be up to 70%, with other series going down as low as 30%, but it's an option for patients. Some insulinomas, of course. Again, not everybody is fit for surgery, and also the data of 90% complete ablation rate is interesting, given that the alternative for some patients is a full pancreatic duodenectomy. And small, low-grade, non-functioning neuroendocrine tumours in that grey zone between surveillance and surgery, which is usually between the 1 to 2 centimetre mark. And we've had a fair bit of experience in using it for particular metastases to reduce tumour load, breast, renal, melanoma metastases to the pancreas we've all been treating. And I think it's a very exciting time and a possible new treatment for some patients with hypertension. And finally, a need for randomised controlled studies. And that brings me to the right-hand side. We've just opened a brand new study, also funded by the British Heart Foundation, which is a randomised trial comparing radiofrequency ablation with laparoscopic adrenalectomy as an alternative treatment for unilateral primary aldosteronism. And the first 2 patients have been recruited in the last 2 weeks. So thank you very much for your attention. I hope that was of interest. And I think I've been asked now to move to a case report of, or at least a case of one of the patients that we treated only last week or so. This is a middle-aged man who is morbidly obese, a body mass index of more than 40. He's had complications related to his ongoing severe hypertension, including atrial fibrillation, an ejection fraction of 30%, some chronic obstructive pulmonary disease and obstructive sleep apnea. He'd been assessed for metabolic surgery for his obesity and been declined based on his unfitness. And the hope was that we could treat his hypertension, get that under control, and reduce his complications, including chronic kidney disease.
Hello, so we're going to be doing a radiofrequency ablation of a left adrenal aldosterone producing adenoma, which is in this 55-year-old gentleman with significant comorbidity. He has a BMI, body mass index, of over 40 kilograms per metre squared. He's got hypertension requiring multiple alpha and beta blocking drugs. He's on spironolactone to improve his hypokalemia. As a result of his long-standing hypertension, he has atrial fibrillation, a cardiomyopathy with an ejection fraction of 30%, and creatinine of 170, as well as obstructive sleep apnea. So he's not been fit enough to be considered for metabolic surgery, and our goal here is to treat him for the second time. So to find the left adrenal, so we come along the pancreatic body, so we're at 50 centimetres from the incisor teeth here. It's quite poor views because of his very fatty pancreas and liver, etc. So here's the left kidney on the left, and then generally you'll find the adrenal by just counterclockwise torque. Just dropping my left hand a little slowly, just looking to see if I can find the medial and lateral limb and the body of the adrenal. So it's not easy, but now you can see here there's a lesion here, which looks approximately 18 to 20 millimeters in size. You can see a normal looking lateral limb to the right of that. I'm not sure I can see the medial limb. So normally these are generally spherical, most commonly associated with the body of the adrenal, usually well demarcated. Sometimes the tail of the pancreas can be in the way, and also obviously the splenic artery and occasionally descending aorta is very close. This seems to be well away from vessels. A little bit difficult to see because of his body habitus, and also I think there's evidence of treatment effects centrally. So that heterogeneous grey-white area is the adenoma. So what we're going to do now is to use the 19-gauge StarMed radiofrequency probe. This is 18 millimeters long, so we're going to use a 10 millimeter long probe. It's a 19-gauge needles, as I said, and it's water-cooled, so we have refrigerated saline, which is pumped through to keep the needle cool. We don't want charring of radiofrequency ablation, and it sort of avoids that. So the needle is connected to a StarMed generator, which is provided by Taiwung in Korea and distributed by Aquilant here in the UK. And probably this sort of lesion, you have to think in 3 dimensions, of course, with these spherical lesions. So I will start sort of bottom left and sort of try and work around the sphere, and probably be looking at least 6 to 10 treatments. So you can see, you can visualize the probe quite nicely. It's very stiff at 90 gauge, so you can see it moving very easily without displacing the lesion. And the key here is just to sort of try and be confident about where the tip of the probe is. I think I can see it very nicely. Just here, Gavin. So put your probe just around here. So okay, ready? We're going to do start, stop. Okay, start. So you can see the electrical effects of the probe, and you'll start seeing microbubbling now. Just starting now. And stop. So those numbers that were being called out as the impedance, and this system has an automatic cutoff at 1,000 volts for impedance, but generally we're looking for that microbubbling, as you saw there. So you can see the needle tip nicely. I'm just outside the adenoma there distally. And stop. So I'm near the edge of the adenoma. That's nice. Okay, we'll go again.
And is it a 2 centimeter?
This is a 1 centimeter probe. So I'm going to do this in 2 layers, basically. Yeah.
So do the far end first.
Yeah. And stop.
So that's that centimetre there.
Yeah.
And then you do that.
That's right. Yeah. Yeah. So Gavin's just saying. So what I'm trying to do to do the inferior aspects of the using the 10 millimeter probe, and then come back and do the more proximal aspect or more cranial aspect of the adenoma. And when we finish treatment, we take the needle out. We generally watch the field for a few minutes just to see if there's any change in echogenicity, and then finally also look endoscopically to see if there's any endoscopic evidence of bleeding.
Okay, so fantastic case, Steve. And you know, one can imagine an area that may really develop. And Rita, just, you know, where do you see this sort of ablative technology going in terms of the location of lesions and the pathological type of lesion?
Yeah, I mean, well, right now the indications are neuroendocrine tumors in the pancreas, or I suppose anywhere where you could access them. As we've just heard about the adrenal adenomas. I've also used them in sort of symptomatic lymph nodes, pathologic lymph nodes that have been seen. And I think really in terms of location, it's where you can access, right? It's all about where you can access with EUS and needle. And so I think in terms of the pancreas, the hardest ones to get to are perhaps the uncinate process. It depends on the stiffness of the needle and whether you can get it into position. But otherwise, I think anywhere in the pancreas where you can access it is doable. I think another indication that might be good is even to bridge patients to surgery. I was thinking about patients that are on so many hypertensives, might not be good surgical candidates. And if you can treat them, at least get them more controlled, then perhaps more definitive surgery later. Yeah. I think that's where we have to figure out now, indication-wise. Yeah. Where do we send patients to surgery? Where do we offer them ablation?
I agree. And Steve, there's the question of location and type of lesion, but where do you see the actual technologies for ablation going? Is this the end deal that you're showing here, or are there going to be, do you think, other modalities of ablation?
Well, I think the first thing to say about the current ablation devices with radiofrequency ablation for endoscopic ultrasound is that it's very safe. It requires the techniques of an endoscopist who does endoscopic ultrasound and takes biopsies from pancreatic lesions. It's very easy to use. It generally runs off generators that are available in endoscopy, so it's not very expensive. And it's a dependable treatment with a low side effect profile. But it has limitations, and we know from the experience from interventional radiology that there are certain advantages with other technologies which have not yet arrived to endoscopy, and we've just seen one case report of microwave ablation. Our radiologists here use a lot of cryothermal ablation, particularly for renal lesions as well, and we would like to have those kind of options available for us. Yeah.
Okay, and do you see any adjunct to physical ablation? Is there going to be other forms of chemical or even chemotherapeutic ablation? Is there any direction of travel in that direction?
Well, I think again, with endoscopic trials, we've generally seen case series and things like that, and I think we need to concentrate on how can we sort of show where the role of a particular ablative device in endoscopy fits amongst all the armamentarium that's available, for example, in pancreatic cancer and other pancreatic tumours. And so we need to, and I think neuroendocrine tumours are a good example. You could think about non-functioning pancreatic tumours. There's a grey area which is being met by some of the large European and US studies about what we should be doing with those non-functioning tumours that are between 1 and 2 centimetres. And maybe that's a question we could answer: radiofrequency ablation versus surgery, or radiofrequency ablation versus continued surveillance. And they're the studies that require big multi-centre studies to test. And as far as combination treatments, that's again an extra level of complexity to try and test.
And it's perhaps a false analogy, but yesterday afternoon, which feels about a year ago now, we were talking about chronic pancreatitis and the role of endoscopic approaches compared with surgical approaches, and the fact that many patients would like to know if there is an endoscopic approach compared with major surgery. And when we're talking about non-functioning or low functioning lesions, for example, in the head of the pancreas, in the absence, there's no medical therapy. The surgical therapy is pancreatic duodenectomy, a Whipple's resection, which is a big undertaking.
Yeah.
Do you see that this sort of EUS guided therapy may, in that particular patient group, find a particular role, and at what point might we be having that fair discussion with patients?
Absolutely, and at the moment we're in a setting of case series, and the standard treatment is normally going to be surgery. For example, there's an abstract which has been submitted looking at 1,000 endoscopic ultrasound radiofrequency ablations in neuroendocrine tumours, and that will as a multi-centre study, and that will be presented hopefully in the coming year. So that kind of evidence is very supportive of safety and potential indications. And then that should lead, I hope, to studies which is comparative. For example, the trial that I mentioned of looking at unilateral radiofrequency ablation versus laparoscopic surgery in adrenal tumours. So the same could be done in pancreatic tumours.
If I could, I would say that ablation is to solid lesions, solid organs, what ESD is to luminal lesions. It's organ sparing, especially if it's a benign lesion, and the risks taken and the sort of changes that might be incurred with surgery can be avoided by endoscopic treatment.
And are there any potential benefits or disadvantages beyond the accessibility question of radiological percutaneous radiofrequency ablation over EUS guided, or is it simply an access question?
I don't actually have experience with that.
Pancreas is difficult radiologic if you're aiming at small things. For adrenals, the right adrenal is ideal for percutaneous approaches. That's our approach in the randomized trial, whereas the left adrenal is sitting there for endoscopists to approach.
And you may have mentioned this, but of course one thing to do a beautiful technical result here and ablate. Do we have enough longitudinal evidence yet to know the extent to which this has an impact on long-term antihypertensive medication or in the setting of insulinomas, the glucose control and weight reduction?
So, you know, there's going to be there'll be data been showing that there will be a recurrence rate with EUS guided ablation, for example, of neuroendocrine tumours. And then the question will be, okay, can we improve on that ablation rate? We're still learning techniques. You know, we're not probably as comprehensive as radiologists might be in treating hepatocellular carcinoma or renal cell tumours. We need to think about how we can improve that, and also, you know, what is a recurrence rate acceptable? For example, in a benign insulinoma, which is small, is it acceptable, for example, in the patient I showed, to have a recurrence rate 2 years later and then to treat that with good effect? Or think about surgery at that stage because the person no longer has recurrent hypoglycemia and obesity, etc.
Yeah, and I think an area perhaps for innovation is really ways to actually detect how much you've ablated and is it adequate, you know, either scans or kind of markers or something like that, so that we can either you know, add more treatment at the time or bring patients back sooner for completion therapy to help improve outcomes.
Okay, fantastic. So we promised at the beginning of this course to address common clinically relevant areas of diagnostic endoscopy. We make no apology for going right to the other end with this topic, because I think in terms of therapeutic innovation, this is an area that we're really going to see developing over the you know, over the next few years. Thanks, Stephen and Rita. I think we've got a very quick break before going to the next session.
Very good.
So I have the great honour of presenting the final section of the day, and I actually have the dream team back with me. So I have Matthew Banks from UCH, Hamid Steffi from New York, and Philip Chu again from Hong Kong. So this is the perfect team to end the day with. And what we want to focus now on are submucosal lesions, which you're doing a diagnostic gastroscope, you go down with the scope and you see this little bump underneath the surface of the stomach, let's say, and it's an absolute disaster. You've got no idea what to do with these lesions, and in fact, really, actually, no one has any idea what to do with these lesions. And really what we want to try and come to at the end of this section, no pressure team, is a definite conclusion as to what we should do with these submucosal lesions. So to start with, we're just going to show a very quick example of a fine needle biopsy of a gastric submucosal lesion. So let's just see that little quick example.
So we're doing an EUS and FNB on a round hypoechoic gastric lesion with this ground glass appearance arising from the fourth layer, which would be consistent with EUS appearances of a GIST. I'm using the Medtronic Shark Core 22 gauge FNB needle in order to get adequate tissue sampling, and you can see that we're going to do multiple passes, and we know that this needle has around an 80-85% tissue acquisition and diagnostic yield according to data.
So it was quick, a lovely example there of a fine needle biopsy. I'm going to hand on to my colleague there, Matt. I showed that was the Medtronic Shark Core needle, and if you could just talk us through some of the sort of the final aspects, I suppose, of the needle we used there.
Thanks, David. In terms of grading, the submucosal lesions are graded as some of the hardest to obtain tissue from in terms of EUS. So it is difficult to get even the best needles in. This is the Sharp Core by Medtronic. It looks like most other US FNB or FNA needles. It's got 6 cutting edges. I can't see them, but there are.
You're getting quite old now.
I know, absolutely. But it does mean it's very sharp, and I like my knives sharp, or needles. And the other little thing here is this: as the stylet comes out, you can keep the. So I'll just show you here. You can advance the needle when you're in the tissue, because it's got 6 cutting edges, so it's very sharp. There we go. Thank you, Amrita. Just click the stylet back in. And once you advance the needle into the tissue, you can then just click here, and then the needle comes out, but the sheath stays in, so you can remain in position, which is a very nice little feature. Like with all punctures, it makes it slightly sharp if you take it out, but once you put it in, you then just depress this a little bit just to remove any epithelial tissue that you may have accumulated on the way. Ergonomically, I've used that term twice already in this afternoon, I do like it. It's actually very nice to hold. So when you're fanning the tissue, it's really smooth and easy to use. It's quite flexible, so when you're having to use the bridge, the needle comes out quite easily. And the other aspect is you can interchange FNB and FNA needles. And that's really important with the more dense subepithelial tissue, because they're very hard. And the other point is they're mobile, particularly in the stomach wall. So it's like trying to, with the knife on your head, as you showed the photograph before, it's trying to get the knife into the nappen and the barrow. It's really, really very difficult. And we know that tissue acquisition in some studies is no better than 50% with some needles.
So, I mean, fantastic, Matt, and thank you so much for talking us through the needle there. But Amrita, so I'm going to come to you because you're the expert on this. I'm pretty sure you're the expert. You're going to solve this problem. So I gave the example. I've gone into a gastroscope. I've seen this submucosal lesion. Am I supposed to biopsy it? Is that pointless? Am I supposed to do a tunnel? But how am I going to get tissue? What am I going to do? And what size should I be trying to work with here? When do I not care?
Yeah, I mean, so if a general gastroenterologist is seeing a lesion, I think if it's a small size and you can do a couple of maneuvers to see if it moves. There are a lot of things that are external to the stomach that will cause an impression that you sometimes can get an idea. You can also see if there's a pillow sign, which are more characteristic of lipomas, for example. But it is acceptable to do what we call stack biopsies, or some people call them well biopsies. It's taking one biopsy on top of multiple biopsies at the same exact site to try to obtain submucosal tissue. The yield on that is not great. I think there are multiple other methods. I probably would say that it should be sent to an endosonographer to do those methods, and certainly not all of these need to be biopsied. So I think I would probably refer these patients to someone who does EUS, who can characterize the lesion, the layer it's coming for. That's what we're interested in. The echogenicity of the lesion, which can help with diagnosis and sometimes doesn't even require a biopsy. And then doing some more advanced maneuvers. If a lesion is greater than a centimeter, I think EUS FNB is very reasonable. When they're smaller, those can be much harder lesions to do FNB. They're stickier, they're a little bit harder to get enough needle into. So a lesion like that, you can do, for example, a tunneling technique using a needle knife, or just creating a cut into the mucosa and then putting the biopsy forceps deeper into that. And then based on EUS results, sometimes cross-sectional imaging, and then pathology, decide what needs to be done. Is it benign? Any malignant potential, and size. And certainly things like GIST, the size matters, and the mitotic index matters for things like neuroendocrine tumors. Also the Ki-67 will matter, the size will matter, location probably matters. All of these things are things you're going to discuss in a multidisciplinary
Fantastic.
meeting.
And we're going to move on to
I'll say a shameless plug, by the way. Recent clinical practice update in CGH.
I knew you were the expert. But Matt, you've got 30 seconds. So I want to focus on the slightly smaller things to start off with here. So Emily said beautifully there that over 1 centimetre, EUS FMB is perfectly reasonable. Under 1 centimetre, she's highlighted there that there's problems in terms of getting tissue acquisition. What do I do? I haven't got tissue now. I have no idea what that sub-centimetre lump is. When do I bring them back? Do I never bring them back? What do I do? You've got 20 seconds to answer that.
It depends on the appropriateness of the patient's condition. If they are elderly with multiple comorbidities, there's very little reason in bringing them back. And I think if you can attain some EUS pictures, if there are no features of concern, if there are no cystic spaces, if it's regular, if the contour is smooth, if there's nothing to suggest this is a high-grade lesion, I think you don't need to invite them back. If they're younger patients, your options are, if you don't attain tissue in the first 20 seconds, I think that's how much time I've got left, then you can consider removing it as a full thickness resection. And as a young person, I think that's a reasonable option because you don't have to you know what the tissue diagnosis is and you don't need to worry about it.
I'm going to stop you there because that's a beautiful segue. Well done. It's like you've done this before, Matthew. So fantastic. So that's a really good tips there. And what we're going to move on to now is those slightly bigger lesions, or perhaps those lesions you want to obtain tissue from the younger individuals. And we're going to see a lovely example of full thickness resection here from my colleague Vinay Sehgal.
Thank you, David. So I'd like to commentate over a video demonstrating the gastroduodenal full thickness resection device. So this was a middle-aged gentleman who was known to have a 15 millimeter gastric subepithelial lesion here. I think this video is, there we go. So he'd had endoscopic ultrasound performed twice over a period of 5 years, and the histology had been inconclusive, and the actual natural history of the lesion was unknown, so we just decided to monitor him periodically. After a detailed consultation, we decided to offer him sort of a resection using the full thickness resection device to really get a tissue and make a diagnosis here. So what we do in the stomach here is we've marked the lesion, as you can see, and our practice at University College is actually to perform a hybrid procedure where we perform a circumferential incision around the lesion. So we perform a circumferential mucosotomy. To really, the premise behind this is to try and release the tension away from the stomach wall, which we know is very thick, and that is in stark contrast to colonic FTRD, where the wall's a lot thinner. So we've made this our standard practice before the procedure to invest a little bit of time and energy in releasing that lesion, because we have noticed in the literature and our own anecdotal practice that it can be otherwise quite difficult to achieve a full thickness resection. So what I'm using here is a Pentax gastroscope with a splash knife, and after sort of liberal injection, we're performing a very careful circumferential incision of the lesion. And only when that is complete will we consider then next performing the full thickness resection procedure. A couple of important points that I should have alluded to earlier. The patient is having a full anesthetic, airway protection, and in our experience, the median procedure time is approximately sort of 45 minutes or so. Most patients are kept in overnight and discharged the following day, primarily for pain control, actually. So if we come back to the case, and once I've completed the incision, I'll be able to demonstrate the introduction of the device. So it's really important to invest some time and energy at this stage to make sure you really release as much of the muscularis mucosae as possible, and that's what you want to see before you put your device down. So this is the view with the device mounted onto the scope. So importantly, you need a 3.7 millimeter therapeutic gastroscope. You will need to perform a balloon dilatation of the cricopharynx. The balloon is included in the kit, which is provided by Synmed and Invesco. So you will just perform the dilatation using a 20 mil Lurlock syringe, and you can see this here. And then when you follow that down, so you follow your device down with the balloon very, very cautiously. And this only adds an extra minute to the procedure, but it is recommended for all of them because it is a bit of a clunky device otherwise. So once that's complete, you run down here, and essentially the key facets of this device here is that the clip that is over the scope includes a snare. So you will have simultaneous
closure of the clip and the snare. So what I'm doing here now is using the grasping forceps, which are included in the kit, to really bring that lesion in. And you need to take your time here to make sure you are happy that you have the whole lesion on FAS before you deploy your clip and close your snare. And it's critically important that you get your steps right. And you can see the end result here. So the clip has been fired, and there is no immediate complications, very bloodless field, and you'll come out. What I want to hopefully demonstrate here is what the lesion looks like ex vivo outside of the patient. Make sure that you've had no complications in the esophagus. You can see a few lacerations on the posterior esophageal wall here, but there's nothing full thickness here. There's no full thickness injury, and I can tell you that the patient went home the following day. Hopefully we can have a little clip just to show the lesion ex vivo for a moment. And there we go. So you can kind of see a very well demarcated kind of globular tumor. And actually the histology was a lipoma. So slightly unexciting, but actually I think very important, because this patient was coming for repeated endoscopy every 2 or 3 years. And actually we could say to him after this procedure, you need no further follow-up. You are discharged from regular endoscopy and surveillance, and he was very glad of it. So it can be very helpful for sort of small to medium-sized subepithelial lesions. And I use that term subepithelial, which I think is more precise than submucosal, to actually achieve an accurate tissue diagnosis and actually plan what to do next with that patient, because we know that we are unable to acquire as much tissue with FNA to measure things like the mitotic index and the Chi-67 index compared to a full thickness resection. So hopefully I can now actually demonstrate the device for you ex vivo. I have my expert senior nurse, Rainina, who will be assisting me in demonstrating the device. So this is just an overview. So it is an over-the-scope device, which you will mount in a very similar way to the usual Avesco system. So the snare runs on the outside of the gastroscope, and you will need to put a plastic sheath around the scope to prevent the snare from looping when you introduce it into the patient. So you've got to do these steps at the start. You have your the wheel that you will turn when you deploy your clip, and you will have a grasping forceps, which you saw in the video, which we'll use to go after video. So what we're going to do at this stage here is we're going to just zoom in on the cap, please, if we can come in onto that. So I can just show you the clip. There we go. So you can see that the clip is mounted over the scope and it's attached to the snare. And I think the key thing is here, you need to have the working channel free. And it's not obscured by the device itself, so you can see actually what you're doing. Fundamentally, this is actually a 3-person procedure. So there will be the endoscopist that performs the procedure and deploys the clip. Secondly, you will have a nurse that is holding onto the grasping forceps for you, and you will also have a nurse that's closing the snare. So you need 3 people, and it's really important that you get the steps in sync. And actually the device has been made in such a way that they've labeled it 1, 2, 3. So it's very much hopefully idiot proof. So number 1, you will deploy your clip. At the same time, the nurse will close the snare. And the final thing is you will press completely down on endocut Q, and you will close the snare very, very quickly. You are not, this is pure coagulation, cutting current. You're not going to be using any coagulation here, and it's a quick closure. And I would encourage you that you get those steps rehearsed very, very strictly before you deploy your clip and actually perform the resection, because that's where the complications arise, when you get those steps wrong. So pretty straightforward to set up. Plenty of information online and from the manufacturer as well if you need anything further, but I can't emphasize as importantly the steps for actually 1, 2 and 3, getting those in sync, and then collecting your lesion and making sure you've had no complications. I hope that was a useful demonstration of the kit here. We're just going to just show you what the grasping forceps look like actually as we come through here. So if you just open the grasping forceps, please. And that's what you want to take care when you are actually grabbing your lesion. And once you've grabbed it, you'll bring it back into the cap completely so it's on fast, and then you will then deploy your clip. A final kind of helpful note is patients included in the kit is a MRI safety information leaflet. So this is MRI compatible, and we would normally give these home for the patients to take with them, so there's no confusion or misunderstanding about whether they need any further scans or not. Just a very simple but very helpful thing for patients to have on them. I will hand back, with no further ado, to David and the team. Thank you.
Thanks so much, Vinay. Really lovely case, really lovely demonstration. Philip, coming to you. Nice demonstration there. Tell me, firstly, what patients are you selecting for this procedure, and what have been the, we've heard beautifully there, I guess what the advantages are. Have you had any problems in terms of using the kit? Are there any patients you found actually, or any perhaps anatomical locations you've thought, nah, I'm not going to use the kit in those sort of areas? So please enlighten us.
Thank you. Actually, I don't use this, I have never used this FDRD device, but at the same time, I think full thickness resection will be indicated for lesion in the stomach, because in the esophagus, a lot of time they're actually leiomyoma. I prefer the tunnel technique. But for the gastric side, I think most people worry about is a GIST. And I think more importantly, we have to ensure an adequate margin when we are resecting these lesions by the use of the full thickness resection. So I personally do an exposed technique of full thickness resection using the ordinary ESD device and also a traction device. And I think the indication will be divided into whether the size is larger than 2 centimeter or below 2 centimeter. Because nowadays all the guidelines actually illustrated that if they are larger than 2 centimeter in size, suspicious feature of a GIST, I think we should take it out. So either surgically, endoscopically, using the conventional method or the current method. But if you are less than 2 centimeter in size, I think we have previously discussed. So if you can get the tissue and ensure that this is GIST, then you have formally a good treatment plan. And of course, for younger patient, I think the patient prefer to be resected rather than to have a endless surveillance endoscopy. And you actually don't know the time period that we need to provide for the patient for the surveillance as well. So, and then the patient, we also did some questionnaire survey and found that some patient actually got really anxious 2 or 3 months before the surveillance endoscopy, because they don't know whether there's an enlarged and how would that end up in any kind of treatment. So to relieve the patient from anxiety, to provide them with a treatment endpoint, I think endoscopic resection by full thickness resection is one of the options for these patients to consider.
Yeah, fantastic, fantastic answer. And I think we're coming together with the nice algorithm here, aren't we? So less than 1 centimetre, we may struggle to get tissue. We may bring people back if they're younger. 1 centimetre, 2 centimetre, we're going to try and get a sample through EUS ideally. And as you say, above 2 centimetres, we're looking to try and resect. Matt, just a couple of things on the intricacies of that specific device there. Is there a size limit to using that device, and are there areas of the body in which you can't use it, or is it actually it's a free fall and go wild?
It very much depends on the texture of the tissue. So if you have a GIST or a leiomyoma, and as Philip has alluded to, most leiomyomas never change through surveillance. You can leave them alone unless, of course, they're causing symptoms, in which case you may need to enucleate them through surgery. But these caps, particularly the upper full thickness resection device, for more dense tissue will only hold about a lesion 14-15 millimeters max. So you need to try and minimize the amount of tissue that you suck into the cap. So one possible advantage of taking the cap off is you remove the mucosa, and if you could dissect around the lesion, and so you're doing an open full thickness resection, then you can possibly grab the tissue, retain the tactile movement which we discussed before, and pull the whole thing in. So the answer to your simple question is no more than 50 millimeters for dense lesions. Softer lesions, maybe a few millimeters more.
Perfect. Thank you very much.
Access.
I know. I'm going to go that to Amrita. You've tried. You did half the answer. It was fantastic. But Amrita gets the actual bit. So please, anatomically speaking, is there any way that you wouldn't use that device, or is it fine to go?
Yeah, I mean, this device for the upper was just recently introduced. So before that, it was difficult to use in the upper GI system. I think the most common place that it will continue to be used is in the colon. And just to comment that I think the ability to see that you have the whole lesion does make a bit of a difference, and that's why its best indications are for those scarred down lesions or cancers in unresectable patients where you're actually seeing the lesion and you're making the markings and you can tell everything is inside. I think in terms of the upper GI tract, I think anything that needs to be done in retroflexion is going to be a problem. You really have to have that en face view. You have to have one-to-one with the deployment of the cap to make sure it doesn't misdeploy. the clip, and then the duodenum, I think, is a difficult place, both from getting through the pylorus as well as some of the angles, or if it's too proximal, you have to be able to get the entire cap into the duodenum. In the colon, you know, it really depends. It's going to be harder in the distal colon, and it's going to be harder in patients who have a lot of diverticula, sigmoid loops, and things like that. And so there is actually a cap, sort of a testing cap, to be able to see whether you can get to the lesion with the cap before actually putting the clip device on, because that can be a difficulty. So when, so it's something to think about in terms of your technique. How hard was it for me to get to this lesion with the endoscope?
Fantastic answer. And Philip, we know why you don't use this device, because we had a fantastic case last year that you showed us of a lesion, and I make no apology because it was such a great case. We've flown you over specifically to show that case again, so we can watch it again, and we want to talk to you all about it. So what I'd like to lead on to now is these bigger lesions, these bigger submucosal lesions that we want to remove endoscopically. And again, pushing the field of our endoscopic boundaries, I think, here. So this is a case from last year, but it's a cracker. And I'm going to introduce it right now. This is Philip Chu from last year.
Hello. This is my honor to join the London Live Endoscopy and to talk about endoscopic full thickness resection of duodenal gist. So thank you so much to Dr. Josh Ratner for your kind invitation. I'm Professor Philip Chu from Department of Surgery, Faculty of Medicine, Chinese University of Hong Kong. And I would like to present my patient, who is a 57 years old lady. First present with hematemesis with upper endoscopy showing a bleeding gastric ulcer and also a duodenal submucosal lesion. She was H. pylori positive and eradication therapy being given. On follow-up endoscopy, it showed a 15 mm submucosal lesion in the first part of anterior wall of duodenum, and an endoscopic ultrasound examination showed that this lesion is around 12 times 10 mm in size, arising from muscularis propria. She received PET-CT, which showed a SUV of 3.0 for this lesion, and there's no regional lymph node enlargement and no other lesion. So we decided to treat this lesion by duodenal endoscopic resection. So after locating the lesion, I first inject at the submucosa to elevate the lesion, and using the normal saline, it mixed with indigo carmine and also epinephrine. And afterwards, I start the mucosal incision. Knowing that this lesion, it's involving the muscularis propria, and that the duodenum, the muscularis propria is usually very thin, I would expect this to be a full thickness resection. So firstly, I'd like to open the near side of the mucosa in order to expose the tumor, and then assess to see how much mucosa is needed to be resected together with the lesion. So if you look into the endoscopic view, I think the lesion is more on the intraluminal side, and this is also the same assessment from the CT, so justifying the use of endoscopic resection. And so at the very beginning, I try to be very cautious in not dissecting over the muscularis layer, but now you can see that we are starting to see on the near side the duodenal tumor border, and that this is embedded in the muscularis propria layer. So in order to achieve a good resection margin, then we need to cut into the muscularis propria layer. So like that, you can see the location of the tumor, and then I started cutting into the muscularis propria layer. So also noticing that the muscularis propria layer appeared to be a little bit more thick as compared to the normal duodenal muscularis propria. So and also with the adequate dissection around the lateral border of the tumor before we actually enter into a full thickness resection will help us to limit the amount of gas leak during the full thickness incision. So for this procedure, it is done under general anesthesia And the insufflation that I usually use is CO2 in order to avoid too much of the gas leak and tension and peritoneal cavity being developed and compromising the ventilation. So now I started to dissect at the border, and in the duodenum, I prefer to use the IT nano knife because of it's smaller in size at the head, and also the easier maneuverability as compared to the normal IT2 knife. And of course, I try to be really cautious in the dissection, and I think that this insulated knife will help me to retract at the same time dissect around the tumor. So for duodenal GIST tumor, it is kind of rare, but the same principle apply that we need to achieve a good resection margin and en bloc resection. So we need to pay attention to the border and the margin. So that's why I try to dissect really close to the muscularis propria layer. And in the dissection, I generally use a combination of knife because the combination of these two knives would give us the best advantage of the two knives, so that we can, as you can see, we check the tumor and also perform the dissection. So this is definitely a tumor that involves the whole layer of the duodenum, and it is of course much bigger than we expect from any of the imaging because of the difference in the dimension assessment. So this tumor, it's closely adherent almost to the serosal layer and the full thickness. So we are cutting over the serosa. So now we have completed the whole dissection of the lesion. This is the posterior side, the far side of the lesion. And in this lesion, we cannot spare too much of the mucosa simply because of the movement of the tumor to the mucosa and the densely adherent. So after resection, I think the very first thing to do is to grasp the tumor with the rough net and take it out. And to avoid dropping the tumor into the far side of the duodenum. So afterwards, because of the large defect, I attempt to close this defect with the Apollo overstitch. So this is the latest version of the single channel overstitch device. It comes with quite a significant large size end effector over the head of the endoscope. So in the duodenum, it is especially difficult to apply. So I use the tissue helix to apply to pull the tissue to near me and then apply the suture. And I usually perform the suturing in the figure of 8 manner. So now after passing the first suture, I pass the needle back and then apply the second suture. So because of the limitation in the space, I need to readjust my position of the scope in order to drive the needle. I think if the lesion is far beyond the D1, I don't think this overstitch is going to be able to apply beyond the first part of the duodenum, but only because of this location over the anterior wall that I attempt to use this single channel overstitch device. So as you can see, the advantage of this is that we can perform a full thickness suturing, and that will give me more security in performing full thickness resection in the first part of the duodenum. So again, catching the needle, I will then apply the second suture to the lesion and the full thickness closing the defect. After the figure of 8 application, then I drop the needle and pull back the suture and then apply the casing and tighten the suture. So the first suture was applied, but then I have a difficulty to apply the second one because of the limitation in the space. So I combine this closure with the clip and the loop technique. So this is again using a single channel device. So the loop, the detachable loop is actually applied to the outside of the scope. And I try to clip the loop to surrounding the defect and applying this empty clips. And then finally tightening the loop and completely close the defect. So I found these two methods to be the commonly applied for endoscopic full thickness resection. So this is the final part of the closure, and I'm pretty sure that we have completely closed the defect. So the pathology of this lesion is confirmed to be a GI stromal tumor with a c-KIT and CD117 positive. It is a 15 millimeter in size with a clear resection margin. And I did a follow-up endoscopy 6 months later and confirming the complete healing of this EFTR site with no evidence of a recurrence. So in summary, this is a patient with a 15 mm duodenal GIST tumor that successfully treated by endoscopic resection using endoscopic full thickness resection techniques and closure by an overstitch and also creep and loop technique. Thank you very much.
Fantastic and exciting last VT of London Live. And coming to you straight away, Philip, if that's good, I'm going to ask you a really basic question before better people than me asking more intricate questions. That was a lesion, a bigger lesion. It was in the duodenum. What's the pathway in your hospital? Are you now at the point now where actually everything comes to you, the endoscopist, and the surgeons are now irrelevant? Or is there a conversation? How does it work?
Yeah, I think there's always necessary to be a multidisciplinary approach to managing these lesions because the duodenal submucosal tumor is not common and a lot of them are actually GIST. So, but of course there are other benign lesions, even the lymphangiectasia or NET can occur in the duodenum. But I think a multidisciplinary approach is important. Of course, for submucosal lesion that is more closer to the serosal side, then the surgical laparoscopic resection is more feasible. So I think it's a joint decision. But for those lesions that are within the lumen, most of the component, then they will be referred to me. And the duodenal full thickness resection is a kind of expert area that is totally different from stomach and the esophagus. So the complication and risk is much higher in the duodenum. As you can believe that during the dissection, if there's a perforation, the management is in fact pretty difficult.
Yeah, I'm sure. And you know, there was so much technique on display that you had a few questions and points you picked up during there.
Yeah, submucosal lesions are a bit of a minefield when deciding which approach, whether you use a full thickness resection device, whether you use an exposed technique like you did there, or whether you create a tunnel. Do you mind just elaborating on what your thinking is in terms of choice, where in the stomach you'd use a tunnel technique, where you'd use an open technique? I suppose it all depends on how easy it is to close, but I'd like to hear from you, Philip.
Thank you, Matt. So I think for esophagus, I definitely will use tunnel technique, considering the possibility of the pathology. So nowadays for stomach, for lesion that is located at the gastric cardia, lesser curvature, and the antrum, I also do it by endoscopic full thickness resection, and I almost always use the exposed technique because I worry that these are actually GIST. And as you mentioned, the FDLD device have a limitation in the specimen side. So if you have a large size of the lesion, if you actually end up in a involvement of the margin, then I worry about the recurrence. So I almost always use the exposed technique. For duodenum, it's kind of difficult to develop a tunnel, so you have no choice. And but then the decision to proceed to the resection by endoscopy, it depends on, firstly, the component, as I mentioned. So you need to look at whether it's an extraluminal or intraluminal component as a majority through imaging. And I usually order a CT scan to assess the component before deciding whether I use endoscopic or a laparoscopic or a combination of both techniques.
Oh, fantastic answer. So, go on, sir, Matt.
Just sorry, one more question, which is for those who do POEM and ESD, how difficult is the transition to tunneled full thickness resection?
You want to know because you want to do it next week, Matt, don't you? Is this your answer?
So I think for you mean the full thickness resection by exposed technique. So basically it's a combination of the ESD technique with a traction. So the commonest case that you should start with probably in the stomach, which is really indicated for a gastric cyst, not too large in size, like 20 mm, 15 mm. Then you actually circumferentially open, dissect the muscle, and then use a tissue traction like a clip and line technique to pull the lesion into the lumen. So I believe is that the endoscopic dissection have all the advantage if the lesion is within the GI tract. So you have to pull all the lesion to the inside. You look at the serosal side, complete the resection of a margin. So, and then of course you need a good closure technique. But if you don't have any experience in using the overstitch or the suturing, then I think now you can still use the clip and the loop to close any defect like 20 mm or less. I think it's very secure to use the clip and the loop technique.
And Anita, coming on to that, because that was a lovely example there of closure technique, and this is clearly a planned perforation, or however you want to put it, but of course sometimes it happens, Wobertide in your ERCP, perhaps what else. I guess take us from the basics of managing a duodenal hole right through to what are the other perhaps more advanced closure techniques one can adopt for these issues.
Yeah, so I think one of the important things is being able to identify the defect. So, it's important if you see, for example, during an ERCP, if you see that there is a perforation caused by the scope, is to make sure that you have some type of a marker of where it is, because whatever technique that you're going to do likely will require a change of scope, or there's going to be some bleeding and you lose visualization. So whether it's a clip or placing a wire through the defect or something, I think marking it is important. You can, if it's small enough, try the through the scope clips, and having experience with clipping closed EMR lesions, for example, or ESD lesions, is very helpful in terms of understanding to do like a zipper technique and really bringing the mucosa together. I think there have been some nice new demonstrations by Professor Yahagi, for example, of using the clip in line to bring together the walls of the defect to allow for them to be closer, so then you can securely place a larger clip over it. But I think between the over the scope clips, both types, including the padlock and the Avesco, that I think those are more secure closures. And then of course the overstitch suturing. And the difficulty that we saw in that case is, the over the scope suturing systems do require a fair amount of distance, and being able to maneuver a large stiff scope. You have to come out with the scope, you have to mount it and have a therapeutic or a double channel available. Now they do have a new through the scope suturing system, the X-Tac system, that really allows you to actually keep the scope in place. You don't even have to come out. It can work with any type of scope. And I think that's actually a fantastic way to close defects, particularly in the duodenum, because you can maintain your visualization, you can keep the same scope that you have in. We the other day did do one through an ERCP scope, a little bit more difficult, but but doable. So I think those are the variety. I would say for full thickness resection, even if you don't have access to the suturing systems, mastery of whatever closure techniques you are going to use is imperative before you really embark on that, whether it's clip and line or really understanding how to do that and how to ensure that you're actually closed.
Fantastic. And Matt, just coming to you, let's say you're doing a diagnostic endoscopy and you don't have the skills of Philip and Amrita, and I know you don't because we've worked together enough, of Philip and Amrita to close. You don't know what to do in this yourself. You've seen a perforation. What do I do? Do I pull out immediately? Do I put a feeding tube down? Do I just panic and run to the surgeons? What's the basic step there if you don't have these advanced skills that these guys have?
I think, as Amrita has already suggested, you need to stabilise the patient. If the patient's uncomfortable, they're moving around, you're not going to get anywhere. So you need to take the scope, decompress them first, take the scope out. If it's abdominal, decompress the abdomen. It's very, very easy. You just pop a needle in. Talk to an anaesthetist, use a GA if necessary. And once the patient's settled, then the zipper techniques really quite easy if you practice. if these are new perforations, so the tissue's healthy, it's flexible, it comes together. If you start off with a nubbin on the most distal aspect of the perforation, if you take your time, you can very easily oppose both sides. And I know that the suggestion is anything over 1 centimetre you can't close, but you know, we've had achalasia balloon perforations up to 4 or 5 centimetres, which we've closed successfully with a zipper technique. And using a band is very easy. You can just put a band on a clip, take the band across the other side of the perforation, oppose the sides as much as you can, and then you can finish zipping with the clips. Or use a ligature, you attach it to one clip, put in another clip, tighten it, and then you can zipper the rest quite easily. So you don't, if you practice these techniques, you don't really always need a suturing device.
Yeah. Actually, there are now 2 new clips, I think one Microtech and one Boston, both of which are particularly made to draw the edges together. So one is a dual opening clip, so you can grab one side and grab the other, and then the other has sort of a you know, more of a grabbing mechanism, so that you can really bring the sides together. So I think it will change. I think a lot more will be manageable with clips.
Yeah, fantastic. And you know, whenever I see you guys do your work, you always make it look so easy. And I think that part of that, I guess, is also experience, but also just staying calm, I think is one thing. You know, we've all had moments in endoscopy where something's gone wrong, and actually the biggest thing I think that I noticed when you guys all scope is actually just very calm, and you deal with the situation in front of you, and you can panic later when the patient's out of the room. But you know, I think that's always something that's very impressive whenever I see people like you scope. So I've really enjoyed that session. That was fantastic, and thank you very much for joining me, guys. It was really great, and that's it. That's the last educational moment of London Live. So it's been a great on to closure. I'm going to hand over to my great friend and colleague George Webbs, who's going to say the final goodbyes and thank yous. But before I do, I just want to say one thank you, which is to George Webbs himself, because he never gets the thanks for this, and he literally has done this now. He doesn't know how many years. I've heard this speech 12 times. He may do it again now, but he doesn't know how many years that we've run London Live, but he does it every year. The preparations start about 6 months in advance, and you know, he works tirelessly, and it's, I think, a great educational event. So thank you, George. Thank you to everyone on the sofa with me. And George, you can say the final goodbyes.
Thanks, Dave. And the fact that I can't remember how many years we've been doing it is either a very good or a very bad sign, not quite sure which. So, yeah, we've had a great couple of days. I've certainly hugely enjoyed it. And I've only enjoyed it because of a number of important factors. The faculty, you know, it's been a huge privilege to have such titans of the world of endoscopy, both from the UK and internationally. Great to have them with us. The innovations that we've seen over the last couple of days and improving patient care, none of those come about without the integration and the interaction with our industry partners. Not only have they been fantastic in supporting this meeting, but day in, day out, delivering technical and advances in endoscopic care. Huge thanks to them. Thanks to the delegates. We've just looked at the numbers, more than 2,500 delegates attending over the last 2 days, and delighted to see from 91 countries. And I think that is telling us something about the importance of endoscopy, actually, and the importance of endoscopy training. So really great. If you're a delegate, we are absolutely delighted that you've been able to join us. The group, Dave, thanks for thanking me, but the other group in the background that you don't see is the technical team from Hub, who have facilitated all the studio side of things. Thanks to them. Now, over the last 2 days, we have shown 54 endoscopy cases, and I think we've built really important learning and discussions around those 54 cases. If you haven't been able to catch every bit of the meeting, there's no problem. You can go back at any time onto the Gastro Learning site, and not only watch the meeting again if you've got two days to spare, and you can watch it all the way through, or you can choose the bits that you missed. You can also go onto the Knowledge Centre and augment your learning further with tricks and tips and procedure tutorials, which we hope will help. Every week we put out a Gastro Learning Express that with a few little tricks and tips, and then once a month a Gastro Learning Live, in which we have a detailed discussion just for 30 minutes with an expert on a particularly focused area of gastroenterology practice. So, look out for that. And finally, great to have everybody with us. Keep well, enjoy delivering high quality endoscopy, and thanks for being with us. All the best.
Good morning, everybody. Welcome back to ESG Days 2022.
Amazing to have a meeting dedicated to endoscopy. If you look at the array of data that's being presented from across the world, it's fantastic learning. And when you see role models and experts in their field, particularly on the live endoscopy stage, it's truly inspiring.
I believe that we are now the premier endoscopy congress in Europe. We're on the cutting edge of innovations and new technologies, which is very exciting. We have original research that is presented here. We get to the science of what's going on in the world of endoscopy.
For me, highlights of ESG Days are, first of all, the program is amazing, and of course hands-on, because you can learn and you can teach. So that's unbelievable, and you have amazing tools and people over there. We can get close to our experts, discuss with them, start collaboration, and it's so motivating for me as a younger endoscopist to have this inspiration from them.
We had the opportunity yesterday during the hands-on training to work together with nurses, experienced nurses, with other colleagues, and of course with our participants, and try to show them new techniques that we could integrate in their clinical day practice, and this was really amazing. ESG Days is a fantastic congress. They brought together doctors and endoscopists from all around the world, from the States, Australia, Asia, Europe, all around Europe. And I think that this is the goal for next year in Dublin, to go there and have even more participants from more countries, more continents if possible.